We are live.
So welcome to the second day of the 5th Global Neuro-Ophthalmology Case Festival. We have another set of very interesting and challenging cases of the efferent system in neuro-ophthalmology. Without further ado, let me start with the introduction of the panelists. So first of all, we have Dr. Krishna Vaidishwaran, who is a consultant ophthalmologist at Moolchand MedCity Hospital, Delhi, and also at Mamta Medical College in Siwan. He is the associate editor of medical statistics section of the Indian Journal of Orthopedics and Indian Journal of Neurosurgery in Delhi. He is an editor of the current Perspectives on Ophthalmology textbook from Elsevier from the 5th to the 10th edition. His research interests include optic nerve decompression, chemodenervation, perceptual learning, and neural vision therapy. Over to you, Krishna.
Thank you so much. So, can I? Right. So, it gives me great pleasure to introduce Dr. Satya Karna, who is a director of ophthalmology, and he's a prolific cataract and refractive surgeon, and of course, a neuro-ophthalmologist par excellence, a friend of over several decades. I mean, he's the backbone of this enterprise that we are having here today, and he's so very resourceful, and he can almost manage anything. So his present affiliation is Karna Eye Clinic, Noida, as well as Max Hospital, Noida, in the National Capital Region of Delhi. His areas of interest include teaching, basics of neuro-ophthalmology and neuroimaging. He's an author of the Shankar Netralaya Atlas of Neuro-Ophthalmology, 2 editions, and both of them have been very successful, and believe me, most of us do refer to it all the time. He was the Joint Secretary of the INOS 218 to 2023, and is a specialty reviewer to the Indian Journal of Ophthalmology. So, of course, he requires no introduction, and we all know Satya here. Anybody who's here knows Satya. And now I would give it back to him.
Thank you, Krishna. Let me now introduce the rest of the presenters and panelists. The next panelist would be Dr. Muralidhar. He is the head of Department of Pediatric Ophthalmology and Neuro-Ophthalmology at the Eye Foundation, Coimbatore in India. He had his training from AIMS, Delhi and Shankar Netralaya, Chennai, and he has many publications in national and international journals. He has conducted many instruction courses at national and regional conferences. Next, we will have Dr. Swati Alok, who is an additional professor at the Rajendra Prasad Center for Ophthalmic Sciences at All India Institute of Medical Sciences, Delhi, India. She is a specialist in strabismus and neuro-ophthalmology, and she has 80 peer-reviewed publications and 25 chapters in various books. Let me go on to the first presenter for the evening, Dr. Edsel Ng, who is a professor and chair of ophthalmology and visual sciences at the University of Alberta in Canada, and a professor of ophthalmology at the University of Toronto. He has had 3 clinical fellowships at Wills Eye, Mayo Clinic, and the Allegheny General Hospital. His PhD was in diagnostic prediction models done at the Kingston University, and his MPH in public health at Harvard, and his MEd, education in the health professions, at Johns Hopkins. Over to you, Dr. Edsel, for your case presentation.
Great. Thank you so much for the introduction and the opportunity to be here. So hopefully this screen share will work. Can everybody see the slides? We're good?
Yes.
Okay. Great. Excellent. Let's see if I can get rid of this bar here. What do you click this more thing, or is it just going to show up at the bottom line? Or
So it's not showing. You can continue with the presentation. It's not visible.
Yes.
Okay. Oh, good,
Yes.
good. So, greetings from Canada, and I'm trying to advance here. Okay, I guess I have to use the arrows down. So, greetings from Canada, and I thank Dr. Satya and Dr. Krishna for this opportunity to discuss a case of inadvertent eye injury due to an underlying neurologic disorder. I have no relevant financial disclosures. Um, Now, from Shakespeare, a rub is a vexing problem that makes a plan problematic. And I wonder if you've encountered a similar rub in your Hamlet. So this patient was referred to me by a cornea specialist. This 57-year-old left-handed gentleman had compulsive eye rubbing and also tics of his jaw since childhood. He had this incessant urge to rub his eyes with his knuckles. They tried putting him in goggles when he was a kid, but he kept on reaching underneath them. And unfortunately, about 12 months ago, he developed an alternaria fungal corneal ulcer that scarred over his cornea with an underlying iridocorneal adhesion. Oh, I'm not sure where that came from, but um, uh, on further history, there's no history of autism or profanity or word repetition. He was taking risperidone to try to decrease um, um, the eye rubbing, and he was using artificial tears. I don't know which cardiac surgery he had as a child. Perhaps it was to close a patent foramina valley. No history of viral encephalitis, no substance abuse, or Huntington's. On examination, he was 20/40 in his right eye and count fingers at 5 feet in his left eye, and his cornea had this appearance with opacity and the iridocorneal adhesion. No lag ophthalmos, no facial nerve palsy, no floppy eyelid syndrome. I'll try to run the video now. So this patient was in his car, and his wife took the video of him, and he just figures it out right there. And they continue to do the video, and you might see that he has to hold his arm down when he's driving. When we get further advanced in the video, to stop rubbing his eyes, he actually touches his teeth and keeps his hand on his teeth. And perhaps that's the source of his alternaria fungus, because it's alternaria is in the dental plaque and in the saliva. Okay. No history of atopic dermatitis. So I guess you guys get the picture about what he's doing. And at this point, I'll just briefly pause, and you can tell me what your diagnosis is. Yeah. So,
Edsel, isn't this a very common habit that many people have?
oh, I haven't seen it to the severity that this is the first time I've seen somebody with a corneal ulcer. I guess you hear of people with some patients with developmental delay or mentally handicapped that have self-abusive behavior, but it's not a common one for me. But I certainly would appreciate this international audience and the advice from it. Um, so the Yale um, motor tic symptom list, we find he's got eye blinking, mouth movements, shoulder shrugs, arm movements, hand movements. Um, if you'd follow the video, like he had some coughing, throat clearing, and sniffing, which are supposed to be your phonic tic equivalents. And most definitely with his corneal ulcer, it's classified as self-abusive behavior. Um, Also on the Yale score, they talk about the tick severity scale. And so I tried filling things out. He's about 25 out of a scale of 50. Um, and on the diagnostic and statistical manual, DSM-5, he meets all the criteria for Tourette syndrome. As you see here in red, it has to start before the age of 18. So perhaps this is what Satya is referring to as being very common. Um, in my practice, I don't see a lot of Tourette syndrome. Um, he probably also has obsessive compulsive disorder associated with it. Apparently, it's a very common accompaniment. One thing that I didn't realize was coprolalia. The swearing is not that common compared to other hyperkinetic motor disorders. Um, the tics characterized by Tourette's happen more, persistent sleep. Sorry. Uh, this band is in the way of all the slides. Characterized by distractibility, suppressibility, and especially this premonitory urge. And a premonitory urge is this unpleasant bodily sensation that builds up until the tic is performed, much like trying to hold back a sneeze or resisting an itch. And only 10% of patients with Tourette's have coprolalia. So at this point, we have a 57-year-old gentleman with Tourette's disorder and probably OCD eye rubbing. He's already on risperidone. He doesn't want to wear dress safety glasses or retry his goggles. I don't know how much keratoconus he has from his eye rubbing. He's about 20/40, but refuses to wear glasses. He wouldn't wear things like elbow splints. He didn't want to try recreational drugs. So I'll let you briefly think about how you'd manage him.
Mm, would it,
According to the, oh, sorry, yeah.
uh, yeah, but then what about the ocular surface? I mean, is there some element of dry eye or something which could precipitate this kind of a behavior? Because as Satya said, it's pretty common to see particularly in a place like Delhi where you have, a lot of dry eye. And so, you can have patients, particularly if they're driving or they're using a visual display unit, they constantly rub their eyes.
Right. Yeah. I haven't seen this frequency because like here like he's actually trying to suppress I think his touching there. Like at one point you'll see he actually holds his fingers to his teeth. I don't know if it's worth watching the video that long. But later on he just holds it. So I he just seems like he's moving a lot more than I'm used to. It is too much touching. Um,
Mhm.
and this is after he knows his wife's videoing him, so he's trying to control it. He has to hold one arm down like this when he's driving, and then at a certain now he's got his fingers on his teeth, and I think that's how he's adapted to not touching it as much, and it's probably also the source of his fungal ulcer, I think.
And
But I'm just so here he's holding it and he's able to suppress it. But that's after he realized his wife was filming him because he was touching it a lot more before. Just not used to the frequency. Um, so according to Tourette's Association of America, you can try different therapies, including habit reversal. There's other psychologic treatments like relaxation training. As an ophthalmologist, I don't often give these medications listed below, like clonidine, occasional topiramate, piprazole I don't write for. But there's a medication that I left off on the list that we do as ophthalmologists and neurologists give quite frequently. And that one, if you haven't already guessed, is Botox. Botox not to the arms, but they said try it on his eyelids and see if we'll eventually be able to do his corneal transplant. So why would Botox to the eyelids help? Uh, in Tourette's, it's thought that there's a dysfunctional cortical thalamic striate cortical sensory motor feedback loop, and if you put the botulinum toxin into the orbicularis muscle, it somehow modulates the lid corneal sensory feedback and reduces the intensity of the premonitory urge. And perhaps you can teach them some type of substitution movement to get them happier. Um, Something like habit reversal therapy. So I gave him my usual Botox, 3.3 units, 6 sites in his upper lid. in the pattern you see on your bottom left. After about a week, the wife felt there was 25% improvement, like less touching of the eyes. The patient didn't notice any subjective difference, though, but did say his eyes were quite watery. I think he just had reflex dry eye from the decreased blink. If you notice in the diagram here, I purposely don't like injecting the infromedial region here because Horner's tensor tarsi is there and you might get some more watering. Now, on the Cochrane reviews, when they looked at this topic, Botox for motor and phonic tics and Tourette's, unfortunately, there's not any high quality evidence saying that the severity of the tics and the premonitory urges are decreased. So should we be doing Botox or not? I figure as long as the patient thinks it might be helping, I could continue it. The good thing about the Botox, no systemic fat side effects like a lot of the systemic medications. And if this doesn't work, I was wondering maybe I should refer him for deep brain stimulation. But with this great international audience, I sure would appreciate any other tips you'd have for this patient who refers us to use things like elbow splints. Yeah. Yeah, thank
Well,
you.
was there any diurnal variation in the tics, please?
I didn't ask if it happens at night, but apparently the ticks are supposed to continue there. So at nighttime, you think he wore a shield right after he got his first corneal ulcer, but I think he stopped. He just doesn't like wearing glasses.
And
But it's pretty frequent during the day. When he first came into the office, like he would, maybe he could stop it for about 30 seconds, but then it just started again.
what about the vocal tics that were usually associated with the Tourette syndrome? I mean, did he have any vocal
Right.
associations? I mean, like any sounds he would
I
make?
didn't hear any of the vocal ones, but apparent those phonic equivalents, like the sniffing, the coughing, and I don't know if you saw him during the video, like you go, like those are apparently phonic tick equivalents.
Okay. So, would they also reduce with botulinum toxin? I mean, is because you do have a premonitory urge which brings about the phonic and the motor tonic, the tics. So, would the Botox actually reduce the vocal and the phonic equivalents to the tics too?
I don't know if it would reduce the other ones because he also had jaw ticks, and I don't know if you saw him like hold there's all these different
Mhm.
things he has to do, and to drive the car, I think he just holds one hand down. So at one point there's no hands on the steering wheel, but um, I think he's adapted to it. Still able to drive. I don't think it would decrease the other ones. And one of the problems is if you take away one tick, sometimes you get a worse tick replacing it. So
Okay. Uh, just a thought. I mean, because one of the important elements that I mean, like causes a tick to happen is the premonitory sensory stimulus. As also there is a hypersensitivity. Basically there is the entire sensory system is kind of charged up because and then he does have a corneal issue with a perforated corneal ulcer and a vascularized corneal opacity there. Uh, is it possible to, I mean, would it be, I mean, just thinking of, uh, it would, I mean, just a drop of proparacaine or a local anesthetic, did that reduce the tics? Because it would reduce the premonitory, symptom itself,
right. Yeah, yeah, yeah. I could certainly try it. It's just I guess if that ended up being the solution, maybe a scleral contact lens, because we couldn't give him like he'd get just like topical anesthetic because we
Mhm.
had to do an emergency corneal transplant. But maybe a scleral contact lens if that worked, if he could stand it.
Uh,
Hmm,
So, I mean,
maybe at least protect the eye while it was on. Yeah.
yeah, with that kind of botulinum toxin, the question was, what about the surface? What about the tearing part? What would it would
Mhm.
accentuate the dry eye part? Because it would
Right.
reduce the
Yeah. Yeah.
secretion particularly,
Right,
and
right.
perhaps.
Oh, I think what happened in him, he had more tearing because his eyes were drier because he didn't blink as frequently as before. So that's why I think he had more tearing. I guess it's possible that his blink response might have been affected with all the orbicularis stuff too. So was it overflow tearing? I'm not sure. When he said he used the artificial tears, I asked him to put in more, and then he said he felt better. So I presume it's not um, the blink dynamics problems.
So, did he have a component of, some psychiatric ailment also, like the obsessive compulsive,
Oh,
or something
the
which could be
OCD,
treated?
the touching part might be OCD, but in
Mhm.
terms of his personality, one of the most reasonable people I've met. I wouldn't think that it'd been so severe for him. Poor guy. Yeah, but very reasonable, very bright gentleman, very cooperative.
What about anxiety and stress levels? I mean, were they assessed? I mean, could that be one of the factors that led him to, you know, have
Right,
this problem?
right. So yeah, so he's not uh, we used to be a graphic designer, so he's not working right now. So I think that he would have less stress not working, but the tics still persist.
Um, Anything else, Satya? What would you think? I mean,
Yes, so I would like to take this opportunity to suggest a method which is natural and off medications, that is meditation.
Mhm.
And there is a particular method of meditation wherein you are, uh, you know, taught to learn how to identify your bodily sensations and then realize that they are there and then avoid reactions to the bodily sensations. I wonder if that would help him because
Oh
it
yeah.
is a very effective method for many such situations where there is a psychological component. Krishna, what do you think about that? I'm
oh
sure you would
yes.
also have had that kind of knowledge in the past.
Absolutely. In fact, we almost term meditation and the mindfulness as the third arm in most of our at least in our practice. We tell them that it is important to meditate and mindful and try and get particularly the movement disorders. And we've seen a couple of patients with very severe tics. Of course, I have not seen too many of Tourette syndrome giving rise, causing so much of to cause a corneal erosion. But yes, it so happened that we asked him to meditate, and he joined this the art of living, and he actually became a teacher there. And since then, he's not required any medicine. I mean, so that's one case report that we can straight away. I can straight away tell you that he had this tick which caused him to have a lot of problems. He came for botulinum toxin to me when I suggested meditation. Did give him a Botox, but then he went on to become an art of living teacher. And of course, he's doing fine. So that's one thing that yes.
We'll certainly discuss that with him. Yeah, thank you.
Uh, any of the panelists would like to add something, anything that they would like to, you know,
Yes,
bring
thank
to the
you.
fore? Mhm.
Hi, Krishna. Can you hear me?
Yes, please. Yes, please. Yes, please.
Yes, Etzel, I'm a neurologist and I treat general neurology mostly. And we tend to see patients coming in with Tourette's now and again. But mind you, I do adult neurology more than pediatric neurology. And that's where you'd see more of the Tourette syndrome. So I don't have a very vast experience with Tourette's. But what we tend to do is co-manage them with psychiatry. And if you look at all the drugs that you have, it's always a matter of trying one and then the other. And amazingly, haloperidol works in these patients. Even though it's one of the older antipsychotics, we find that a very small dose of haloperidol does the trick. You in Canada will most likely have access to tetrabenazine. Have you tried that in this patient as well?
Oh, haven't even heard of the medication before, so we'd have to ask him.
Oh,
I think the psychiatrist did put him on the risperidone, so you could
yeah.
certainly ask him about that
Yeah, no, I think haloperidol
tetrabenazine.
is a haloperidol, a low dosage. There's always the concern about extrapyramidal side effects from these drugs. They develop Parkinsonism, an akinetic rigid syndrome, and that's what you want to avoid. A very small doses with Satya and Krishna's suggestion of relaxation therapy and meditation, you could probably achieve something with this patient.
Just one more thought. One of the hallmarks of Tourette syndrome is the hypersensitivity. I mean, your sensory system is totally is on a full charge, and it's probably because of those interneurons which are GABAergic. So, would you think that some kind of gabapentin would also help? I mean, particularly in a person with these kind of fits?
I don't have any experience with gabapentin for Tourette's, so I can't comment on that. But we've used haloperidol quite effectively. We use risperidone, clonidine in some patients.
So
I haven't tried
pushing up the-
topiramate that much. Yeah.
Yeah. So it's actually pulling up the dopaminergic and serotonergic path. I was just wondering if you can just add on to the, the GABAergic, and so path, and then maybe you could actually reduce the incidence of the excitation. So what do you think the prognosis is, Itzel? Do you think, would you have to repeat the botulinum toxin for some time?
Oh, I think
you
if
plan
it
to?
works, it would be indefinite. If it's only decreased by 25%, though, I don't think the corneal graft will survive. So, in addition to your therapy, I don't know. Does anybody use deep brain stimulation? Because that might do
One thing
something. They
about
say deep brain stimulation.
So I'm sorry, I just wanted to add something about the botulinum toxin. We would typically repeat it after about 21 days, I mean, if
Oh,
if you fix it
21. Okay.
21 days, because there's a maximum exoplasmic pressure there at that point of time. So it would give a supraadditive effect, before the effect of the first Botox goes away. So, and then this 25% might go up to, say, a bit more acceptable value, and that might give him some long-term effect.
Oh, yeah, good point. I haven't tried it that frequent before, so good. Would giving a double dose be the same as giving it as frequent, or?
No. In fact, you can give half the dose and repeat it after 21 days. You get it, supraadditive effect.
Okay.
So it's usually it works best after about 21 days when you have the maximum exoplasmic pressure, and it works excellently. As you said, it works very well on the sensory and the gamma effronts. So therefore, you get very, very, very good relief, particularly in these tics when you can't possibly, pinpoint the cause. But of course, we need to be careful about the dry eye part, because that's something which could enhance the rubbing and, the surface disorder. The corneal surgeon may not be very happy with a very frequent botulinum toxin regimen.
Yeah, maybe I'll try it in the summer or something. It's just winter here, really dry.
So you were wondering about deep brain stimulation. Is there somebody with some experience with deep brain stimulation for Tourette syndrome or any one of those tics and movement disorders? Dr. Anand, would you have any experience with deep brain stimulation for these patients?
No, deep brain stimulation for idiopathic Parkinson's disease for patients with dyskinesias, peak dose dyskinesias from the use of levodopa. We've used deep brain stimulation for those sort of patients, but I haven't in the case of Tourette's. No, I don't have that experience. Certainly from a tremor point of view, from an idiopathic Parkinson's disease point of view, we've had good results.
Okay, so Krishna, shall we move on to the next case now?
Yes, please. I think that's good. It was a
Thank
lovely
you.
presentation, a very rare condition of Tourette syndrome, presenting with a corneal perforation, and I'm sure you've done the best for the person. Thank you so much, Itzel, and it was wonderful listening to you.
Well, thank you. Thank you for all the suggestions.
Thank you.
Thank you. Then let me introduce the next speaker in this session. That is Dr. Anand Murli, who is an honorary associate professor of the University of KwaZulu-Natal in South Africa. He's an affiliated associate professor at the University of the Free State in South Africa and the General Secretary of the College of Neurology, Colleges of Medicine of South Africa. He is a consultant neurologist at the Inkosi Albert Luthuli Hospital and a tertiary hospital in Natal, South Africa. His areas of interest are eye movement disorders. His focus of research lies in neuro-ophthalmology and teaching of general neurology and neuro-ophthalmology to undergraduate and postgraduate students. Over to you, Dr. Anand.
Thank you, Satya. I hope you can hear me.
Yes.
And can you see my slides?
Yes.
Okay. Thanks very much for inviting me once again. I presume that it must have went well the previous times I presented, which is why I received another invitation. Thank you very much. And I must admit, I really enjoyed the session yesterday, and hopefully today is going to be a wonderful session again. And thanks for having the session yesterday. I think if I was watching the South Africa versus India cricket match yesterday, I would have been traumatized. So instead, logging into this meeting prevented me from being traumatized yesterday, but watching the highlights today, I think I've lost all my nails. And we've lost the series against India, which is not good. Anyway, coming back to the talk, it's an eyes wide open. That's the title of my talk. And, it's always a challenge trying to find a suitable case for this meeting because you don't want something too simple and straightforward. Hopefully, this is not as challenging as Itzel's case. So this was a young lady that I'd seen in one of the general medicine wards. I was called for a consult. And I mean, what was most striking about her was the stare that she had. And I must add that I was given permission to use her images and videos from her and her family. So she had this very marked lid retraction bilaterally. And obviously, in a teaching ward round, the first thing you'd want to do is to discuss the differential diagnosis of a patient who presents with such lid retraction bilaterally and symmetrically. And a lot of things go through your mind. And of course, thyroid eye disease will stand out most prominently, as well as dorsal midbrain syndrome, sympathetic overactivity, the usual differentials we'll give for bilateral involvement. Dorsal midbrain syndrome, certainly looking very closely for all the signs of a perinorth syndrome, the pilinomas, the hydrocephalus and meningitis as etiology with dorsal midbrain syndrome. Parkinsonism can do it. Overactive sympathetic system, and some drugs like the acetylcholine receptor inhibitors can do that as well. But thyroid eye disease is something that's most prominent and what we see more commonly. But, we don't jump to conclusions by just looking at a patient like that. We teach them that, you got to take a full history, do a full clinical examination, and then have your differential diagnosis. So looking at the background of this young lady, she's 27 years old, known with HIV infection since 2009, from the age of 11. And we were told that it was actually acquired through vertical transmission. So this is via placental spread, placental transmission, and transplacental transmission. And so she's been HIV infected for the last 27 years. She's been on antiretroviral therapy since 2009 and claimed very good compliance. She has been on our first line treatment for HIV infection, which is TLD. That's the tenofovir, lamivudine, and dolutegravir. And then she was also on Bactrim, which is cotrimoxazole, and that's for prophylaxis against pneumocystis, pneumonia. And fortunately, there were no other comorbidities. But going into her history, she actually had no ocular symptoms. She didn't complain of anything involving her eyes. Her main complaint was that of a 3-month history of poor balance. She was clumsy, her speech had become slow. She had this head tremor. She complained of some mild weakness of the arm, the left arm and left lower limb. She was not ambulant for the previous 3 weeks prior to admission. No visual, hearing, or sphincter disturbances. And amazingly, she denied any cognitive impairment, claimed to have very good memory, and not have any problems with her cognition. So on examination, we were looking out for features of advanced HIV infection. And she certainly had melanonychia, which is the pigmentation of the nail you see in these patients, the hyperpigmentation, suggesting that she had significant immunosuppression. But there was no oral thrush, no lymphadenopathy, and the rest of her clinical examination was normal. And specifically looking for features of thyrotoxicosis, they were negative. She had no tachycardia, no fine tremor and sweating, and there was no constitutional symptoms either. So she was previously well until the previous 3 months, despite having such severe immunosuppression, which I will allude to in a little while. Most striking, of course, was this stare that she had bilaterally, and we've seen it in patients who are HIV infected, And over the years, advanced HIV infection presenting with lid retraction, we've seen it in patients with advanced disease. And the theory, which really hasn't been proven as such from imaging or any other investigations, is that this is most likely from a lipodystrophy involving the periorbital tissue. But there was something more to this patient. And when you examine her, you'd find that, in fact, she had limitation of up gaze. Here we're asking her to look upwards. I must apologize for the poor video. Must blame my registrar for this. But this is where we asked her to look upwards, and you see there's marked limitation of up gaze, and there's limitation of down gaze as well. That's where she's trying to look down, and she actually flexes her head, flexes her neck to try and move her eyes downwards, and then getting her to look horizontally. She has horizontal movements, but that was rather incomplete. And you can see she had this head tremor, which we call titubation. So she had this titubation as well. And on neurological examination, what was quite obvious was that she had this bilateral lid retraction and hypomimia, meaning that her facial expression was somewhat reduced. Her comprehension was normal. She was slow in responding, but amazingly, her memory, etc., was fairly good. And when the medical officer was presenting her to me, she was actually correcting her quite frequently with the history and making sure that the history was quite accurate. So she had this scanning speech, which you see with cerebellar dysfunction. And having had HIV infection for such a long time, we tried to do an IHDS scale, the International HIV Dementia Scale, but that was difficult because I'm showing you the items that one tests for the HIV Dementia Scale on the right side. The left side is the HIV Dementia Scale. The right one is the International HIV Dementia Scale. And here we look at recall of 4 items at 5 minutes. We look at finger tapping and the Luria test, which is the fist, palm, and side. And it's got to be done within 10 seconds. And you count the number of times the person is able to do that. And this is scored out of 12. But in view of incoordination, it became extremely difficult. So we couldn't get an accurate assessment of whether she had significant dementia or not. But as I said, I mean, she was very attentive, slow in her responses, but fairly accurate in her replies. And in terms of her eye examination, visual acuity was normal, fundoscopy was normal, visual fields by confrontation was intact. Her pupils were 4 millimeters in ambient light and normally reactive, so there's no afferent pupillary defect we could see. She had this bilateral lid retraction, which is fairly obvious, with a normal blink frequency. And on Hertels, the measurements were 20 millimeters bilaterally. She had limitation of horizontal eye movements, which you could see on the video, but total loss of vertical eye movements. And with vestibulo-ocular reflex, we could overcome some limitation. And the slit lamp examination was normal. Now, in neurology, we don't only examine the eyes. So for my ophthalmology colleagues, yes, there is more to the person. There's a brain, there's a trunk, there are limbs. So we examine those as well. She had mild left upper motor neuron facial weakness. She had the titubation, the head tremor, which you could see. And then she had features of an akinetic rigid syndrome, which you get in Parkinson's disease. And that she had neck rigidity, she had rigidity of the left upper limb, left lower limb, and she had a positive glabellar tap. These are the features you'd find in a patient with Parkinson's disease. She had mild left hemiparesis with brisk reflexes on the left side. A sensation was normal with intact proprioception, and you need to test that when a patient has incoordination to make sure it's not from joint position sense loss, but cerebellar dysfunction. She had symmetrical incoordination of both upper limbs. She had impaired finger to nose testing. She had impaired rapid alternating testing. She had impaired heel nition testing. So there are a number of features pointing to cerebellar dysfunction. There's no intention, sorry, there was an intention tremor, but no resting tremor. And mind you, from all of this, she was definitely not able to walk. With regard to her investigations at the time, once again, we were looking for thyroid eye disease, and the TFTs were normal, her thyroid antibodies were negative. Of note was that her CD4 count is 84 cells per microliter, means that she was severely immunosuppressed. But virologically, she was also suppressed. The viral load was lower than detectable. So she had immunological failure from her antiretroviral therapy rather than virological failure. And her ESR was 65. And these are the relevant investigations that I've listed here. We did CSF examination on her, but mind you, this was done after we had done a brain scan for her. So the CSF examination was done after the brain scan. It showed normal CSF pressure, protein of 0.33, glucose was slightly reduced, but she had no cells in the CSF. And looking for opportunistic infections, they were all negative. So in summary, we have had a 27-year-old young female with HIV infection with severe immunodeficiency with a 3-month history of progressive imbalance, speech disturbance, bilateral and symmetrical lid retraction, which you could see. She had a complete vertical gaze palsy with an incomplete horizontal gaze palsy, which could have been overcome slightly with a vestibulocular reflex. She was bradykinetic, hypomimic. She had neck and left-sided rigidity, all these Parkinsonism features with bilateral cerebellar dysfunction. And this is a clinical signs that get neurologists excited. So you can imagine I was quite excited at that point. I mean, she had Parkinsonism, she had a Gale's palsy, she had pyramidal signs, she had cerebral disease. This is progressive supranuclear palsy. But presenting with a 3-month history, very unusual. But PSP, has many subtypes, and the subtypes depend on which is the predominant neurological presentation. For instance, you can get PSPC, which is a cerebellar type of presentation in progressive supranuclear palsy. Classically, it's the Richardson syndrome, where these patients have the oculomotor involvement. And in those patients, you would find that they would have the supranuclear gaze palsy, which is the predominant presentation. But there are other features as well that can present, and depending on which is most prominent, they may have a frontal lobe type presentation, they may have a corticobasal syndrome type presentation, a speech and language problem, postural instability, gait freezing. So these depends on which one is the most prominent, would give you a subtype of the PSP. And that has really evolved over time. And PSP itself evolves over a period of time where it can start off fairly mildly and become quite severe as the disease progresses. And in fact, the eye movements can become totally plegic towards the latter part of the disease, where initially it'll be just the limitation of down gaze with intact vestibulocular reflex and pursuit and smooth pursuit. But as the disease progresses, that can become more severe. This is the MRI scan, and you would find that she had lesions. She definitely had lesions. She's got lesions. I hope you can see my pointer, can you?
Yes.
Okay.
Yes,
The medulla, you can see she's got this hyperintensity in the dorsolateral medulla. She also has a central hyperintensity. The cerebellum, bilaterally in the cerebellum, she has these hyperintense lesions on T2 weighted imaging, extending into the middle cerebellar peduncle. In the pons itself, there's some hyperintensity within the pons and posteriorly as well. Perhaps the facial colliculus going into the superior cerebellar peduncle. Within the midbrain, you can see these hyperintense lesions again, involving the tegmentum, involving the cerebral peduncle. And then there were some lesions extending, involving the internal capsule and the white matter, the centrum semiovale. You can see that as well. So she had quite extensive white matter hyperintensities. On T2 flare, you can see very similar distribution, shown a bit better because we suppressed the CSF signal, and the pontine lesions, the midbrain, and we needed to look at the midbrain because that's where we were localizing her problem. And with dorsal midbrain syndrome, it's this sort of area we're looking for a lesion, and you can see, I mean, it looks fairly okay, both in the T2 and the T2 flare. The dorsal midbrain looks fairly good. So we can say with confidence that there's no features of dorsal midbrain syndrome or Parinod syndrome. And in fact, clinically, she didn't have all the other features, the light near dissociation and the retraction convergent nystagmus as prominent features for Parinod syndrome. She had the lid retraction, though. And she had other white matter hyperintensities, as you can see, involving the white matter higher up as well. So these are all fairly nonspecific. And then post-contrast, this is the most important feature in the imaging. And that post-contrast, you see no enhancement. So these are the cerebellar lesions, and you see there's no enhancement in the cerebellum, in the middle cerebellar peduncle, in the midbrain itself. There's no enhancement of these lesions in the tegmentum, in the cerebral peduncle, as well as the lesions extending into the cerebral hemisphere on the right side. So as a neurologist, you've got an HIV-infected patient who's presenting with these multiple white matter hyperintense lesions involving the cerebellum, involving the brainstem. Without any enhancement, one has to think in this patient that she most likely has progressive multifocal leukoencephalopathy, which is due to the JC virus infection. And in fact, a CSF result comes back as PCR positive for JC virus. Now, for some of you who don't deal with JC virus, don't see it in an ophthalmology setting, it's the John Cunningham virus, and it's one of the very few things in medicine named after a patient rather than a doctor. Doctors have big egos, but here we have a patient's name attributed to a virus. It's a human polyoma virus. 50 to 80% of the general population are infected with the virus, but we don't present with disease because we have an intact immune system. So it lies latent in the kidneys, in the lymphoid tissue, and the bone marrow. And when you are immunosuppressed, that's when it presents with progressive multifocal leukoencephalopathy. So we see it in the setting of HIV infection, but also with natalizumab used for multiple sclerosis, in which case you stop the drug and sometimes use plasma exchange to remove the drug from circulation in order for the patient's immunity to be restored. So what does JC virus do? It infects the oligodendrocytes and it destroys myelin. It causes weakness, cognitive deficits. So depending on where it lies, it'll present with different features. But the common sites for PML are bilateral parietal occipital lesions. So they can present with cortical blindness. They can present with Balin syndrome, okay? And of course, the brainstem and cerebellum are other sites, and so they can present with lots of brainstem and cerebellar type of disorders. And it's fatal if not detected early and if the immunity is not restored. There are no specific antiviral drugs for JC virus. So it's a matter of restoring the immune system in these patients. And in her case, she had been on antiretroviral therapy already. She had been on first-line agent. So the plan was to change it into the second-line agent where other drugs would be added on. And noting that when we do that and the CD4 count starts to go up, that these patients can have immune reconstitution problems. And the non-mass lesions will now be space occupying, and there'll be more enhancement from the immune response. So you want to prevent that from happening, in which case you would add steroids to her treatment. And that's what we did. So she went on to the second line agent and we added steroids to her treatment as well. She was given prednisone. Now with regard to supranuclear palsy, there are very good reviews and many in the literature, but this is a good one that looks at the PSP-like syndromes. Now in that case, we can't really call it progressive supranuclear palsy because she's got an underlying HIV infection. And this is not just primary neurodegeneration, and there are many reasons why she would not have PSP as a primary neurodegenerative disorder, but would have a PSP mimic syndrome. And this review discusses the primary neurodegenerative PSP, as well as PSP mimic syndromes, where it can be paraneoplastic, it can be autoimmune, it can be vascular, where the progressions, as you can see, are far more rapid than the insidious type that you see on the neurodegenerative PSP. But infections are also causes of PSP mimics. And the progression, once again, can be fairly rapid. And in this review, they looked at previous reports of PSP mimics where it was due to Whipple's disease and syphilis. So infections, and in our case, we think it most likely is the HIV infection and perhaps contribution by the JC virus infection as well, where she's presenting with a PSP mimic. And why would this happen in HIV? Well, there are lots of reasons. It's possible that the HIV-associated neurocognitive disorder, or HAND, the dementia that happens in HIV, affects the subcortical matter and the basal ganglia, and basal ganglia involvement can give you Parkinsonism. PML from subcortical involvement, once again, can give you ataxia, bradykinesia, postural instability, and of course, other opportunistic infections like CNS toxoplasmosis, as well as primary CNS lymphoma, which does not apply to her, but we think in her case, it might be a combination of the HIV infection and the JC virus infection. Well, there are various clues that we have that will make you realize that you're dealing with more a mimic of PSP rather than true PSP. And the clues would be that it's a younger age patient. which in her case, she's 27, and PSP, the neurodegenerative disorder, happens in over 60 years of age. She had a fairly rapid progression. She's got immunosuppression. Imaging shows focal lesions, inflammatory lesions, asymmetric lesions, and that's not typical of PSP. And it improves with antiretroviral therapy, as opposed to PSP, which never improves, or treatment of the infection. But in her case, you would see that this wasn't the case. Now, in terms of PSP itself, there are various other signs we look for on imaging, apart from just atrophy of the midbrain. There are a number of signs, and our radiologists have very vivid imagination. The hummingbird sign is one of them. This is from the literature at the bottom. The patient's MRI is on the top left and top right. And what you're looking for is atrophy of the tegmentum and the somewhat flattening of the head of the hummingbird. I don't think this patient has it. And then, of course, we look at the midbrain, and you want to see large cerebral peduncles, as in the Mickey Mouse sign, with somewhat atrophic tegmentum and a decreased AP diameter of the tegmentum. No, not really as well. And then you look for the morning glory sign. The morning glory appears everywhere, even in ophthalmology. So in radiology, they're looking for the morning glory sign of the midbrain, which I'm not convinced that this is the case. Having said that, there is a case report of a patient who has reversible progressive supranuclear palsy-like phenotype as an initial manifestation of HIV infection. And this was reversible, so it was a PSP mimic. And it was reversible with antiretroviral therapy. In our patient, unfortunately, this wasn't the case. And this is her 2 months later, while she's on the second-line antiretroviral therapy and on steroids. And you'd find that now she's got almost complete ophthalmoplegia. So we are asking her to look from side to side and then look up and down. And you'd find that there's marked limitation of eye movements. That's her trying to look to the left side. And then we try to get her to look to the right side. But you would agree that she has square waves. And then we try to get her to look upwards and downwards, and basically there is no movement at all, right? Let's see the next one. This is where I think we're trying to get her to look upwards and look downwards, and there's complete loss of both vertical gaze and horizontal gaze. And then when we try to get her to, we try to do a vestibulocular reflex on her. Once again, there's limitation of the VOR. And that's basically significantly lost. So in essence, we think that this is most likely a PSP mimic, in that she's presenting with the supranuclear gaze palsy, she's presenting with Parkinsonism, and this is most likely as a result of a combination of a HIV infection and progressive multifocal leukoencephalopathy from a JC virus infection. I thought it might be a suitable case to present at this forum to get your opinion. These are my references. Thank you.
Murli, would you like to discuss?
Yeah, Dr. Anand, it was a very interesting case and an extensive discussion of the progressive supranuclear palsy subtypes. Interestingly, I had also seen a patient with progressive multifocal leukoencephalopathy who presented as cortical blindness, and the patient had bilateral optic atrophy. So on MRI, we had similar lesions, asymmetric and not enhancing with contrast. Was a known HIV positive acquired through blood, and the CSF was positive for JC virus. So typically, I would say it's a rare condition. But do you, I mean, how many of these patients with JC virus infection would you have seen? I thought it was a pretty rare condition, but
no, in HIV infection, we see them actually. We tend to see them with when there's a significant immunosuppression, usually less than 200 cells per microliter of the CD4 count. So that's where we get to see PML. But it's not that uncommon in HIV-infected patients. But we must remember that we are a referral center as well, so we get to see these patients who are presenting with these syndromes.
And
If
largely,
one
I
looks at
think
the entire, sorry,
these would
if one
present
looks
to
at
a
the,
neurologist rather than to an ophthalmologist or a neuro-ophthalmologist.
it was actually, this patient was in internal medicine, and we were consulted from neurology to have a look at her. She was in internal medicine. So I think she was managed by internal medicine as a result of her inability to walk, and then she had some of these Parkinsonism features and cerebellar dysfunction as well. So she wasn't primarily referred to ophthalmology or to neurology. She was seen in internal medicine and then subsequently referred to us.
And is there a difference in presentation between patients with HIV and those on immunosuppression, not just with natalizumab, but also with other drugs like mycophenolate and stuff?
Yeah, no, I would think the presentation should be similar, because I mean the sites of involvement are very similar. You know, it's that parietal occipital lobe involvement. Yesterday, Dr. Umapati was talking about Baylan syndrome. We've seen Baylan syndrome in the setting of PML because of the specific bilateral involvement of the parietal occipital region. And it depends very much on where the lesion lies within the central nervous system, and that's how these patients present. So I would think that, well, certainly from the natalizumab ones, we don't see too many of those because we don't have natalizumab readily available in the public sector, but certainly in the private sector, it is available. But once again, the incidence is very rare. It's like 1 in 1,000 cases of people who are natalizumab would get PML. We use a lot of mycophenolate. We use a lot of azathioprine. We use cyclophosphamide, etc. But PML is not common in those patients. You know, unfortunately, they're not that common. But in HIV infection, certainly as an opportunistic infection, we tend to see it. HIV is a major problem in India as well, as much as we see it in South Africa.
Yes, that's right.
And PML, apart from cortical blindness, do you get any other referrals to?
I mean, that was the only patient I had seen. The other panelists could add.
Okay.
Just one question with the clinical signs, actually. The VOR was limited. So
Yeah.
does it, I mean, in supranuclear also, it appeared as if the Bell's was also limited, and maybe there was a little bit of a legophthalmos too. So there must be a component of the infranuclear part too, you know, I mean, like probably because of the medullary lesion there. It's not just limited to the supranuclear.
Yeah. Well, you know, initially, she progressed quite rapidly. I mean, in 3 months from initially having some horizontal eye movements, we had not seen her prior to that. We know that with vestibulocular reflex, it can be lost late in a PSP type of presentation, the typical PSP. Patients initially will present with just the down gaze problem, then the up gaze and the down gaze, and then it's the horizontal gaze, and then it's pursuit that goes, and lastly, it's the vestibulocular reflex that goes. In terms of, you think there might have been some lag of thalamus, she was able to blink quite well, and when you get her to close her eyes, the eyes were closing quite nicely without any lag of thalamus. But she did have subtle upper motor neuron facial on one side, and I think that might be from the corticospinal tract involvement, which we saw on the right side. You know, it extended from the brainstem all the way up into the white matter, and I suspect that caused the left hemiparesis and the subtle facial weakness that she had.
Okay.
It's an unusual presentation in that, you know, it's a patient who's presenting with what looks like a PSP mimic in a very young patient, and one looks for secondary causes. So I thought that might be appropriate. I mean, obviously, the discussion regarding what is causing her problem is a difficult one, because we wouldn't know whether it's the JC virus that's doing it or the HIV infection, you know. But mind you, she's had HIV infection for 27 years. So by now, we would expect significant atrophy. She had some atrophy, certainly. And loss of nerve cells as well. Fortunately, she's been on ARVs, but you could see that her CD4 count was still quite low. That is worrying.
That the titubation we saw in the first video, would it be part of some form of horizontal apraxia that was happening, and because she was not able to initiate the saccadic movement?
Yeah, and I see what you mean. You know, where she's moving her head to try and move her eyes. Using the vestibulocular reflex to try and move her eyes. It's a consideration. In her case, I attributed that to a cerebellar presentation. You know, that she was most likely having titubation from a cerebellar dysfunction. Another problem we have, and I'm sure most of you do as well, is when we're testing for the VOR in patients with Parkinsonism, and especially in patients with PSP, is that the neck rigidity really prevents you from doing a proper VOR, and especially doing the vertical and doing the horizontal becomes extremely difficult actually when the patient is very rigid. Hers wasn't too bad. You could see from the second video it wasn't too bad. Rigidity was actually a lot worse when I saw her initially, but it is a problem. It is difficult to try and demonstrate it.
I was just thinking that actually, because it did seem a little rigid. I thought maybe if you could use the caloric test, I mean, like the mini caloric test or something, that would have probably.
Yeah, no, certainly. That's a consideration. We will certainly do that the next time.
Well, thank you very much, Anand, Murli, and Krishna. We'll move on to the next case now. Let me introduce to you the next speaker. And that is Dr. Mariana de Virgilis from the University of Barcelona and University Austral. And she is the head of Neuro-Ophthalmology section in the Hospital Universitario Austral. She is the head of teaching and research at the Hospital Oftalmológico Pedro Legles since 2022. She's a coordinator and lecturer in multiple national and international courses in ophthalmology and neuro-ophthalmology. She's a principal investigator in the neuro-ophthalmology studies with publication in indexed journals. And she's also a reviewer for Neuro-Ophthalmology and Journal of Neuro-Ophthalmology. Over to you, Marianne.
Thank you, Satya. Okay. I share my screenshot. Good morning, everyone. It's truly an honor to be part of this international and prestigious event. I'd like to begin by thanking Satya for this kind invitation and for coordinating this outstanding scientific meeting. Thank you. I'd like to start by presenting a clinical case. In April 2024, a 44-year-old man presented with binocular diplopia that had been present for about a month. The patient reported progressive worsening of double vision over the previous weeks without any other symptom. So, looking at his background, he had a stage 4 BRAF mutated melanoma with liver metastases. Earlier that year, he underwent neurosurgery for a cerebellar lesion, which confirmed melanoma, and later need reintervention of bleeding. In March 2024, he started treatment with ipilimumab and nivolumab. On ophthalmological examination, his vision was 20/20 in the right eye and 20/25 in the left. Extraocular movement showed limitation of abduction in the right eye. On fundus examination, we observed bilateral papilledema. Here you can see the patient during the motility exam. Pay attention to the restricted right eye abduction. This explains his horizontal diplopia, especially when he looks to the right. The OCT shows increased fiber layer thickness in all quadrants, compatible with optic disc swelling. In summary, the patient's papilledema and sixth nerve palsy indicated raised intracranial pressure. So we consider three main possibilities: non-communicating hydrocephalus, communicating hydrocephalus due to meningeal infiltration or metastasis, or increased intracranial pressure without hydrocephalus due to tumor edema or venous compression. But the MRI shows both surgical changes, the indirect signs of raised intracranial pressure, such as ciliar arachnoidocele, but no abnormal enhancement, posterior scleral flattening, optic disc protrusion, and distension of the optic nerve sheaths. Given the combination of diplopia and papilledema in an oncologic patient, we consider three main possibilities: leptomeningeal carcinomatosis, paraneoplasia, or adverse event secondary to the monoclonal antibody. To differentiate them, we perform a lumbar puncture with opening pressure measurement and full CSF analysis. The lumbar puncture was normal with an opening pressure of 10 centimeters of water, CSF protein normal. No cytological or microbiological abnormalities were found. We excluded leptomeningeal spread and started acetazolamide 250 every 6 hours. Follow-up OCT show normalization of fiber layer thickness in both eyes. So at this point, the patient completed a total of 4 cycles of ipilimumab and nivolumab. During follow-up visits, the patient reported that after receiving each cycle, diplopia worsened. The patient continues only with nivolumab cycles and is free of diplopia till now. The patient developed rosacea and autoimmune diabetes consistent with immune-related toxicity. Follow-up MRIs show no significant changes from the previous study. No new lesions or enhancement, but clinically, the patient improved with complete resolution of diplopia and papilledema. Ipilimumab and nivolumab are immune checkpoint inhibitors. Ipilimumab blocks CTLA-4 protein, while nivolumab blocks PD-1 protein on T cells. They enhance the immune response against cancer, but may also cause immune-mediated side effects. These published cases show that neuro-ophthalmic complications from immune checkpoint inhibitors are not isolated events. Diplopia, optic neuropathy, and other immune-mediated findings have been described after ipilimumab and nivolumab, reinforcing the importance of clinical vigilance in oncologic patients. This review by Micheli compiled 109 cases of immune checkpoint inhibitors-related neuro-ophthalmic events. The most common were myasthenia gravis, optic neuritis, thyroid eye disease, but isolated ocular motor palsies have also been described. Although pembrolizumab was the main drug implicated, similar adverse events are described with nivolumab and ipilimumab. So, even though these events are rare, they can involve multiple levels of the visual system and require prompt recognition. According to this 2024 meta-analysis, CTLA-4 inhibitors have the highest rate of immune-related adverse events among checkpoint inhibitors. Combination therapy, like ipilimumab plus nivolumab, increased that risk even further, which fits our patient timeline as support an immune-related mechanism behind his symptoms. The most likely mechanism is the effect of the posterior fossa surgery, which alters CSF and venous dynamic. This alone can explain the raised ICP signs and sixth nerve palsy. A postoperative venous sinus disturbance is also possible and would fit the picture well. Now, as a possible secondary modulator, we consider immune therapy. I don't think the immune therapy explains the whole picture, but the timing is hard to ignore. Each ipilimumab cycle made a diplopia worse, and stopping it made the symptoms disappear. So I see this as a secondary immune-related fluctuation over a primarily post-surgical mechanism. To conclude, although the primary mechanism is posterior fossa surgery, in patients undergoing treatment with monoclonal antibodies, always consider the medication as a possible cause of the clinical presentation. Second, in any patient diagnosis with neoplasia, it is important to consider the possibility of an associated paraneoplastic syndrome, infiltration, or metastasis. And finally, interdisciplinary management is essential. Collaboration between ophthalmology, oncology, neurology is key to achieving the accurate diagnosis and the best outcome for our patients. As we like to say, we only see what we know. Thank you very much for your attention. This case reminds us that medicine is always teamwork. And let me stop to share.
Yeah, thank you, Mariana. That indeed is a very interesting case and probably confusing also, because it all started with, surgical intervention. Then is it infiltration or some kind of meningeal infiltration or a tumor relapse or something? So after even your LP did not show very high pressures for that matter. So, would you, by any chance, consider the infiltration of the nerve itself by tumor cells to give that papilledema as a presentation?
That's a great.
Pictures, yeah, were pretty clear, showing sheet dilatation and other signs of raised ICT there. But CSF pressure surprising was very low.
Yes, thank you. That's a great question. In this case, we think direct tumor infiltration is very unlikely. The MRI did not show any enhancement of the optic nerves or meninges, and the CSF cytology was completely normal. Also, the pattern of papilledema and sixth nerve pulse is better explained by altered CSF and venous dynamic after the posterior fossa surgery, we think, rather than a focal infiltrative process.
Yeah, that's really true. And other thing I was thinking, how many times is it possible to have leptomeningeal infiltration and CSF cytology? Is it always positive, or can you have instances where you may have negative CSF yield?
Yes, could be absolutely. CSF cytology is not always positive. In fact, the sensitivity of a single tap can be quite low. And sometimes multiple samples are needed to detect leptomeningeal disease. But in this patient, the MRI showed no leptomeningeal enhancement. The clinical course improved this clue, and there were no new red flags. So although false negative cytology is possible, the overall picture here does not support leptomeningeal infiltration.
Okay, thank you, thank you. And my other thing was that, it was every time we would give ipilimumab, it would worsen, or diplopia was present. So there's kind of an acute rise or acute rise in ICT or something like that, because generally these presentations take a gradual time to develop. So every time it was like episodic rise of ICT with the immune checkpoint inhibitor therapy. So I don't know, would you consider kind of, because these checkpoints inhibitor are also known to cause aseptic meningitis and encephalitis. So is that also into the picture?
Yes, exactly. The episodic pattern was very stringent. The underlying disturbance of CSF venous dynamic from the posterior fossa surgery was likely the baseline problem, and the ipilimumab acts as a trigger, producing transient inflammatory changes that worsen the diplopia each time it was given. So the ipilimumab didn't create a new disease, I think, but probably amplify the vulnerable post-operative system given those acute short-lived rises of intracranial pressure.
Because normally it should take around 6 to 12 weeks for these side effects to appear with ICIs, isn't it? As far as I'm aware. So
Yes.
this was too acute, too early a presentation for side effect
Yes.
to appear.
Just a little.
Yes, it's true. And in our patient, in our patient, you're right. But most immune related adverse events develop gradually over weeks. We think the patient had the vulnerability in CSF, venous and venous dynamics, and the ipilimumab simply triggered the transient inflammation on top of that. So I don't think he caused, but yes, this compensate more abruptly. And 6 to 12 weeks of starting therapy is when you see an our patient and diplopia develop after 4 weeks, which fits the early immune activation window.
Okay, yeah.
Just
Yeah,
one
Dr.
little
Krishna
question.
want to say something.
Yeah,
Yes,
yeah.
yes, please go ahead.
I just wondered if there was a little hyperintensity in the area of the pituitary gland in the MRI there. So I was just thinking, could it be a case of hypophysitis induced by the ipilimumab, which, every time we brought it on again, it induced a hypophysitis, a local inflammation in that area, and maybe also, the inflammation spread out and, gave rise to a sixth nerve and maybe a localized optic hydrocephalus. But I don't know. I thought there was this hyperintensity around the pituitary gland. I'm not sure. I mean, I just saw it very. Was it there?
Let me see. Okay. It's an interesting thought. Immune-related hypophysitis is well described with ipilimumab, but in this case, MRI did not show the enlargement or enhancement of the pituitary or stalk. The hyperintensity you notice was consistent with an empty cella for a chronically raised ICP rather than inflammation. Also, the pattern of papilledema and sixth nerve palsy was diffuse, not focal. So while hypophysitis is a good differential, the imaging and clinical evolution fit much better with postoperative CSF venous disturbance, which with ipilimumab acting alone as a transient amplifier.
Okay, thank you.
Yeah. Dr. Satya, I think, has a question. How about MRV? Would you consider doing it? Did you think about it? What would you expect to see?
MRV was completely normal, but sometimes you have a really little abnormalities that you can see in the MRV, and we consider it. And if we had seen progression of red flags, and MRV or repeat MRI focus in the pituitary and the venous sinus would have been our next step. But till now, one year and he's perfect.
Okay, are these ICIs can also cause some kind of hemostasis or something which can lead to raised eyes? It is just a thought. I've gone through that review articles. I didn't find it, but just a thought. Is it a possibility?
I don't know if I understand the exact question, but I think that at the moment there's no clear evidence in the literature that the immune checkpoint inhibitors create an hemostatic disturbance significant enough to raise intracranial pressure in their own. Coagulation changes with immune checkpoint inhibitors have been reported, but they are uncommon and usually not linked to episodes of increased ICP. In our patient, imaging didn't show venous thrombosis or hemorrhage, so while it's an interesting hypothesis, the findings fit much better with the postoperative and CSF and venous imbalance that was transient exacerbated by ipilimumab. But I
maybe. Right. Any other panelist, if you would like to have Dr. Luciano, I think, has said that you need to collect at least 20 ml of CSF to detect for neoplastic cells. So I think that's an important takeaway there, that if you get a negative CSF yield there for metastatic cells, it's important that we get at least a good amount of CSF there to look for those cells. Any other panelists, if you have anything else to say or comment upon the case?
How many LPs were done?
Just one, because then he improved.
Right. I think, thank you. That was indeed an interesting case. I think we'll keep that in
Bye,
mind as one of the important side effect of ICIs. Thank you, Mariana.
Thank you.
Thank you, Mariana and Swati, and we'll move on to the next session of today. I'd like to introduce the moderator for the next session. Dr. Naveen Jaikumar is the co-founder and honorary director at Darshan Eye Care, Chennai. He is a member of the editorial board of the Journal of Neuro-Ophthalmology, and he is the president of the Indian Neuro-Ophthalmology Society. Previously, he was at Shankar Nethralaya as consultant and director of the Department of Neuro-Ophthalmology and my mentor. He has also been associated with the Chinese University of Hong Kong as a visiting scholar in the Department of Ophthalmology and Visual Sciences. He has also received the APAO Academic Achievers Award in 2016. Over to you, Dr. Naveen.
Yeah, thank you, Satya. I guess I'm audible?
Yes.
Yeah, great. So, good morning or good evening, everyone, wherever you may be on this planet. I'm Dr. Naveen, and I'm going to first start by introducing the speakers for this session. Is my slide visible?
Yes.
Yeah, great. So we'll be starting with Dr. Heidi Martinez, who's the founder of the Neuro-Ophthalmology Section Hospital at the University of Buenos Aires in Argentina. She's a full member of the Argentine Society of Ophthalmology and the Argentine Council of Ophthalmology. She's a professor superior of the course of Neuro-Ophthalmology at the SAO and CAO above. She's done a lot of training for fellows in neuro-ophthalmology, author of several articles, works, and posters of national and international congresses, and also an author and coordinator of the book for distance master's degree in the Argentine Council of Ophthalmology in its last 3 editions. So first, welcome to Dr. Heidi Martinez. Thank you for being with us this evening here, at least in Chennai. My apologies for the name here. Our next is Dr. Michael Dattilo, who is a professor of ophthalmology, section of Neuro-Ophthalmology, Emory Center. His research interests include interaction between intraocular pressures and ICP in papilledema and glaucoma, ischemic optic neuropathy, stroke rehabilitation, and retinal artery occlusion. Welcome, Dr. Michael from Emory. Mahesh is from Dr. Mahesh Kumar from Arvind Eye Hospital. He's the head of the Department of Neuro-Ophthalmology. He did his post-graduation at Arvind Eye Hospital itself, trained under the Professor Dr. G. Nachiyar, who's one of the first ladies of neuro-ophthalmology in India. He edited a neuro-ophthalmology textbook for postgraduates. He's the co-author of the Atlas of Imaging in Neuro-Ophthalmology and has several publications in national and international journals under his belt. Welcome, Mahesh. And last but not the least, Dr. Virender Sachdev, who is a consultant and the head of pediatric ophthalmology, strabismus, and neuro-ophthalmology at L.V. Prasad Eye Institute. He did his fellowship in neuro-ophthalmology at Emory, and his interests include optic neuritis, IIH, neuroimaging, myasthenia, and supranuclear disorders. He has an impressive 92 peer-reviewed publications and 16 book chapters, and is a reviewer for several journals such as the AJO, BJO, Ophthalmology, IJO, JCRS, etc., and on the editorial board of the BMJ Open Ophthalmology, Current Eye Research, and IJO. So welcome to you, Virender. And with that, let me go on to our panelists. We have Dr. Janil Sheth, who's done his DNB. He's the faculty lead in pediatric ophthalmology, strabismus, and neuro-ophthalmology at the Shantilal Singhvi Eye Institute. He did his post-graduation and fellowship in pediatric and neuro-ophthalmology at L.V. Prasad. His interests include complex strabismus, primary optic nerve diseases, and neuroradiology. He's also co-authored book chapters and has 2 public index publications in journals as well. So welcome, Dr. Janil. Dr. Preeti is an associate professor of ophthalmology at the University of Pittsburgh School of Medicine. She's a pediatric ophthalmologist and a pediatric neuro-ophthalmologist at the UPMC Vision Institute and the UPMC Children's Hospital at Pittsburgh. Her interests include cortical visual impairment, nystagmus, pediatric IIH, complex pediatric and adult strabismus. And as far as teaching is concerned, she's the associate director of the ophthalmology residency program there. Welcome, Dr. Preeti. And finally, we have Dr. Paramita Datta, who is a professor at the Guru Nanak Eye Center at Maulana Azad Medical College in Delhi. She did her MD ophthalmology from AIMS and a senior residency in Squint, Neuro-Ophthalmology and Glaucoma. She's the head of Neuro-Ophthalmology Service at the Guru Nanak Eye Center, and her interests include pediatric neuro-ophthalmology, pupil disorders, and toxic neuropathies as well. So welcome once again to our panelists and speakers. And I think we will be starting with Dr. Hedi, who has titled her presentation, Life is Full of Surprises. So let's see what surprise Hedi has in store for us.
I'm going to share my presentation. You can't see me because my camera is on and off.
Yes,
but I'm here. Okay. Well, thanks again for inviting me to this wonderful meeting. And I want to share with you 3 cases that really surprised me. And that's the title of my presentation. The first patient, a female patient, 64 years old. Like any other in a general consultation of ophthalmology, she complains of not being comfortable with the multifocal lenses, that she is getting seen blurry, that light bother her. All the examination was normal, visual acuity 20/20, ocular examination, motility, OCT, visual field, all normal. But she had dry eyes, so lubricants were prescribed, hoping that this will get her more comfortable. But she returned 1 year later, saying that my vision is getting blurry and not comfortable, and all was already normal. And as in general ophthalmology says, cataract may be the guilty of this uncomfortable vision. So phacoemulsification was performed in both eyes, no complication, and the visual acuity post-surgery was 20/20, but she continued complaining, I am not perfect, especially in my left eye. Again, all was normal, fundus, OCT, visual field. She had no other symptoms, no cephalia, but she argued that due to family issues, she was very nervous, she was very stressed, and she thought that all must be nervous. You can see here the visual field completely perfect, and I told her, well, that nervous theory must be proved. We must discharge any other pathology. We cannot kill the nervous. So I ordered an MRI. But she was very in a hurry. She wanted to travel to visit her old father. And 2 days after, she returned with a tomography without report. And that's what I was seeing. And I couldn't believe what I was seeing. You can see bilateral giant calcified aneurysm. And then we make an angio-CT, and you can see that there were really 3 aneurysms, 1 big in the right side and 2 in the left side. You can see better here. So I told her, you can travel. Tomorrow we are going to see the neurosurgeon, and the neurosurgeon made the surgery a week after in the right side, 1 month later in the left side. But I must say that she continues seeing not well as she wanted, but now she is not complaining. She's happy because we have find the pathology that causes this and what's life-threatening for her. These are other 2 cases. The first is a female patient, 64-year-old, complaining of intermittent episodes of diplopia lasting 1 to 2 minutes. But she has had diplopia in 2020 that was related to COVID-19, that had an postnasal improvement with sequelae of diplopia and a strained right gaze. She has a medical history of colon cancer treated with surgery without chemotherapy, 3 episodes of vertigo related with otitis, and the examination was completely normal, but mild abduction limitation and mild ptosis in the right eye. Now I must clarify something about these two patients. Both were remote consultation from their ophthalmologists that were seen then in the inner of the country, make a phone consultation and send me the studies by mail. So I couldn't make my myself the examination of the motility. But when I asked them, they referred that the diplopia worsened with fatigue and along the day. The second patient, female, 54-year-old, diplopia, a week after starting with methotrexate for aggressive arthritis, that improved 2 weeks after discontinuing the medication. So the medication seemed to be the guilty of the diplopia, but she had mild residual ptosis in the left eye. She also has a history of hyperthyroidism, treated with 2 doses of iodine, but she has been euthyroid on unstable dosage for many years. All was normal. Ocular motility was referred to be normal, fatigue positive, but when I could see her, I found diplopia on left gaze and nystagmus in both horizontal strain gaze, and of course, the ptosis. So with these two presentations, my first thought was, well, seems like myasthenia. So I told the ophthalmologist to ask for the antibodies and also to make an MRI with angio-MRI. And that's what we found. First patient, a right non-pedunculated big aneurysm on the right side, but if you look carefully, you can see in the left side, this is another aneurysm, then confirmed by angiography. So again, bilateral, giant, cavernous carotid aneurysm. Second patient, a left aneurysm that displaces the informed set, the left third cranial nerve, maybe compression or inflammation, but really we don't have a third palsy in the clinical picture. The aneurysm in this region tends to be giant and frequently bilateral. The main presentation is the headache, but this patient didn't have headache or ocular pain, nothing like that. The diplopia, when it's present, is like an oculomotor palsy progressive. And this patient have intermittent diplopia, no real palsy. When the aneurysm is anterior, it used to compress the third nerve. When posterior, the sixth nerve, and also it can compromise the fifth nerve and produce Horner syndrome and facial numbness. This patient didn't have nothing of that. When the visual field is compromised, the typical description is binasal amniopsia, but again, this patient have completely normal visual field at all. So, as an axiom, we say that clinical manifestation, the clinic rules, but sometimes it seems that clinic trip us up, maybe for seeing if we are paying enough attention. And our secret weapon, neuroimaging, must be ordered when the clinical picture is not clear, or when we are wondering not to have a bad surprise later on. So these are simple cases, but I want to share you because really they surprised me a lot. And now I open to comments and questions.
Dr. Naveen, you're muted. We can't hear you.
Yep. Can you hear me now? Yep. Thank you, Hedy. I was curious about the first case, and I would like your views on how much that blurred vision that the patient complained of had anything to do with the diagnosis, and what made you do the neuroimaging for that particular patient. Because if I remember,
Well,
the blurred vision and a
well,
bit of photophobia.
in the first case, I want to be sure I was not missing anything that could surprise me. That's why I wrote an neuroimaging. The nervous theory is common, but why she was complaining, blurring, good surgery, no complication, and she continued complaining of the blurring vision. So I want to be sure. That's
Right.
what I ordered, and I didn't expect at all the result of the tomography. You can imagine my surprise when I was seeing the images. So, and she continued complaining, but nowadays she's happy because she knows why. And the mechanism involved maybe is vascular subtraction. You know that there are disturbance of the vascular circulation when aneurysm is there, and I thought it's that. Why in the left and not in the right, where is the biggest aneurysm? I don't know.
Right. Any comments from any of the other panelists? Because this is something unusual that, in the sense that Hedy was lucky that her index of suspicion was high enough to do an MRI with an MR angio and pick up this very large aneurysm. And especially with the eye examination and the investigation, like fields all turning up kind of normal. Sometimes we just put it down to intuition or just experience. I just would like our other speakers or panelists to weigh in on this particular case, because it's so easy to miss. That's the thing I was thinking about.
Yes, easy to miss, and I want to be sure because this is a real woman that is a good woman, intellectually well prepared, and so why is she complaining so much? She refer really troubles in the daily visual life. So I want to be sure. That's all.
We have one question
And
from
yeah,
Preeti Patil, who says, in the first case, the CT picked up the aneurysm, but what would be your preferred modality of imaging?
well, angiography is the gold standard, but it's invasive and has risk. So I feel that tomography with angiotomography is enough. MRI with angiography seems to detect smaller aneurysm, lesser than 2 millimeters. And also the subtle invasion of the aneurysm of the arachnoid that can induce subarachnoid hemorrhage, but it's expensive. And so I believe that with a good tomography, with angiotomography is enough. And you also get with this the bone relation that is needed for surgery.
Right, right.
Dr. Janil, would you like to discuss?
Janil, would you like to say
Just a
something?
question to Dr. Martinez. Excellent cases, and the first case is something which I came across exactly. And for me, I took a longer time to advise imaging, and I picked up a little late where the visual acuity dropped. So interestingly, do you think when we go back to such patients, an OCT MGCL would be able to pick up those findings even before the visual field effects develop? Because the patient did complain of uncomfortable vision. Acuity always remain good, but definitely there must be a compressive effect of a fleeting effect of the aneurysm, probably fluctuating with blood pressures, more in some diurnal variation. So probably a slow damage to the optic chiasm over the period of time can be picked up by OCT, MGCL earlier than the field effects. Is it possible? Because I didn't find that in a very similar patient I had 6 months ago.
No, OCT was completely normal. Ganglion cells were normal. I believe it's functional. Only vascular soul from the aneurysm. That's what I feel. I'm seeing other cases of aneurysm that you can see in the MRI, the microangiopathy produced by the blood stool of the aneurysm, but not in this case that where the rest of the MRI was completely normal. And I want to add that the first patient didn't improve. The two others also went to surgery with a prestigious neurosurgeon here in Argentine with no complication. But after the surgery, they went worse. The diplopia was more permanent in primary gaze. And after 2 or 3 months, they began to improve. And they are returning to the primary position with intermittent diplopia. They have more or less 5 or 6 months of evolution, and I hope they'll continue improving. They have really no complication of the surgery. You know that these aneurysms are difficult to resolve completely, and recanalization is frequent.
Right.
And when I saw these cases, I was asking myself why these aneurysms grow so much, because they are symptomatic long time. You can see it, one of the patients from 2020. This patient, the first patient, was complaining for more than 2 or 3 years, a long evolution. And there is not a single explanation for this. Maybe a combination of mechanical factor and anatomical factor. The venous shed of the venous sinus provides the aneurysm a place to grow without complication. And also, you see the carotid divides into smaller branches, and this produces retrograde pressure. And also, the shape itself of the carotid arc makes turbulence acting on the arterial walls. Also, we must consider the walls themselves, the elasticity, the hardening, and of course, if we are with connective tissue diseases or fibromuscular dysplasia, it will be worse. But all this combination make possible that aneurysms grow asymptomatic until then compress the nearby structure.
Dr. Hady, I'd like to just quickly ask you about the second and third cases. We have a couple of minutes more. Intermittent diplopia with ptosis, with positive fatigue signs. What made you think that this is not myasthenia or this is something else that needed neuroimaging? And therefore, corollary to that is if we do an ICE test, what are the red flags that would tell us this is not really a positive ICE test, for example?
Well, as I told you, both were remote consultation. I was not able to examine by myself. So I want to be sure, yes, because the picture was not clear. Of course, methotrexate was not guilty of this. 1 week of methotrexate couldn't produce this. The first patient, diplopia resolved after COVID-19, but with a secondary diplopia and strain games. The case seemed not clear to me, because 5 years on myasthenia evolving, you must have something else.
Right.
And I couldn't realize the examination by myself. So I tell, well, initially it's in myasthenia, but be sure that we are not dealing with another thing. So order an MRI.
Great. Mahesh and Virender, maybe if you could comment on when you think an ICE test may not really be positive or suspicious.
Yeah, if I could see them and then I saw them,
Yes.
I realized the ICE test and it was negative. And fatigue there was not positive, of course. The patient referred that were worsened with fatigue, but it was not done by myself. I really believe a lot in fatigue and eye test. I find a lot of myasthenia in my daily consultation by this way, then confirmed by the antibodies or electromyography, but I couldn't perform it. And general ophthalmologists seem not to be able to realize this don't cry, because it's very easy. We speak about this easy test in all our presentation here, yes?
Right.
But not reliable from other ophthalmologists. They were negative.
Thank you very much, Dr. Hady. It's a very interesting set of cases that you presented. We will move on to Dr. Michael Dattilo, who's here to make his presentation. And
Thanks a lot.
thank you, ma'am. Dr. Michael is going to speak on the good, the bad, and the ugly. Mike, you have to unmute yourself.
Sorry about that. Yes, thank you so much, Satya, for the invitation to speak today. And thank you, everyone, for your attention. I'm going to share my screen now. Okay. Can everyone see my screen okay?
Yes, it's visible. You can go to slideshow.
Let me just hide the video panel.
Yep.
And hide the floating meeting controls for the moment. Okay, good. All right, so this case is entitled The Good, the Bad, the Ugly, and it is an uncommon manifestation of a common neuro-ophthalmic presentation that we see. I have no financial disclosures. So this is the case of a 64-year-old white woman who presented with intermittent fuzzy vision. Her past medical history was significant for breast cancer, status post-lumpectomy, and mastectomy of her left breast in 2001. Her past ocular history was significant for age-related macular degeneration in both eyes and a choroidal nevus. She was on multiple medications and had multiple allergies to medications, including penicillin, sulfa medications, all cane anesthetics, and preservatives. Her social history and family history were non-contributory. As I mentioned, she had macular degeneration, myopia, and a choroidal nevus in her left eye, for which she was followed at our institution since 2004. In July 2019, she saw one of our optometrists, and she complained of worsening vision in both eyes. However, on her examination, it was stable and normal visual function. The only findings were rare intermediate and small central drusen in both eyes and a temporal choroidal nevus. She was told to follow up routinely in 9 to 12 months. However, in February 2020, she presented to the emergency room due to worsening headaches, which were more severe than her usual headaches. They were also associated with nausea and vomiting, which were not typical for her headaches. She was treated with a headache cocktail for a severe migraine, and she had resolution of her headaches. She was discharged without further workup. 3 months later, in May 2020, she presented to one of our ophthalmologists, and she complained of a fuzzy change in her vision in the lower corner of her right eye, on and off for the last month. The episodes were intermittent, and they lasted about a minute or so per episode. It was felt by the ophthalmologist that her visual disturbances were due to optic migraine. On examination, she had stable visual function with normal visual acuity, no relative afferent pupillary defect, full ocular motility, and full visual fields to frontal confrontation. This is color fundus photographs of her eyes, and you can see the macular degeneration, the drusen in both eyes. And zooming in closer on the optic nerves, you can see that the right optic nerve is elevated and swollen, and the left optic nerve may have some slight swelling to it. On direct visualization, it did have some swelling. These are her visual fields, which had poor reliability parameters in both eyes, and they were essentially full with the exception of a possibly enlarged blind spot in the right eye. Peripapillary retinal nerve fiber layer confirmed elevation of both optic nerves, more so in the right and the left. And as you can see in the left eye from the infrared, there was definitely elevation and likely mild swelling of her left optic nerve. So what to do next? Well, that's really dependent upon what your differential diagnosis is. So let's talk a little bit about bilateral optic disc edema and the potential causes. So there are a number of various causes for bilateral optic disc edema, including infectious, non-infectious, inflammatory, ischemic causes. Compressive is unusual, typically unilateral, but I have seen several cases of bilateral optic disc edema from compressive etiologies. Toxic, metabolic, infiltrative, I included hereditary here with labor hereditary optic neuropathy, which causes pseudoedema of both optic nerves, but it can be mistaken for swelling of both optic nerves, and papilledema. On this next slide, I've just listed some causes in each of the categories, including sarcoid, MOG, optic neuritis, syphilis, ischemic optic neuropathy from NAION or radiation. Thiamine deficiency has been known to cause bilateral optic disc edema. There have been reports of vitamin B12 and vitamin A deficiencies also causing optic disc edema. And infiltrative, and as I mentioned, labor hereditary optic neuropathy can be mistaken for bilateral optic disc edema. And then papilledema, which we're going to delve a little further into. So papilledema, the most common cause of papilledema, which is bilateral optic disc edema due to elevated intracranial pressure, that I see is from idiopathic intracranial hypertension. However, there are much more insidious and concerning secondary causes of elevated intracranial pressure that I've listed here. And similar to glaucoma, it's a problem with drainage versus production, more commonly a drainage problem for CSF drainage, less likely choroid plexus tumors, choroid plexus papillomas producing more CSF than the drainage and the arachnoid granulations can handle. So any venous sinus pathology really can cause elevated intracranial pressure, meningeal pathology, space-occupying lesions intracranially, medications, iron deficiency anemia. I believe there was a talk that mentioned iron deficiency anemia yesterday, and malignant hypertension. So the workup for bilateral optic disc edema and papilledema necessitates neuroimaging. I prefer MRI brain and orbits with and without contrast to evaluate for both. MRV head with and without contrast is more specifically for papilledema, looking for venous sinus pathology. And then lumbar puncture with opening pressure in CSF studies. Frankly, the opening pressure is less important to me. If it is elevated and I'm considering elevated intracranial pressure, I use it as a confirmatory test. However, if the clinical scenario suggests elevated intracranial pressure and the opening pressure is low, that doesn't necessarily discount that diagnosis for me. The CSF studies that I typically obtain are your standard CSF studies with cell count, glucose, CSF protein, cytology, and flow cytometry to look for atypical cells, cryptococcal antigen, and bacterial and fungal cultures. Recently, I've included laboratory studies, not only a CBC, but I've had several cases of MOG manifesting as bilateral optic disc edema with fairly normal visual function that was suggestive of papilledema. And then depending on where I'm practicing, syphilis, Lyme, tuberculosis are also included, given the right clinical scenarios. So back to our patient. She was actually a statistician and a biomedical statistician. So after a very long discussion about the potential risks of and the potential causes for her bilateral optic disc edema, she unwillingly agreed to go to the emergency room for urgent workup for her bilateral optic nerve edema. And it's fortunate that she did. On the next slide, I'm going to show you her MRI scans, and I'll let them cycle through a couple of times. Not that it's subtle, so you guys can get an idea of what was going on with her. So as this cycles through, you'll notice that she has a giant extraaxial osseous mass that has aggressive features, including brain parenchymal invasion. There was invasion of the parietal and occipital bones and extracranial soft tissue invasion. She also has invasion of her superior sagittal sinus, which is most evident on the coronal images, on the sagittal images, sorry. And she had severe mass effect with leftward midline shift, right uncal herniation, downward transtentorial herniation, and downward tonsillar herniation. So all very concerning findings on her MRI. Interestingly, though, she had no symptoms. She had, except for that one episode of headache, she didn't complain of headaches, no diplopia, no pulsatile tinnitus or transient visual obscurations, as I would have expected with someone who likely has extremely elevated intracranial pressure. As you can imagine, a lumbar puncture was not done given her MRI findings. She was started on Keppra and dexamethasone for seizure prophylaxis and for the edema, for the cerebral edema that she had from her intracranial lesion. She underwent surgical resection and debulking with a biparietal and bioccipital craniectomy, as well as cranioplasty and external ventricular drain placement. Her pathology was significant for an atypical meningioma, WHO grade 2, which was infiltrating the bone. Her postoperative course, though, was complicated by cerebral edema, hydrocephalus, anemia, scalp necrosis, and seizures. She underwent multiple procedures to repair the bony defects from her craniectomy, and she received subsequent adjuvant radiation therapy to her residual tumor. Fortunately so this is just an article that was published by our group, just highlighting one of the more uncommon causes for elevated intracranial pressure, which is invasion or compression of dural venous sinuses by meningiomas. These are rare events from three various academic institutions between 2012 and 2016. Only 16 cases were identified. Of those, 10 had a delayed diagnosis, and as with our patient, these required multimodal and a multidisciplinary approach. So just to follow up with our patient, 3 months post-operatively, she was doing well. Her visual function was normal with normal color vision, no relative afferent pupillary defect, and normal visual acuity. She had interval resolution of her papilledema with normal appearing optic nerves. Her visual fields were essentially full in both eyes with possible mild enlargement of the blind spots bilaterally. And as you can see here, compared to her initial peripapillary retinal nerve fiber layer OCT, her 3-month postoperative OCT showed normal retinal nerve fiber layer average thickness in both eyes. So just to circle back to the title of the story, The Good, the Bad, and the Ugly. The good was her preserved visual function throughout her entire course, and ultimately she wound up with normal visual function, normal visual acuity. The bad was the finding of bilateral disc edema, which was later determined to be papilledema, although I guess you can consider this as something good because it led to her ultimate diagnosis, which was the ugly, which was this very large intra and extraaxial meningioma that was causing severe brain compression and the cause for her bilateral optic disc edema, her papilledema. Thank you.
Thank you, Mike. That is really interesting. I had a question to ask you regarding the first examination done. Was it in the ER, or was an ophthalmologist involved in the diagnosis of the migraine? And therefore, when would you consider a migraine not really a migraine?
So during the first
Looking back at this
examination,
case, in hindsight.
okay, so during the first examination where she was seen by the ophthalmologist, the one that was called the optic migraine,
Yes.
that was in clinic. So she was being seen for a routine annual examination, and the finding of bilateral optic disc edema was found. I happened to be in clinic the same day, so I was asked to see the patient to confirm the disc edema and to talk to the patient about next steps. But that was all done by one of our staff ophthalmologists, and I got called in after that finding of papilledema.
Okay. And do you do an LP for CSF for all your papilledema patients, or do you selectively, in the sense that, is it a kind of a presumed IIH that you make just based on the MRI and the papilledema, and you reserve the CSF for in case things are not going the way you feel they should go when you treat them?
Right. So
is it a blanket CSF tab for everyone?
The vast majority of patients on presentation, I will get a lumbar puncture in CSF studies. Very, very rarely will I not if the patient has significant objections to getting a lumbar puncture. And the reason that I do that is not so much, as I mentioned, for the opening pressure assessment.
Right.
It's more for the CSF studies. I've had several cases where we've had findings on CSF that led us to an alternate diagnosis in patients who were your typical demographic for idiopathic intracranial hypertension.
Right.
I found one case of cryptococcal Gatti meningitis that required long-term treatment in someone who otherwise would have fit perfectly the demographic for idiopathic intracranial hypertension. So because of several patients that I've had where they've had findings on CSF studies, even though they were the typical demographics, I typically perform it on all patients.
Is that the kind of standard across other centers and other hospitals as well? Routine CSF tab, or is it typical to Emory only or something like that?
I'm
Or
not
the
sure about
more
other
sense?
institutions. I know most of my colleagues that I'm aware of will do lumbar punctures on patients, or will perform lumbar punctures on patients who present with bilateral optic disc edema. At Emory, it is standard protocol for us. If there's someone who has bilateral optic disc edema suggestive of papilledema, we'll perform or order a lumbar puncture for all of them for the CSF analysis to make sure we're not missing an inflammatory neurologic process.
I would probably therefore throw this question to our colleagues in India, Dr. Jenil and Virender, Satya, Mahesh. Just like Mike said, for almost all patients with papilledema suspecting raised intracranial pressure, would you do a standard CSF for everyone, or do you kind of reserve it for certain situations? I'll ask Satya first, and then.
Yeah, so I think I would like to highlight that checking the blood pressure in the OPD is the first and foremost thing to be done, especially if you see any retinal changes along with the disc edema. Many a times you just have accelerated hypertension causing bilateral disc edema with some retinopathy. So that is the first. And second is, I would like to add that I did see a patient who was a doctor, a general physician, who presented with headache and somewhat similar presentation as yours. And on complete ophthalmic examination, found papilledema, and his MRI, along with MRV, just like the protocol that you suggested, showed a huge frontal meningioma, along with a superior sagittal sinus thrombosis. So I guess he developed the increased intracranial pressure when he developed the sagittal sinus thrombosis. So that was treated first. Over a period of few months, that resolved. His headaches went away, and then he went for a surgical excision of the tumor, and everything came back to normal, and he is doing his practice very well. So I think the mechanism here is that meningiomas grow very slowly, and therefore, even if they do cause any kind of increased intracranial pressure, the symptoms develop so gradually. I mean, the process is so gradual that the patient doesn't really realize it until a symptom becomes significant.
Right. Virender, papilledema, normal MRI sort of with maybe some venous sinus stenosis. Do you proceed further and do a CSF tap, or you treat first and then see?
Thank you, Dr. Naveen. I think if the imaging is showing signs of raised ICP and we do not have any structural lesion, we always obtain a CSF opening pressure and analysis at our LVPI centers.
Right.
That is a standard practice for us.
Right.
But we all, as Mike also was telling, that he obtained MRV brain or MRV head. So that is part and parcel of the imaging for our all patients. We are assuming that there is no CSVT also.
I think everyone here does an MRI with an MRV for
papilledema.
Mahesh, any comments on this?
Yes, Dr. Naveen, thank you for the question. So in a clear case of idiopathic intracranial hypertension with a patient who typically fits into that profile with a high BMI, I would hesitate in doing a lumbar puncture. And we might go clinically that, okay, she fits into that pattern, and why not treat it with Diamox and see. So in this context, I have a concern because some of these patients, when we do in all these patients, at least some of them come with a chronic back pain. You know, these are all ladies who need to do work at home, and it's not good to hear that complaint from them. And for months and years together, some of them have this. So why not give a clinical thought that she has a high BMI, and why don't we treat clinic? That is my thought. It may not be entirely scientific, but then that's my thought process. In selected cases where it's a fulminant IAH or threatening vision loss, or a male patient, then probably a lean female patient, probably we would go for a lumbar puncture. Thank you.
Any
I
other
make a
comments?
comment, Dr.
Yes,
Navin?
Ambika, go ahead.
Yeah, Preeti, you go ahead.
No, ma'am, it's all right. You can start.
Please.
Okay, let's ask Preeti
Finish.
first. Please go ahead.
Yeah.
Preeti.
No, I was just going to comment about the LP, a couple things. So here, where I'm practicing now, which is UPMC and the Children's Hospital, we do get an LP for everybody, of course, after an MRI and MRV. And Western PA is sort of like the Lyme capital of the United States. I know it's not something we see commonly in India at all. But there are several children who present with Lyme meningitis, which looks and feels exactly like IIH. And getting the CSF analysis is key, because if you do treat them with Diamox, empirically, they're going to respond. You will almost always see an initial response, which could sort of trick you into assuming the IIH diagnosis,
That's an
as would
interesting
be the
point.
case. As would be the case probably with some of the more severe sinister presentations, including carcinomatous meningitis even. So I think getting the CSF, and I agree completely with Mike here, is not so much for the opening pressure, but for the analysis actually would be key. Of course, if we imagine find a Chiari and that precludes an LP, that's a different situation.
Yes.
The other question I had for Dr. Dattilo was, you ended up being pulled to see this patient in clinic. It happens to all of us when you get curbsided sometimes. How urgently would you press for the evaluation? Would you insist, like you did for this case, to go into the ER for an emergent workup? Or would an outpatient workup in this situation, relatively asymptomatic patient with bilateral edema, would you consider an outpatient workup, which we know could take a few weeks?
Right. Typically, I recommend emergency room, specifically or particularly in this patient because she was an atypical demographic. She was skinny. She was outside of the typical age range for papilledema. She was in her 60s. So for her, I was suspecting idiopathic intracranial hypertension less than some other causes, but I didn't have a clear understanding as to what her cause was. So I wanted to rule out potentially concerning and dangerous pathologies. In most of our patients, I typically do recommend emergency room care just to get expedited dural imaging, mainly because it can take weeks, and I don't want people to have a concerning diagnosis or a potentially detrimental diagnosis that goes undetected for a while. I've had several cases of patients, young patients, who have had glioblastomas who had no neurologic sequelae but had elevated intracranial pressure from a glioblastoma. So I think urgent diagnosis is probably best, and it's facilitated through the emergency room. So even in patients of typical demographics, I typically recommend emergency room workup, provided they haven't come in with neuroimaging already, whether it be a CT scan or an MRI. If they've had a CT scan recently that was normal, or an MRI recently that was normal for another reason, then I would pursue an outpatient workup. I wouldn't necessarily go through the emergency room.
Thanks, Mike. Quick comment from Ambika, and then we can move to the next patient, please.
Sure.
Yeah, I think default we are getting an lumbar puncture for most of our patients for bilateral papilledema. But one important thing is nowadays I see people who are coming with a choice that will they go through a lumbar puncture or not from many of the neurology referrals. But those are the ones which are very subtle disc edema without any visual compromise. But these cases we can use OCT to follow up the disc edema. And sometimes it can be we fish out many of the times MOG and GFAP and so many associations where we get a CSF. So if you see a bilateral disc edema, it's always better to get. And we also have a lot of viral illnesses which can go missed if we are not getting the analysis done with the infections preluding along with us. So better get an analysis with the pressure always.
Agree.
Thank you, Ambika. We'll move on to the next case. This one will be presented by Mahesh, I believe. We'll have Virender following that.
Yes.
Go ahead, Mahesh.
Yeah. Okay, so good evening all, and first I would like to thank Satya for having this program and having invited me to present this case. So my case is a case of a sudden vision loss due to blindness due to the third eye. So this is a young boy who presented to us with sudden onset of painless defective vision of 1 week duration, and in both eyes of with a subacute progression. So prior to this, he had vomiting and headache of 1 month duration, and he gave a history of seizure 3 weeks ago. So on examination, he had a visual acuity of no light perception in both the eyes. There is some degree of lid retraction, and both the pupils were 5 millimeter dilated and very sluggishly reacting to light or not at all, because it was a no light perception. On examination of the ocular movements, there is a limitation of abduction and elevation and adduction in the right eye, with a slight upbeat nystagmus with a retraction of the globe and attempted upgaze with a convergence. So it was essentially a convergence retraction nystagmus. And in the left eye, he had a limitation of elevation and adduction alone, and a mild degree of nystagmus and retraction of the globe and convergence on attempted upgaze. So this was the child. So there is some degree of convergence retraction nystagmus when he was trying to elevate, and unfortunately the movements could not be recorded, and you'll have to take it from me. The movements which I had presented in the previous slide, there is limitation of the elevation and abduction and adduction in one eye, and elevation and adduction in the other eye. On fundus examination, he had a mild degree of bilateral temporal pallor of the optic disc with a papillomacular bundle damage. And initial evaluation with the CT had shown a mass in the penile region. You can see here it is a dorsal midbrain mass, and then it is compressing and causing a hydrocephalus. So now this is a case of a pineal gland, a dorsal midbrain tumor, which is causing a no light perception in both eyes, which is quite unusual. And so it was diagnosed as an optic neuropathy, paranoids, and ocular movements of a 1.5 syndrome picture. So he needed a definitive neurosurgical management, which was promptly referred. So after presentation, he was referred to the neurosurgeon, who initially went VP shunting, and then on the visit 2, he had a temporal pallor persisting. The vision was no light perception. He had occasional flashing of lights, probably some degree of attempted regeneration, and he still had a horizontal gaze palsy in the right eye. On the visit 3, after 45 days, we were relieved to see some degree of improvement. He was on regular follow-up with the neurosurgeon, and he had some degree of vision in the right eye, and the left eye also had a light perception and diffuse degree of chalky disc pallor in both the eyes. And further down, his vision had marginally improved in both the eyes. And after the VP shunting, now he underwent a definitive craniotomy and partial excision of the tumor because it was very close to the vital structures. The neurosurgeon decided to do the partial excision, and it was a grade 1 pinealocytoma. And 5 months later, in the final visit, he had some degree of useful vision, 1/60 though, and the convergence retraction nystagmus persisted with a diffuse chalky pallor, and patient was lost to follow-up ever since. So this tumor is unique in that sense. We normally don't expect an optic neuropathy. So now what happened here is a tumor which is not normally known to cause sudden vision loss. And the proposed mechanism is a dilated third ventricle causing a subclinical chiasmal compression. So what has happened, we know that anatomy-wise, the third ventricle is related superiorly to the chiasm, and it invaginates between the optic stalk and the recess here. And then whenever there is a dilatation here, it can invaginate and press on the chiasm. So this is a unique mechanism. Normally, we would expect hydrocephalus and ventriculomegaly causing a secondary optic atrophy with a subacute, very chronic vision loss. And here, there is a prompt VP shunting relieved the pressure and improved the vision. So because of its anatomical location, which we normally don't expect, and this is an unusual presentation. And what has happened is likely it was a chronic vision loss with a subacute total vision loss, and that is why the child had came in an acute presentation. Probably he had not realized in the chronic phase, and it was a chronic slow compression, and suddenly when it acutely compressed, the child presented to the ophthalmologist. So again, this is a mechanism, displacement of the third ventricle and compression of the optic chiasm. Thank you.
Very, very unusual and very interesting case, Mahesh. I just had a question. That temporal pallor that you showed.
Yes.
And sometimes, even when we see temporal pallor on PowerPoint presentations, it's difficult to actually make out. And if it's particularly subtle, or sometimes you get artificially bright looking temporal pallors. I was just wondering whether there was a OCT RNFL or something like that along with this. And I'm trying to correlate that mildish kind of temporal pallor with the no light perception. And what was the kind of time frame? Because NLP would indicate that it's not yet a chalky white disk. So at least 6 to 8 weeks before that would happen. So was it fairly sudden, that drop in the vision?
Yes. So unfortunately, OCT was not done in given the situation, and it was a sort of a sudden drop within the last 1 week. So within the last 1 week. So likely the whole compression would not have happened in 1 week. Likely it was in many, even in a pituitary tumor, we would have seen that many times there is just a chiasmal compression and the patient retains good vision for a long period of time or very subtle vision loss. And the pallor doesn't develop yet whenever it's compressed. So it's likely it was present for a longer period of time. And since he was a child, he didn't realize it. And once he started looking for objects, maybe the parents brought him here.
Right. Because I found that NLP and the temporal pallor was not exactly matching. A chalky white pallor would have probably, this would possibly be. I'm just curious whether the pressure was fairly sudden or sometimes maybe impinging on the vasculature of the chiasm, producing a sudden ischemia. Like the pseudo-optic neuritis with sudden enlargement of the pituitary gland, which produces like an optic neuritis kind of a picture, where a steroid improves the vision in 1 day itself, and then you start to suspect this actually a compression and not a retrobulbar optic neuritis. Is it something similar? Was there some kind of an inflammation or a ischemic episode which might have caused the suddenness of it, which is not really matching the appearance of the disc at this end?
Yeah, but after the VP shunting, we did see
Yes.
some degree of improvement during the course of time. So probably the pressure relieved.
True.
But because of the possible chronicity of the lesion before presenting,
The-
possibly some nerve fiber layer damage.
So the disc continued to worsen then, appearance-wise.
Yes.
Okay.
It was not manifest at presentation.
Very interesting. Any comments from our other panelists? Janil?
Yes, Dr.
Paramita?
Yes,
Paramita, are you here?
Yes, I am here.
Oh, wonderful. Paramita, go ahead, please.
Dr. Mahesh, how do you explain the 1.5 syndrome?
Yeah, probably it is not exactly in the location of the fibers of the medial longitudinal fasciculus, and possibly it's a diffuse raised intracranial pressure which is compressing the brainstem as a whole. It's not entirely explainable, and possibly it's the brainstem as a whole compression which might have caused the limitation of the movements. And that is what I would presume.
And was there any evidence of hemorrhage in the tumor that could explain the sudden increase in
no.
volume?
The radiologist reported as heterogeneous enhancement of the contrast, but then there is no report of hemorrhage within the tumor. There is no report. And the fact that after the VP shunting, the ocular movements also fairly returned to normal in a period of time, probably tells possibly because it's a diffuse limitation and diffuse pressure on the brainstem, entire brainstem. The vision at follow-up, as asked by Shika, is again 1/2/60 and 1/60 in the last follow-up.
Janil or Satya, any comments?
Unusual case. Have seen some referrals prior to radiation for pineal gland tumors, where they want to see if there's an optic nerve involvement. And we have seen a normal visual as well as visual fields. Is one mechanism there that if there's a very sudden increase in a very short duration of intracranial pressure, it will cause ischemia of the optic nerve head rather than, and that would be responsible for, is this a possibility? Because the nerves look like a primary optic atrophy. So it is compressive, but are there other theories in mind that why suddenly bilateral no perception?
It could be a vascular compromise also. It could, because of the compression, it could be a coexistent vascular compromise.
Right. Thank you, Mahesh, for that very, very interesting patient. We move on to the last case in our session with Virender is here. So Virender, please go ahead.
Yeah, thank you. I'm just sharing the slides.
Yep.
Yeah, so I hope my slides are visible.
Yes,
and,
it is. Yeah.
Okay. Thank you, Dr. Satya, for organizing this wonderful event and giving me the opportunity. So this case is titled as "Did you check my neck?" And let's see why it's there. These are some of the abbreviations which we are using in this case.
Could you go to the slideshow, Virender?
Doctor, it's not in slideshow mode.
Okay, just a second.
Bottom right hand side where you have minus sign just next to that. Yeah, it is in the presenters mode, Doctor. We can see the other slide. Yeah, all good. Thank
Now
you.
we're good. Now we're good.
Okay, good. Thank you. So yeah, so these are some of the abbreviations that we'll be using in the presentation. So this case is of a 47-year-old non-obese woman who had presented to us with complaints of headache, blurred vision, and transient visual obscurations from 20 days prior. To characterize her headache, it was holocranial, diffuse, present all over the head, and it was constant, present all the time, but was slightly worse in the morning. So she was already seeing a neurologist and who had referred to us with a prior diagnosis of papilledema. Actually, I got a call that this patient is likely papilledema, and we are referring for further evaluation to you. And there was on further probing, there was no other relevant history of vomiting, tinnitus, diplopia. The headache was not worsening on bending forwards. She denied any recent weight gain, and she was not taking the drugs that could be associated with raised ICP, keeping in view that we already had a referral for papilledema. So no vitamin A, tetracyclines, nitrofurantoin were being used for the patient. She denied other neurological complaints, but her past medical history was significant for hypertension and diabetes mellitus for 20 years, though they were under control. She had developed chronic kidney disease 4 years prior and was on hemodialysis from last 2 years. So in the history of managing her chronic kidney disease, she received hemodialysis from a right internal jugular vein catheter for about 18 months. After that, it had closed. And then the patient was currently receiving hemodialysis from the left. Come back to it little later. On the examination, patient's blood pressure was normal at 120/80. The body weight was 48 kgs and BMI was 21.3, which corresponds with our previous assessment, non-obese. There was no other systemic neurological abnormalities on examination. Her ocular examination showed that it was a normal visual function with good visual acuity, color vision, extraocular motility was full and free, and pupils were round, regular, and reacting. This is the fundus examination of the patient. The key findings being normal retina and media, but there was grade 3 disc edema in both eyes, 360-degree obscuration, splinter hemorrhages in right eye, and there was also a few hard exudates along with few dot plot hemorrhages, suggesting a coexisting moderate NPDR. There was mild attenuation of arterioles, but not markedly present over there. So we obtained visual fields of the patient, and we can see that there is enlargement of blind spot in both eyes. In the left eye, we can see that there was a nasal field defect, and there were few depressed points superiorly and inferiorly along the arcuate areas in the right eye. So we know that this patient has frank papilledema. We are not dealing with pseudopapilledema, or could it still be an optic neuropathy? We know that normally we look for a triad. We look for vision change, color vision change, and the pattern of field effect. And this was most consistent with the diagnosis of papilledema for our patient. But what is most important is what could be the probable cause of disc edema in this patient. So it was coming in the discussion before. We always need to check the blood pressure of the patient, and the patient's blood pressure was normal, but malignant hypertension is one differential diagnosis. We have to rule it out always before we go further. Then we could have a bilateral non-arteritic anti-ischemic optic neuropathy. We also considered uremic optic neuropathy given the history of chronic kidney disease. The patient can have a idiopathic intracranial hypertension as a standalone diagnosis, or could it be a cerebral sinus venous thrombosis? And in fact, a special form of CSVT, which is IJV thrombosis, because the patient did have a central venous catheterization in the internal jugular vein for her dialysis. So let's see, for benefit of everyone, the malignant hypertension usually presents with disc edema along with presence of attenuation of arterioles, cottonwool spots, hard exudates. And these findings are not just confined in the peripapillary area, but usually extend much more beyond over the posterior pole. And if you see them reaching the second and third order AV crossings, they are more suggestive of malignant hypertension. Even in the earlier cases, means when all the full-blown picture has not been present, you can see usually cottonwool spots and specifically arterial attenuation. Like you can see possibly in the image to the right, we can see that the patient has a marked attenuation of the arterioles which are looking thread-like. In our patient, we never had a higher BP recording and it was recorded stable. There was not much arterial or attenuation as we expected to be malignant hypertension. So these were against a possible diagnosis of malignant or accelerated hypertension leading to bilateral disc edema. Bilateral NAION is an uncommon disease, can occur in about 1 to 2% of all cases with NAION. But the points in favor in our patient were that it was a middle-aged female. There was chronic kidney disease, hypertension, diabetes as the risk factors. But the patient did have a good visual function. Visual fields showed only enlargement of blind spot, and her vasculopathic risk factors were recordedly normal. However, incipient NAION cannot be ruled out at this point of time in the patient. Uremic optic neuropathy again is rare, but can occur in patients with very high BUN levels, more than 100 milligrams per deciliter. The patient can have a marked decrease in vision, but our patient did not have a marked decrease in vision. There was only mild blurring of vision along with TVOs and headaches. So it was lower in the differential diagnosis of our patient. IH, as we discussed previously also, it does occur in middle-aged women and patients have good visual function. The points against in our patient were it was a non-obese patient with a normal BMI. There was no history of weight gain or taking any medication that can precipitate intracranial hypertension. Our patient was rather older with the age of 47 and there was no other significant history. So in an in-house data analysis, we had seen that if we look at the age cutoff for IH versus CSVT, age more than 36 years suggests that we should look first for CSVT rather than IH, irrespective of the gender of the patient. And since there was hemodialysis history from IJV, we were thinking that it could be IJV thrombosis, which is the cause of secondary intracranial hypertension. So we went ahead, obtained MRI brain and orbits with contrast, and we also requested for MRV brain and neck with contrast. Normally, we discussed in the previous case also when Mike was presenting that we obtain MRV brain for all these patients, but neck was ordered as keeping in view the history of IJV being used for the dialysis. So what was important was that looking at the kidney function of the patient and planning the MRI, MRV in the same setting. Patient's serum creatinine was 15 and BUN was 194. So it was difficult to obtain it. So we coordinated with the radiologist as well as the nephrologist. We did MRI, MRV with contrast on the same and followed it up with hemodialysis on the same day so that the contrast could be removed from the body. For the benefit of all the audience, very quickly, this MRV tells about the venous drainage from the brain. We can see that superior sagittal sinus, the inferior sagittal sinus, they usually converge towards the confluence of sinuses, the right and the left transverse sinuses, which continue as the sigmoid sinuses, and then they go down as the internal jugular vein to, and we can have it. If we look at the anatomy of the venous drainage, we usually see that the transverse sinuses tend to show one side is usually more dominant, drains more of the fluid, the venous drainage, and it's usually more on the right side. In about 60% of the patients, right side is dominant, while 16% of the patients can have a co-dominant drainage. This is little important keeping in view the pathophysiology. We'll come to it later. And from the internal jugular vein, the venous drainage does go down towards the superior vena cava. What is also important to know is that the brain has compensatory mechanisms such as vertebral plexus and pterygopalatine plexuses, which allow for a compensatory mechanism to be working. So we come to the MRI and MRV findings of our patient. We can see that there was flattening of the sclera on the posterior aspect of the eyeball at the optic nerve head junction. We also see there is dilated perioptic nerve sheaths, suggesting that there were signs of raised ICP. And the MRV brain did not show presence of any thrombus. The left side venous drainage, left side transverse sinus was hypoplastic, which is quite common, but there was no CSVT that was noted. So coming to MRV of the neck. So this is a video of the patient's MRV. We can see that the venous drainage is coming. We have the internal jugular vein draining on the left side very well. But on the right side, we can see that this area is not showing the internal jugular vein. I will play the video once more for displaying that the dotted lines suggest that where the internal jugular vein should actually be there and draining into the subclavian vein. So given this, the diagnosis of IJV thrombosis leading to secondary intracranial hypertension was confirmed, and the papilledema was secondary to this mechanism. Patient also had moderate NPDR and the systemic diagnosis as mentioned here. Now the next question comes, how do we manage this patient? Patient has chronic kidney disease, and would a medical management or surgical management will be indicated? We usually keep in mind that medical management works well when we have good visual fields and good compliance, whereas patients with advanced visual field defect at presentation, visual loss, a rapid deterioration, and poor compliance to medicines indicate a surgical management. So in discussion with the patient and the nephrologist, we decided to give a trial of medical management first. It is difficult to give large doses of acetazolamide in these patients. The nephrologist allowed us to use 500 milligrams per day, and the patient was also started on oral anticoagulants. And 2 months down the line, we can see that the patient showed a good recovery of the disc edema. The visual function was very well maintained, and we can see that the visual fields also started showing resolution of the enlargement of blind spot and the nasal field defect in both eyes, suggesting that the things worked out for our patient. Coming to the last aspect, what is the likely pathophysiology of raised ICP in these patients? So not all patients with IJV thrombosis get a raised ICP or a CSVT, but IJV thrombosis can account for about 12% of all cases of CSVT. Hypercoagulable states are one of the mechanisms, and then it has also to occur in about 14 to 66% of patients who are receiving hemodialysis catheters even for a short duration. So we see patients in ICU who are put on central venous lines, and they can also develop. What is the mechanism of developing IJV thrombosis? It could be secondary to altered hemodynamics. There is a high venous flow, which causes high turbulence and leads to endothelial damage, which promotes a venous thrombosis in these patients. Is the venous thrombosis alone enough to cause papilledema? So there are two aspects here. What is important to know that in patients with with indwelling catheters, there is one is high venous flow, but venous thrombosis should develop. Then only we usually see the development of raised ICP. And in our patient, what is the mechanism for developing bilateral papilledema and observing these findings? So we know that right side venous drainage was blocked because of the IJV thrombosis, which is confirmed by the history as well as by the radiological findings. Then is the compensatory mechanism, as I discussed before, with pterygopalatine plexus and other blood venous drainage not enough? What about the other side? We remember that the patient had a hypoplastic left transverse sinus as well. So patient did have both IJV thrombosis on right side and a hypoplastic transverse venous sinus on the left side. And this all combined possibly led to development of raised ICP and papilledema. So take clinic message is that IJV thrombosis is a rare thing to happen, but we should suspect in specific conditions. We should obtain an appropriate workup, including MRV, brain, and neck in patients with long-standing central venous catheters. And we need to coordinate the care of patient both at the time of getting the imaging as well as in further follow-up for giving appropriate care. Thank you very much for a patient hearing, and I'll be happy to discuss further.
Thank you very much, Virender, for a very interesting presentation and highlighting the fact that, yes, there are certain situations when one needs to do not just MRI or MRV of the brain, but to extend the area of interest further downwards, as seen in this particular patient. I was just curious to know in terms of the long-term management, so do you continue to treat the patient on Diamox, or does the whole thing kind of settle down, as it were, and the disc edema disappears, but the IJV thrombosis still persists? I mean, does that clear or not at all?
Actually, this patient had a very long length of the IJV thrombosis. So we kept the patient on oral anticoagulants. And I think for a period of about 4 to 5 months, we kept on acetazolamide. Then we tapered it off, and the patient was doing well at the last follow-up with us. I have seen the patient for about 18 months in the follow-up, and then she was doing well without any recurrence of disc edema, but was kept on oral anticoagulants.
So the thrombosis persists, is it like that area, or have we not looked at it again after that? And in that sense,
Actually,
any MRV or was done or anything?
Repeat MRV was
Curious,
not
the
done.
underlying pathology is still there, but the disc swelling clears up with the medical management, and you can taper and remove the Diamox finally, and it continues to hold even though maybe the IJV is still thrombosed, or any light on that?
So there are, I was going through the literature about it. It recanalizes partially, so the venous drainage would improve. But at the same time, in this patient specifically, repeat imaging was not done. It was discussed with the patient, but patient was not keen on getting it done. Especially given the fact that it has to be coordinated with the nephrologist as well.
True.
That was the point. Dr. Kornblath has added that we can use furosemide at high doses in patients with chronic kidney disease. Definitely, that it was discussed with the nephrologist, which drug they would like to allow us to use, and the nephrologist allowed us to use acetazolamide as the first drug.
What are your, does anyone have experiences about patients with CKD or whose creatinine level is slightly higher than normal, and do the radiologists go ahead with contrast, or they still prefer not to do contrast? Does anyone have any experiences about that? in patients whose creatinine level is a little higher?
So actually, what my knowledge tells is that they look at the glomerular filtration rate. And
Okay.
if the GFR permits it, they can use the contrast. But as was done in this patient, they add dialysis on the same day if the
Right.
GFR rate is very less.
Right. Any other comments from anyone or questions?
Dr. Virendra, hello. Good
Yeah,
evening.
go ahead.
Daniel.
Is there still a possibility of looking at the clinical picture purely of the fundus, a dual component, that there is a component of malignant hypertension, and though later on, because the patient responded to Dimox, so that still exists because the patient is prone to having hypertensive episodes or hypertensive crisis, is patient of CKD. So is that and IJV probably is also one of the probably a dual mechanism, or it could be an incidental finding since it was well thought by you during the clinical examination.
General, definitely malignant hypertension we did consider. We went through the patient records and the blood pressure was always recorded to be normal. So she was on medicines. There were no episodes suggesting that there were accelerated hypertension in the past few years. So she was maintaining regular checkups and these records were available. But yes, we have to keep that in mind in a CKD patient always. I agree with that, but in this patient specifically, it was not there.
Also, the imaging did not show a lot of collaterals, or may have missed. So that suggests that it's a very not long-standing thrombosis, and it could be probably nearly recent onset and not lasting for many weeks or months. Is that one likely possibility that it's not a chronic thrombosis?
Yes, I agree with you. It was not very well seen on these images, and but the patient was possibly getting a little bit of the collaterals which were there. If you see the right side versus the left side, I think it is there. I'll try to reshare, but yeah, we are little late in the session, but you can see that there is a little bit of collaterals which are forming on the right side.
Thank you, Virender, and I'll hand over. Thank you all for attending this particular session. Slightly behind time, so I'll hand over to Satya, and thank you very much, Satya, for having us.
Thank you, Dr. Naveen. It was a very stimulating session, and now I would request Virender to continue moderating his session.
Yes. Thank you, Dr. Satya. So we come to the last session, but possibly one of the very interesting and one of the best sessions planned by Dr. Karna. It's my pleasure and privilege to introduce all the panelists and speaker to this session. I'll begin with a brief introduction for the panelists. Let me just try and share the slides. So I hope that they are in the slideshow mode.
Yes.
Okay. So our panelists, we have a galaxy of national and international neuro-ophthalmologists who will be there in this session. Our first panelist is Dr. Ramesh K. Kunaya. He is head and consultant at Child Sight Institute of LV Prasad Eye Institute. And he also heads the Center for Technology and Innovation at LVPI. He did his pediatric ophthalmology fellowship at Jules Stein Eye Institute, and he's an excellent teacher, mentor to many of us here in the group as well as in the session. And he is a reviewer for ophthalmology, BGO, AGO, clinical and experimental ophthalmology. His keen areas of interest include complex strabismus, vision development, pediatric cataract, pediatric neuro-ophthalmology, and ophthalmic genetics. Our next panelist is Dr. Varshini Shankar. She is a consultant in pediatric ophthalmology, strabismus, and neuro-ophthalmology at Shroff Eye Center, New Delhi, and Viva Vision Center in New Delhi. She did her fellowship in pediatric ophthalmology and strabismus from Shankar Nethralaya, Chennai, and her special focus is disorders of convergence and accommodation, complex strabismus, and unexplained vision loss. Welcome, Dr. Shankar. Next, we have Dr. Veerna Shah, who heads the Department of Neuro-Ophthalmology at Arvind Eye Hospitals, Coimbatore. She has over 2 decades of clinical experience in the field. She has over 40 peer-reviewed publications in neuro-ophthalmology and related disciplines. Her key areas of interest include optic neuritis, toxic optic neuropathies, and artificial intelligence in neuro-ophthalmology. Welcome, Dr. Shah. Next, we have Dr. Pradeep Sharma. He's a consultant, pediatric ophthalmology and strabismus, currently working at Center for Sight, New Delhi, India. He formerly headed the strabismus unit at RP Center, AIMS, India. He has over 250 index publications. He has helped many PGs with their thesis, and he has authored the book which many of the postgraduates follow in India, Strabismus Simplified and Essentials of Ophthalmology. He is privileged to be the first Asian invited to deliver the NAP lecture by American Association for Pediatric Ophthalmology and Strabismus in Vancouver, 2016. And he was also recognized for his contribution to the field by American Academy of Ophthalmology by Achievement Award in 2017. Welcome, Dr. Sharma. Next, we have Dr. Vivek Warkad, who is a consultant and head in the Department of Pediatric Ophthalmology, Strabismus, and Neuro-Ophthalmology at our Bhubaneswar campus in LV Prasad Institute. He did his fellowship in LVPI, and followed by that, he had a stint of international fellowship at Boston Children's Hospital, Harvard Medical School. His special focus is on complex strabismus, pediatric neuro-ophthalmology, and pediatric cataract. Currently, he has over 30 publications and serves on the editorial board of IGO. And he has been invited speaker in many national and regional conferences in India. Welcome, Vivek. Next, we have Dr. Seema Biswas, who is currently a neurologist in private practice in North Carolina, USA. She is a board certified general neurologist, certified by the Diplomate of American Board of Psychiatry and Neurology. She has a unique experience in the field of clinical neurophysiology. She is also a former ophthalmologist with a special interest in neuro-ophthalmology. She hails from India and has done her education and training at JIPMER, India, both her MBBS and ophthalmology residency, followed by clinical neurophysiology fellowship from University of Iowa Hospitals and Clinics, USA. Her research interests include epilepsy, neuromuscular disorders, and neuro-ophthalmology. Welcome, Dr. Biswas. And our first speaker for today is Dr. Wayne Kornblath. He's a professor of ophthalmology and visual sciences and neurology. He did his medical schooling from University of Missouri, 1983, and did his residency in neurology from University of Pennsylvania in 1987. He went on to do his neuro-ophthalmology fellowship from Wilmer Eye Institute, Johns Hopkins, in 1989. His interest areas include ocular myasthenia gravis, giant cell arteritis, optic neuritis, and idiopathic intracranial hypertension. Welcome, Dr. Kornblath. Our next speaker would be Dr. Daniel Gold, who is professor of neurology, ophthalmology, and otolaryngology, head and neck surgery, neurosurgery, emergency medicine, and medicine at the Johns Hopkins University School of Medicine. He is a neurologist with fellowship training in neuro-ophthalmology at University of Pennsylvania. And in addition, he went on to do special training in neurovestibular disorders at Johns Hopkins. He is currently the Director of Ocular Motility and Vestibular Otoneurology Fellowship within the Division of Neurovisual and Vestibular Disorders at Johns Hopkins. He has made outstanding contributions to neuro-ophthalmology through the novel platform especially contributing to the ocular motor and vestibular collection. Welcome, Dr. Gold. Our other speakers are Dr. Bart Schwales. He's faculty in neurology and ophthalmology. He did his training at many prestigious institutes, University of Illinois, Chicago, followed by residency in neurology at Harvard Medical School. He did clinical fellowship in advanced general and autoimmune neurology at Massachusetts General Hospital. And he also did fellowship in neuro-ophthalmology at the same place. His focus areas include inflammatory disorders as well as those disorders affecting the base of the skull. He's a founding director of Inflammatory Neuro-Ophthalmology and Skull-Based Disorders Clinic there. Welcome, Dr. Schwales. Our next speaker will be Dr. John Chen, who is Professor of Ophthalmology and Neurology at Mayo Clinic, Rochester. He's Fellowship Director for Neuro-Ophthalmology at Mayo Clinic. He chairs Upper Midwest Neuro-Ophthalmology Group. He's on multiple committees for American Academy of Ophthalmology and board member for NANOS. He has won the Achievement Award from AO, and many a times he has been conferred the best teacher at his workplace, that is Mayo Clinic. And his focus areas include ophthalmic imaging, IIH, and optic neuritis, especially NMOSD and MOG antibody-associated disorders. So welcome, Dr. Chen. Then we have Dr. Andrew Lee. He's founding chairman of the Blanton Eye Institute, Department of Ophthalmology at Houston Methodist Hospital in Houston, Texas. He is a professor of ophthalmology, neurology, and neurosurgery at the Weill Cornell Medicine at Methodist Houston Hospital. He has over 500 peer-reviewed publications, over 400 national and international medical meetings, and more than 15 named lectures to his credit. He's past president of NANOS, and his focus areas include IIH, optic neuritis, and space-associated neuro-ophthalmology syndromes. Welcome, Dr. Lee. We also have Dr. Lulu Bustin, who is a comprehensive and neuro-ophthalmologist at Western University in London, Canada. She did her ophthalmology residency at Western University, followed by neuro-ophthalmology fellowship at University of Michigan in 2015. She currently is associate professor at Western University, responsible for teaching medical students and residents in both ophthalmology and neurology. She is currently the program director at Western University and has many surgical and clinical teaching awards. She has over 50 peer-reviewed publications in a variety of topics. Welcome, Dr. Bustin. And last, we have Dr. Palmaja Sudhakar, who is associate professor in neuro-ophthalmology and general neurology at University of Kentucky, USA. She did her initial training in Shankar Nethralaya, and then she went on to do a neuro-ophthalmology fellowship at Kellogg Eye Center in University of Michigan, Ann Arbor. She also did neurology residency at University of Kentucky. She has contributed to the Shankar Nethralaya Atlas of Neuro-Ophthalmology and Shankar Nethralaya Atlas of Imaging in Ophthalmology. She serves as associate editor in Frontiers in Ophthalmology and also the associate section editor for Novel. She has been the investigator for many Nordic trials, and she has been actively contributing to education programs, including our this meeting over the years. Welcome, Dr. Sudhakar. And with this, I think
Virender, I would like to request you to invite Dr. Daniel first, as per the program.
Yes, sure. We can go ahead. So we'll begin with Dr. Daniel Gold's talk, and it is titled as Another Case of the White Gold Wiggles or Something Scary. Over to you, Dr. Gold, and it will be moderated by Dr. Shankar.
Excellent. Thanks so much. It's lovely to be here. And let me just, if you learn nothing else from my talk today, please learn that if you're sharing videos over Zoom, always click the Optimize for Video Sharing option. It makes a big difference. All right. Hopefully you'll learn more than that, but that's the baseline. Okay, so another case of the white gold wiggles or something scary. Let me just shift into presenter mode here, and everyone can see my screen and hear me okay?
We can hear you okay,
Okay.
but
Can you see my screen as well? Everything's good?
Yes.
Okay, excellent. Great. All right. So, 2017, a 61-year-old woman with depression and migraine presented with episodic dizziness. Episodes were associated with photophobia, phonophobia, and nausea. And the ocular, motor, and vestibular examinations were very normal. However, with video oculography, with ophthalmoscopy, there was a very, very mild little bit of downbeat nystagmus, less than 1 degree per second, teeny tiny, something that a lot of the normal population may have. She was diagnosed with vestibular migraine at that time, and it was thought that the downbeat that she had was probably normal for her. In 2019, she was put on lithium for her depression, aka white gold, and she started having chronic imbalance. And over the next couple of months, she returned to clinic with new oscillopsia. And at that time, she had really, really robust 33 degree per second downbeat nystagmus in room light. This was not just in the dark. This was not just with ophthalmoscopy. 33 degree per second, just sitting there, minding her own business in room light, without any other clear ocular motor abnormalities. There was no limb or gait ataxia, and she had a high-quality contrast-enhanced brain MRI that was normal at that time. Lithium was stopped. In July 2020, she had 16 degree per second downbeat and subjective partial improvement after stopping the lithium. She had a bunch of negative or normal investigations because after 1 to 2 months, the downbeat had persisted. It was not gone. So we did do a little bit more of a workup, thinking that the lithium could have potentially, there could have been 2 hits. And she had downbeat and a cerebellar syndrome that was aggravated by the lithium, but maybe there was something else going on. But at that time, investigations for other causes of cerebellar dysfunction were unrevealing. And she had robust further improvement on 4-aminopyridine, a potassium channel blocker, 10 milligrams 3 times each day. So here are the vertical eye traces of straight ahead visual fixation. The patient taking lithium, it was 33 degree per second. Lithium was discontinued a couple months later, about 16 degrees per second. And then a couple months after that, so the lithium was probably still wearing off to some degree. And she was on 4-aminopyridine, and there was really minimal downbeat nystagmus. And this is a video of her having little to no downbeat nystagmus in primary gaze, although it's important in all these patients to have them look out to the sides, where you see a little bit of right beating and down beating when she looks out to the right. Just a little bit. And when she looks to the left, again, you see this sort of side pocket nystagmus, a little bit of gaze-evoked left beating, in addition to just a little touch of downbeat, but really unrevealing, or pretty unremarkable, but certainly not normal. And over the subsequent years, there was a very slow worsening of gait, and she was found to have mild ataxia, which she hadn't had before. Previously, it was just this downbeat. In August 2023, we decided to go further with genetic testing, and whole exome sequencing revealed a GAA repeat expansion within 1 copy of the fibroblast growth FGF14 gene. So she was diagnosed with spinocerebellar ataxia type 27B, also known as SCA27B. So, or something scary, SCA, SCA, spinocerebellar ataxia. She had no family history of similar symptoms or signs. So I wanted to talk about this disorder, this SCA27B, which probably is under-recognized in the ophthalmology and the neuro-ophthalmology community and the neurology community, and I suspect every community. But when you see a patient with downbeat nystagmus, the timing is most important. And sometimes, although a little bit less common, it's acute to subacute onset. And you should be very concerned when there's an acute onset or a subacute onset of downbeat nystagmus. It is possible, although typically downbeat localizes to the cerebellum, there are some brainstem regions that can give you a spontaneous downbeat. the paramedian tracts, for instance, or you could have bilateral cerebellar pica territory strokes that cause downbeat. Medication toxicity, lithium is a very well-known, well-described cause of downbeat nystagmus. Some anti-seizure drugs with toxicity can cause downbeat. If it's, again, subacute, be very concerned in an older population about a paraneoplastic disorder, small cell lung cancer, for instance, or nutritional, hypomagnesemia, chronic Wernicke's encephalopathy, where typically in the acute setting, you see a spontaneous upbeat. Over time, it can transition to a downbeat nystagmus. It's much more common to have a chronic sort of progressive downbeat and balance syndrome. And you should think about neurodegenerative problems like SCA27B, multiple system atrophy, B12 deficiency, or structural causes like a Chiari malformation, something that's affecting the cervicomedullary junction. So what is SCA27B and why is it important? So it was identified in 2022. So it was identified since the patient's onset of symptoms, which probably almost certainly were vestibular migraine at the beginning, although that little bit of downbeat in her was probably a harbinger for this cerebellar disease. So it's one of the most common causes of unexplained downbeat nystagmus. So anybody who's ever seen a patient with downbeat should be familiar with SCA27B. The genetics, intronic GAA expansions in the fibroblast growth factor 14 gene. It is autosomal dominant, so it has implications on family members. 60% of patients have visual symptoms. This is why we should be aware of these patients. And GAA expansions greater than 250 were found in about 50% of idiopathic downbeat, even non-ataxic downbeat patients. So these big ataxia registries with lots of patients who don't have a diagnosis. Now we're testing these patients, and about 50% of these unknown diagnoses in these registries are now testing positive. And downbeat in up to 40 to 60% of them as well. And so diplopia is very common in these patients. Gaze-evoked nystagmus and downbeat nystagmus is very common in these patients. Vestibulopathy is actually common in these patients as well, but it tends to be mild to moderate and later in the disease. Oscillopsia can be from downbeat, or it can be from this vestibular loss. A saccadic VVOR, which I'll show you next. So this is another patient with SCA27B. The head is still. I'm just simply having the patient follow the lens of the camera with his eyes, and he has a pretty saccadic smooth pursuit. Very saccadic. Pursuit is quite impaired. And he has a slightly less saccadic VOR suppression. So this tells us that the VOR is impaired to some degree, but it also tells us that there's some remaining VOR. So there's a little bit of a disconnect. Typically, pursuit and VOR suppression will be equally normal or equally abnormal. So there's a little bit of a disconnect here. However, he has a really saccadic, visually enhanced VOR. Just simply moving the head slowly is saccadic. And that tells you that there is both cerebellopathy from the pursuit system being impaired in addition to vestibulopathy. So if you see this, think about SCA27B. Think about a condition that I presented last year called CANVAS, cerebellar ataxia, neuropathy, vestibular areflexia syndrome. But SCA27B is very common. CANVAS is much less common in comparison. So what is this? Can you tell by looking at somebody who has downbeat whether it's SCA27B or another ataxia? Not really. Not really. You know that the cerebellum is the problem almost always. But this doesn't tell you that the patient has SCA27B, just looking and seeing downbeat. What about this patient? He's got gaze-evoked nystagmus. Right beating in right, left beating in left. And he's got really prominent rebound nystagmus. When he comes back, that left beating transitions to right beating, that right beating transition to left beating. So he has gaze-evoked and rebound, which again doesn't tell you that it's SCA27B. But how about if I told you that this is an episodic presentation? This patient has been having attacks of vertigo. This is an interictal exam, but another really distinct feature of SCA27B is an episodic presentation. So it's an important new cause of nystagmus and diplopia. So we took our cohorts of patients with SCA27B at NYU and Johns Hopkins of 18 patients. 18 out of 18 had some form of nystagmus, typically gaze evoked, but downbeat was very, very common as well. And if you use the slit lamp, use the ophthalmoscope, you'll see tiny little bits of downbeat in these patients as well. Lots of diplopia as well. A primary gaze or alternating skew, divergence insufficiency, convergence insufficiency, and even two with a unilateral sixth-nerve palsy, which is a little unclear, but seemingly related in some way, although that hasn't really been reported. And so the majority of these patients improved with 4-aminopyridine. So perhaps I think most people here are familiar with divergence insufficiency, convergence insufficiency, but alternating skew is something else to keep in mind. A right hyper in right gaze and a left hyper in left gaze. In addition to a skew deviation that's just in primary, these are all common causes of diplopia in SCA27B or other SCAs. So treatment of downbeat, these patients often have oscillopsia from their downbeat, and 4-aminopyridine has been found to be helpful diagnostically and therapeutically. And giving somebody 4-aminopyridine can be diagnostically helpful. You should have a very strong suspicion for SCA27B if they have a life-changing or significant response. Take-home points, keep SCA27B on your differential for all undiagnosed downbeat patients, even those with downbeat who have little to no ataxia, especially those with an episodic presentation. Very low threshold to treat with 4-aminopyridine. It can be diagnostically and therapeutically helpful, and I am done. So this is all the videos and much more can be found in my collection through the North American Neuro-Ophthalmology Society, the Virtual Education Library, and I will stop there.
Thanks, Dr. Gold. I think that was excellent presentation and very well put these cases. I think this is very unusual cases and we seldom come across. So when do you start thinking about these cases in your own practice? You have seen a lot of them where the window comes that you are going to do workup for the spinocerebellar ataxia after a normal neuroimaging as well as nothing on the brainstem.
Right. Yeah, I mean, typically there's a little bit of midline cerebellar atrophy at some point, not typically at the beginning, but yeah, I mean, our threshold these days when we see downbeat, when we see cerebellar ataxia, very low threshold to give them 4-aminopyridine, and if they respond, we're definitely going to go down that SCA27B pathway. If this has been sort of over years, if there's episodic presentation of it as well, certainly excluding those conditions that are otherwise reversible or treatable, vitamin deficiencies, things like that. We did go through that process, and I think that's important. You don't want to miss B12 deficiency. You certainly don't want to miss a Chiari malformation or something structural, so these patients do need an MRI. But aside from that, aside from sort of first pass, reversible, treatable causes of cerebellar dysfunction, pretty unremarkable contrast-enhanced MRI, then we're having a very low threshold to test for this these days. It's pretty easy to do.
Thank you. Dr. Varshini, you would like to ask anything and add to the discussion?
Yes, I was just inquiring in this particular case, was the genetic testing done because the downbeat nystagmus persisted even after stopping the lithium?
That's correct. Yeah. So this is an interesting case because obviously lithium is well known. She did have that little bit of downbeat previously, but the downbeat got significantly better over time with withdrawal of the lithium, and then the administration of the 4-aminopyridine. But she also progressed over the subsequent years with regard to her balance. And with regard to sort of ataxia developed, and that was relatively new. So there were some red flags that there was something else going on. This is not purely lithium. Lithium should not cause any further progression in balance over years after its withdrawal.
Ramesh, would you like to discuss the case?
Yeah, I just had a wonderful case, Dr. Gold. Lots of teaching points. I just wanted to know, this lithium was started in 2019. After that, probably it's a precipitating factor for this particular disease, which may not have been, which would have been there. Earlier, we diagnosed it as a case of vestibular migraine, and probably that progressed over a period of time. And typically, you see this spinocerebellar ataxia in around 60 years of age. I had one question and one comment. The comment is that do you get this atrophy of the vermis area of the cerebellum in scar cases? If it is, at what stage you see? And the second comment was, as you said, there has to be more than 250 or 300 repeats of GAA sequence in the genetics to come as a, highly penetrated case because it's an autosomal dominant. And probably it might be worth to test the family members, both in terms of probably there could be some preventive aspects like stopping the artificial sweeteners and other things in these cases. I just wanted your comments, number one on imaging and number two on genetic test.
Yeah, so imaging, yeah, I mean, it really depends. As you get later and later in the course, especially as patients start to develop frank ataxia, right? It's not just the downbeat by itself. You're going to see some midline cerebellar atrophy. That's not specific to SCA27B. There's no sort of pathognomonic MRI or imaging finding that tells you this is SCA3 versus 6 versus 27B versus another. But it is something that you see, and obviously I'm always a little biased, right? If you know that somebody has downbeat, you're thinking about the cerebellum, you're thinking about the vestibulocerebellum, you're thinking about these sort of midline structures as well. So we're a little bit biased, looking very specifically for atrophy in that region. And yeah, so it's been thought that typically 250 or greater than that repeats is probably pathogenic, but we're definitely finding patients in the 200 to 250 range as well who have downbeat. Yes, we have a genetic counselor who's an ataxia specialist who's meeting with family members and having those conversations because it is autosomal dominant. The problem is that in 2025, we don't have any really guidance, concrete guidance to give those patients or those family members, right? We don't have a cure for SCA27B. We can't tell the family member who has 250 repeats but hasn't manifested to do A, B, and C to prevent it from happening or to mitigate the symptoms. So it's a complicated situation.
Yeah. And one more for the teaching purpose, I just wanted to ask is, whenever you see a downbeat nystagmus with imaging being nearly normal, and also you see an ataxia, your battery of investigation starts with vitamin levels checking, that is vitamin A, B1, B12, and E, and then probably some metals like zinc and ceruloplasmin. And I also saw you do all Mayo Clinic anti-neoplastic panel. Could you throw some light on that? Because when the patient comes tomorrow with the downbeat and ataxia, what are those tests? It's mandatory. I just wanted to know. Thank you.
Yeah, I mean, nothing's mandatory. This is tough. I mean, my cerebellar blood tests collection is like a snowflake. It's different in every single patient I've ever ordered it on, probably. It's not just 20 little boxes that I click on. There are some standards, certainly B12 and things like that. But it really depends on the patient. It really depends on the timing. It really depends on the context and the circumstances. Do they have a cancer in the background, right? I would have a very low threshold to get a Mayo movement panel. There are specific Mayo panels, and the movement panel is the one that's a little bit more specific to the cerebellum and these ataxias. Anti-GAD, anti-glutamic acid decarboxylase, is a big one that is treatable. And that is part of the Mayo panel. You can get that independent of the panel as well, but I would definitely encourage people to get anti-GAD in addition to the other in these patients, because sometimes that is a more prolonged course. But again, the timing is most important. Acute, subacute, be very concerned. Think about cancer, think about paraneoplastic. chronic over years. I'm not typically doing a Mayo panel, but she was just a little bit atypical.
Okay, just had one more last question. What are the top 2 causes of spinocerebellar ataxia in your institute? And what are the 2 top causes for downbeat nystagmus in adults in your institute?
I mean, I have to say SCA27B, SCA27B, and more SCA27B for both of those. Yeah. But 3, SCA3, SCA6, they're up there as well. But 27B, we're just seeing positive result after positive result after positive result. So it's become #1 for all those categories.
Thank you very much.
Yep.
And thanks, Dr. Ramesh. I think there are a couple of questions here quickly in the chat. Dr. Conblath asked that you note that it is autosomal dominant. How often is it spontaneous as your patient seemed?
Yeah, I mean, I guess, and I had a little one more slide, sort of fun facts, genetic facts, but I would also recommend, again, genetic testing should be considered in cases without similar symptoms in relatives because of the possibility of newly expanded repeat disorder, de novo pathogenic variants, recessive inheritance, which isn't the case here, misattributed paternity. So I don't know the number, the percentage there, but it is definitely worthwhile thinking about even in the absence of a family history.
Thank you. Might be we are running a little late, but quickly, if this question might be important for everyone, that can you review your bedside technique for enhancing VOR suppression? Might be good for everyone.
So got it. So smooth pursuit. So the head is still, then just the eyes are moving. VOR suppression, it's a combined eye-head movement. So everything's moving together. So you can do a little dance with the patient. You can have them just hold their thumb out in front of you in your chair and just simply rotate them. That's the easiest thing to do. And so those are the methods that I would recommend for testing VOR suppression.
Thank you. And the last, Dr. Ambika wants to ask that how long do you put them on treatment if they have episodic DBN only?
Yeah, it depends. I mean, if they have episodic downbeat from SCA27B, then oftentimes it's going to be lifelong. You take them off of it and they're going to go back to where they were. So not a short-term med.
Thank you. Thank you, Dr. Gold. We'll move on to the next case. That will be by Dr. Wayne Conblath, and he'll be speaking on double and nothing myasthenia during pregnancy. Over to you, Dr. Wayne.
Thank you. And there we go. There. Great. Thank you very much, and thank you for the invitation to do this. It's always a pleasure and always fun to see a bunch of cases. Not sure about Sunday morning, but it's always fun to see a bunch of neuro-ophthalmology cases. So let me start. This was a 38-year-old woman who had double vision and blurred vision, and we saw her in the emergency room initially. And she came in, she was 11 weeks pregnant. She had 4 days of what she said was progressively worsening blurry vision. She noted an inferior visual field defect, and she also noted monocular and binocular diplopia. And she said that her right eyelid was a little droopy and that these things were all new. She had headaches. They were not positional. There was no pulsatile tinnitus or whooshing. She had no visual auras, and she was not on any medications for her headaches. And she has a history of obesity, tobacco use. She had a gunshot wound to the head in 2018. She had obstructive sleep apnea and asthma. And from the gunshot wound to the head, she had a traumatic optic neuropathy at the time. And about 2 years later, in 2020, she had strabismus surgery for the diplopia from that. She also has a history of glaucoma and had a laser procedure. And on examination, She's 20/50 in the right eye, 20/20 in the left. There's an afferent pupillary defect in the right eye. Slit lamp exam was unremarkable. Her motility, as you can see here, she's a relatively concomitant right hypotropia and an inconcomitant exotropia worse on left gaze. And here is her OCT. And again, you can see she has marked pallor in the right eye. She does have increased cupping, right greater than left, but has significant pallor distributed in essentially around the whole optic nerve in the right. And here is her visual field. There's some changes superiorly in the left, probably not very significant, but you can see she has a very clear inferior altitudinal defect in the right eye. And then I'll also have you note, we always do foveal sensitivity. So she has a normal foveal sensitivity on the left of 38 and a foveal sensitivity of 32 on the right, which is a nice double check of her acuity that matches her 20/50 acuity. And so she got a CT because she's in the emergency room. And you can see on the screening kind of scout film, there is high density in her nose and in what almost looks like the apex. And when you look at the axial, you can see the streak artifact and the high density. And this is bullet fragment that's kind of right at the apex. And there's some additional bullet fragment along the medial wall of her orbit. And you can also see that there is, we noted on that kind of scout film, there is bullet fragment in the nose. This is a bone window, non-bone window, and you can see the streak artifact. So now what? She's complaining of new diplopia. She's complaining of blurred vision. On examination, she has a right partial third nerve palsy, and she has a right optic neuropathy. When we look at her imaging, there's a bullet fragment in the apex, right where the optic nerve is, right where the third nerve is. And so the question in this woman was, who's causing what? What do we do next? How do we explain everything? Is she just having new headache and her previous diplopia is decompensating? What's going on? And, do we blame this all on the gunshot wound? Or do we do any other testing? Do we think of any other possibilities for this combination? And what you also have to kind of remember is a bit of the timing. The gunshot wound is 2018. Her diplopia, her strabismus surgery is 2020. We're seeing her, we saw her last year, 2024. So we're seeing her 6 years after this. And so the question is, and this is a red herring, which is a term to mean a distraction. And I did, for those of you who like these things, red herrings, the term came from a strongly scented herring that was used to train hunting dogs. So is the gunshot wound a red herring? Is there other red herrings? And so if you think about this lady and new onset diplopia with any pattern, is there anything else we should do? And so we ended up getting an acetylcholine receptor antibody titer, binding titer, and it was abnormal at 0.12. Normal is less than or equal to 0.02. I'll give a shout out to John Chen at Mayo. Mayo is where we send our titers. I think they're the most accurate lab. We do binding. I do binding only. I don't bother with blocking, or now I even forgot there's a third one. Somebody else can toss in the name. Binding, blocking, and modulating, I think it is. I don't bother with those because their accuracy is not very helpful. The binding is the most accurate. And so if I can have a single test that gives me the best accuracy, I'm going to do that. And so the diagnosis now in this woman is ocular myasthenia gravis, and accounting for her ptosis, her new diplopia, even though it's in a third nerve pattern. And the point there is myasthenia gravis can produce a pseudo internuclear ophthalmoplegia. It can look like a skew deviation. It can be a single muscle, a single cranial nerve pattern, and that's what we had here. And remember her complaint of blurred vision, but don't forget we saw marked pallor in that nerve. That was old. That goes back to her 2018. And, in talking with her, what I think happened is she developed the diplopia, and now she's seeing, as opposed to fusing her 2050 and 2020 eyes, she's now looking with one 2020 and one 2050 eye. And she's like, oh, one vision's blurred, one is not. And so I think it was just long-standing blurred vision that she's became more aware of with the new diplopia. And so this is, as I said, new onset ocular myasthenia gravis and long-standing optic neuropathy. And is, when you think about it, with a gunshot wound, that bullet isn't moving. That bullet has been there for 6 years. It is fibrosed in. It's not going to cause a new cranial neuropathy 6 years after onset. And, why do we care? Because she is 11 weeks pregnant. We have newly diagnosed her with myasthenia gravis. And this is critical for our OB colleagues because pregnant patients with myasthenia can have preterm labor. They can have a difficult delivery if they generalize. Ocular myasthenia gravis can worsen with intravenous magnesium if you were to have preeclampsia, so they'd want to know that. Anesthetic agents can worsen myasthenia gravis. And then finally, there is neonatal myasthenia gravis, where the mother's antibodies are in the baby, and the baby has weakness. And this occurs in up to 20%. And obviously being aware that you might have a baby with transient myasthenia, or a neonate with transient myasthenia gravis is very important so that people can be prepared ahead of time and be thinking about these things. And so that was the case in what we kind of ended up thinking through and trying to figure out and help this lady kind of long term with identifying a problem before she had a problem during delivery that nobody would have been thinking about. Any comments from the panelists?
Thank you. Thank you, Dr. Conrad. That was very interesting. I would like to begin by a few things from my side and then take in things which have come up in the chat box. And Dr. Shankar is there, who is going to moderate your session in the case. So, Dr. Varshini, you want to start?
Yeah. So I first wanted to know what was the squint surgery which was done, because I would really be thinking of decompensation as my first differential diagnosis, because obviously before the trauma she must have been a patient with fusion.
The surgery was done elsewhere, and so we never got the details of it. And we wondered about that also. But she was very clear. I had surgery in 2020 and I've been single for 4 years until just now. And then when we looked at the pattern, and this is always, to be honest, I hate looking at muscle patterns after somebody's had strabismus surgery because it can, it's hard to sort out. But kind of, as you saw from there, there's an incontinent, there was ptosis, an incontinent exotropia, worse on the left gaze, and then the hypotropia was relatively common, but so I kind of said that looks like a partial third to me, as opposed to a decompensated or, decompensated post surgery. And the other thing would be is the ptosis, which obviously wouldn't expect after is a follow-up from strabismus surgery.
Was there any fatigability or variability in the measurements while you were measuring her?
There were not, and I freely admit we didn't measure her, 3 times. It was just we measured her. The measurements were stable, and one thing which we didn't do, which we could have done, is we did not do a rest test for the ptosis. That would have been rest test or ice test. That would have been useful in retrospect.
So, did you go ahead for the antibody testing based on as a panel of workup, or what were your thoughts about getting the panel of antibody testing for myasthenia?
Oh, so we were, so we looked and we said new onset ptosis, new onset diplopia, couldn't blame it on the gunshot wound, wouldn't have expected ptosis with the if her strabismus surgery had decompensated. The pattern looked third nervish. She had imaging, did not have an aneurysm or a tumor, other cause of a third nerve palsy. So we said myasthenia is definitely possible. And then we just, as I said, we just sent the receptor antibody. I send the single test. I think, and maybe John Chen could help. I think Mayo sometimes add, if you do the receptor antibody, they sometimes add, and if it's positive, they sometimes add the other tests. But if you say, what do I order? A single test.
And Wayne, I can at least kind of chime in on what Mayo does. Essentially, they do the binding is the best, but they do often the modulating and blocking, and then they reflex a MuSK if those are negative, although obviously MuSK usually isn't just in the eyes. But there's a lot of discussion in the chat about LRP4. I'd love to hear your thoughts on that.
I mean, I think LRP4 in ocular, I haven't done it. I think I've done it once. And we frequently, so I've seen over 500 ocular myasthenic patients. I've had 2 MuSK positive patients. I haven't had LRP4 patients, partly because I haven't checked, but I'm a simple person. If I think you have myasthenia and your receptor antibody is negative, and we know the receptor antibody picks up 71% of ocular myasthenics, I'm going to give you a treatment trial with Mestinon. If the treatment trial is positive, i.e. it resolves your symptoms, I'll call you presumed ocular myasthenia and go from there. If the treatment trial is negative and I'm still concerned, I'm going to go to a single fiber EMG, which gets me 95% or 95 to 98% of cases. So, I guess somewhere in there, I'd do an LRP4, but I just, it's I think a little like the MuSK. I'm not sure its utility in the pure ocular patients, we're seeing.
Wayne, I was initially pretty excited about LRP4, but our group did an interesting study where they sent 50 myasthenics for commercial testing for LRP4 and about 100 controls. And just out of chance, the myasthenics were not positive for LRP4, and then 4% of the positives were positive. 4% of the controls were positive.
Controls were positive.
And so they went fishing for LRP4, found no actual real fish, and caught a bunch of red herring.
That's hilarious.
It was interesting. So actually, we at this point we're not doing LRP4, maybe until the assay gets better. But we're not doing send outs of LRP4, and at Mayo we're currently not offering it.
Yeah, my understanding is in generalized myasthenia, it would only pick up a couple of percentage points. And so I think its utility in our ocular, as you notice, yes, just not there.
Thank you. That's interesting discussion. I think that brings to us the question that Dr. Bustin is telling, that thinking about the health cost rather than individual patient, because it is more cost effective to do ACH receptor antibodies first and then only proceed to MuSK and LRP4 if there's high suspicion. Yeah, but I think I would like to ask other panelists that what is their practice? Would you get both ACH receptor and anti-MuSK together, given that they can have different implications on treatment?
I also wanted to ask, what is the role of repetitive nerve stimulation test, because we don't have access to single fiber EMG so readily.
So repetitive nerve stimulation, which is is easily accessible. The problem is it only is abnormal in about 40% of ocular myasthenics. So again, it gives you some, but I tend not to do it. I do have single fiber available. If I did not have single fiber EMG, and actually, again, my current practice is I tend to just do a treatment trial of Mestinon and go from there. I don't, it's hard to hurt somebody with Mestinon, and if somebody, and I think is very good at lifting lids, and we've looked at this, about 60% of our ocular myasthenics improve with Mestinon. So it's not 100%, but it's not bad.
Thank you. I think we had one more query. What was the reason for the inferior field defect?
Yeah, and that was just her long-standing optic neuropathy from the initial gunshot wound, and she had a diffusely pale optic nerve. Her acuity was down to 20/50, and so
Maybe
I don't know why the optic nerve does this, but a lot of times it seems if you damage the optic nerve, and you either get a central scotoma or you get an inferior altitudinal defect. And I assume it just has to do with the, vascular top bottom half of circle of Zinn and Haller. But that was from her original trauma.
Thank you. Thank
You're
you,
welcome.
Dr. Conrad. So I think we would move ahead with the next case, which is again an interesting case by Dr. Bart Scholes, and it's titled "The Tongue or the Stem." Over to you, Bart.
Okay, thank you very much for inviting me. Hold up, I'm gonna make sure that can you see my?
We can see your
slides?
video, but not the slides as of now.
Hold on.
Not yet.
Okay, you see it now?
Yes. Yes. Still not in the slideshow. Yes, now it is.
Okay. All right. Thank you so much for inviting me. It's been a very good discussion so far, and I think this actually dovetails very nicely with Dr. Kornblatt's case because there are some of the similar problems that come up. But this is the case of a 62-year-old woman who presents with intermittent binocular oblique diplopia. It's a longer case that involved at least 3 neuro-ophthalmologists and other specialists over 6 years here. But she first presented in August 2019. At that point, reported 2 to 3 years before, had intermittent binocular diplopia while watching TV. And she was prescribed sort of a slightly oblique diplopia, but she was prescribed a horizontal prism. And actually, mostly you will see it's a horizontal kind of problem. So she was prescribed in prism, 4 base out, right eye, in partial improvement. She experiences intermittent binocular oblique diplopia at distance only, no symptoms at near, there's no history of ptosis, dysphagia, or dyspnea, no child history of strabismus or diplopia. She does have a history of refractive error, diabetes, hypertension, hypothyroidism, chronic kidney disease, migraine, and mild liver disease. And she's on insulin as well. She is a former smoker, but not currently. So her afferent exam was normal. On the external appearance was notable for some orbital fat atrophy, and she was noted to have increased lid creases. And at that point, in August 2019, she had a -1 AB duction deficit in the right eye and a mild and concomitant esotropia, most pronounced in right gaze. So an MRI was obtained as part of a workup, and I will just scroll through it once here, but it was called normal at that time. So unrevealing for any cause of diplopia or strabismus. All right, so at the time, it was thought maybe she has a microvascular sixth nerve palsy because she has vascular risk factors, but the chronic course without improvement was considered atypical. Or it was felt she could have sagging eye syndrome, but fits with the patient's demographics and the presence of prominent fat atrophy and the chronic course of the symptoms. But since it was an incomitant esotropia, this was felt to be a diagnosis of exclusion. She was prescribed additional prism. She returned 3 years later, describing that diplopia had worsened and was now more horizontal. And she also described these daily brief episodes of numbness around the right eye, lasting about 2 minutes at a time, and involuntary paraocular spasms. She had had additional workup, and myasthenia labs had been obtained in 2019. At this point, she got a repeat brain MRI that was also unrevealing. But her strabismus had progressed. So she now in the right eye had a -3 AB duction deficit and a -2 AB duction deficit in the left eye. And her esotropia was much greater, still incomitant, and greater in right gaze in June 2022. So she had additional workup performed, including myasthenia testing. And so we talked a little bit about the ACH receptor antibodies. The binding one, which is the most sensitive, the best one really, and the blocking one were negative, but she had slightly positive modulating antibodies. And she had a single fiber EMG that suggested a postsynaptic disorder of neuromuscular function based on abnormal jitter on the single fiber. She returned in November 2023, describing the diplopia as much worse. Her prism requirement has increased. She's now patching one eye most of the day, and she's developed right facial weakness, and there's slight weakness of right eye closure, which irritates the eye. She again has another MRI that's unremarkable. She's tried on pyridostigmine, prednisone, and mycophenolate and has no benefit from these medications. At that point, she has a -4 AB duction deficit in the right eye, -2 in the left eye. And their esotropia, as you can see, has gotten even larger. It's quite huge at this point. And it's less incomitant than before. So she was seen in addition to neuro-ophthalmology by neuromuscular clinic, and she had a workup. Initially, the working diagnosis was myasthenia because of the slightly positive but atypical antibody pattern. She had no thymoma. She had, however, no response to myasthenia gravis therapies, and an additional EMG of the face was performed and showed that the facial nerve palsy was actually neurogenic, and there was a synkinesis. So now she was diagnosed more with a progressive cranial neuropathy syndrome of unclear cause of at least the sixth nerve and seventh nerve, and people wondering about the third nerve being involved. So another detailed MRI with contrast and thin brainstem cuts was obtained that was unremarkable, and she had an extensive workup for autoimmune causes, sarcoid-Lyme, IgG4 related disease. At that point, she presented to my clinic. And shortly before she presented, she had described a self-limited episode of a swollen lip. And she provided some pictures of when the lip was swollen. It was swollen for just a couple of weeks. So I wondered about this diagnosis of Melkerson-Rosenthal syndrome, which is a rare neuromucocutaneous disorder. with a diagnostic triad of lip swelling, third tongue, and facial palsy. Strabismus is rarely described in these cases. This is her tongue. I guess you can sort of hallucinate that maybe there's slight furring, but it's certainly not a prominent feature. But I did go on to obtain a lip biopsy that did not show any granulomas. So this is considered to be often an inflammatory granulomatous pattern inflammation. The lip only had sort of chronic non-specific inflammation. Her strabismus had progressed. She now had a -5 deficit in her right eye. So she couldn't even get to midline, -2 in the left eye. So you can see that this was the most prominent here in right gaze. And then up gaze and down gaze were relatively normal. Left gaze was normal here. This was the facial weakness, so it's relatively mild, but you can see this with gentle eye closure, and then with more prominent eye closure, there's a little bit of a weakness of eye closure, and you can see that the mouth contracts. So there's a synkinesis here with eye closure, which is a telltale sign that we are dealing with a neurogenic facial palsy, peripheral type facial palsy. So maybe ask yourself now, where does this problem localize, and what additional studies might you get? I mean, she's had extensive workup over 6 years at this point, multiple MRIs, lots and lots of labs. But I think maybe we'll leave the discussion to the end unless somebody wants to chime in here. So I did get an additional study. And the study that I got was a CT of a temporal bone, because I thought maybe there's something that is pressing on the bones, and that could be affecting the facial nerve in its course through the inner and middle ear, and maybe is affecting the sixth nerve along the clivus, and maybe that will be missed by the MRI. That's not what I found, but that was the additional study and the reasoning for the additional study that was obtained. And so here's what we found then on the CT of a temporal bone. I'm trying to show a free subshot. There's a curvilinear appearance here of a vessel that is in the dorsal pons here. And so this is a picture here of the pons, again, to remind you of the anatomy. In the dorsal pons, we have the facial nerve nucleus and the abducens nucleus in vicinity to each other. And the facial nerve travels around the fascicles of facial travel around the abducens nucleus and create the facial colliculus. So I believe that this is the localization here for this patient's syndrome. And the cause is a vascular sort of malformation. So as a brief review here, there are a number of syndromes of the pontine tegmentum here that are of neuro-ophthalmic interest. So you can get the abducens fascicles involved, and then you will see what looks like a peripheral sixth nerve palsy. There may be additional neurological findings from the brainstem. If a nucleus is involved, however, you should see a lateral gaze palsy. Because of the vicinity to the MLF, you might see a 1.5 syndrome where there's a lateral gaze palsy and an internuclear ophthalmoplegia. If there's more of the motor fibers involved, you could potentially see a crossed brainstem syndrome, which has been described as the Fauville syndrome, with an ipsilateral facial palsy and a lateral gaze palsy, or an abducens nerve palsy, and a contralateral hemiparesis. The 8.5 syndrome is where the seventh nerve is added to 1.5 syndrome, and there's lateral gaze palsy and ion facial palsy. But I think what we're seeing in this case is it's called the facial colliculus syndrome, where you see a facial palsy and a lateral gaze palsy, but without the INO. And so the diagnosis here is that this is a presumed pontine dural AV fistula. Not many cases are reported of this, but I've talked with a couple of senior colleagues who say that they have occasionally seen this problem pop up in this location. She is currently awaiting an additional angiogram to fully confirm the diagnosis. And I'm not sure what treatment we'll be able to offer her, but I think we need to confirm it. I was hoping she would have it by the time of his presentation and was delayed. But I still think that this is the correct diagnosis here, and I welcome any comments. In retrospect, she had all these MRIs, she had multiple MRIs obtained, and they were always called normal. But several of them were done without susceptibility weighted imaging. On a study, I looked back several years earlier, you could see that there was an abnormality on the susceptibility weighted imaging that was not called out by radiology, but that was in the correct location for this problem. So this was also a case with multiple red herrings and false positive myasthenia testing in terms of both antibodies and single fiber, and this lip swelling, which I don't have a good explanation for. But I think that this is ultimately the diagnosis.
Thank you, but I think it was very challenging case. Multiple workups done over the years, and as everybody would have expected, something in the brainstem, but couldn't be picked up early on. So, could you project that image of the slide where you have the brainstem lesion again? So, as you beautifully highlighted for all the audience worldwide, that there can be multiple syndromes, but and we do have the 6th and the 7th running together. So that would always be one of the important differentials that would come in localization.
It's not sharing well. I don't know. Oh, it's because I'm at the end of slideshow here.
Yeah, no problem.
Yes. Okay. Do you see it now?
Yeah. So is just because that it's very tiny lesion that we couldn't pick it up early on is what I was wondering, and would require multiple thin sections and a very strong suspicion, maybe avoided
Yes.
than the radiologist.
And I didn't even, I have to admit, I mean, I thought about a brainstem localization, but I said, after 4 MRIs, it's with thin cuts and contrast, it was unlikely that another MRI would show something. And so I think it was lucky that this was a calcified lesion, and maybe because she has a history of diabetes with a tendency to calcify. But I think what I was really looking for something maybe in a bony area here, which I think that is an important teaching point, right? That we now tend to often favor the MRI. It is much better for soft tissue imaging, but the CT still plays a role for bony abnormalities. And that can be the case for the orbit, and that can be the case especially also for the temporal bones. Now we have this new CT technology that is emerging, so not used in this case, but a single photo counting CT, which is going to even further revolutionize the application of CT, including, I believe, in neuro-ophthalmology, because we will have much better detailed resolution of anatomic structures with CT comparable to MRI now. But that's for the future.
Yeah, thank you. Thank you so much, Bud. Dr. Virna, you have any comments to add?
No, I think a very interesting case and insightful, and I think it shows us at times we need to go back to the basics and remember that we still have simple investigations that we really need to fall to. I was just wondering, earlier when all your MRIs were negative, would you have liked to do a lumbar puncture to CSF analysis to rule out other malignancies at this age?
Yes, I think that a lumbar puncture is a reasonable consideration. I think that if 6 years down the line, some sort of neoplastic meningitis would be not a strong consideration at this point. No, those usually are syndromes that progress subacutely on the order of weeks or months. could you find maybe some low-grade inflammation and maybe a case of chronic sarcoidosis or something like that? I think that's possible. The peripheral nerve palsy, the facial nerve palsy appear to be peripheral, right? As was evidenced on the second EMG and the presence of synkinesis. And therefore, I was more interested in pursuing the course of a facial nerve beyond the brainstem and the CSF space further out into the periphery to see if there was maybe something there. And maybe it was some sweeping up the abducens nerve or nerves, maybe the third nerve as well. There was the adduction deficit, which in retrospect was a gaze palsy, not a third nerve palsy. But that was an incorrect reasoning, but it was lucky.
Yes, and would you like to rule out neurodegenerative with all these different constellation of symptoms and?
Yeah, I wouldn't know what neurodegenerative cause here to consider. I think that most of the time, so progressive supranuclear palsy, for instance, is one of these causes of so brainstem-related degeneration. It is, I think you would see other things on a neurological exam, especially 6 years down the line, and I wouldn't expect it to be so asymmetric. I don't know. I was certainly puzzled when I first encountered the patient here.
Yeah, thank you. Anybody else on the panel?
I think Luciano has an important point, which he says that there's maybe the lesion is expanding. That's why possibly there's worsening of symptoms. Maybe that there was a small recurrent bleed. That's why the diplopia had worsened, is what he's trying to say. What do you think, Bud?
Yeah, I don't know that. So the way that these dural sort of AV fistulas or parenchymal AV fistulas work is they cause probably venous congestion. There's no evidence of a discrete hemorrhage, but it's a vessel that we're seeing, and so with a linear course. But I think that it is causing progressive probably ischemia and some sort of gliosis or something like that of the brainstem area around it, and that does progress over time because the area is either not getting good vascular perfusion or vascular drainage, and that is causing the neurological impairment. I don't know that there's a good, easy way of fixing it. We thought about maybe irradiating, but the radiation could potentially cause more problems in that area. Yeah.
Thank you. Thank you so much, Bud. I think thank you for the wonderful case. And in interest of time, we will move in with the next case. There will be a small change. Dr. Andy Lee has to take a flight, so he's in transit, and we'll request him to take the next case. Over to you, Andy.
Thanks so much for having me. My little talk is, can you teach an old dog new tricks? And probably you've guessed I'm the dog in this story. So this is a 45-year-old Hispanic male who had binocular vertical diplopia after motor vehicle accident and a slight head trauma. He had new diplopia on gaze to his left. His past medical history was significant for well-controlled hypertension, hyperlipidemia, and obstructive sleep apnea. And he told us that in childhood, he had this eye abnormality, which he'd been diagnosed with at age 4, which caused a strabismus, but he was not symptomatic from that childhood. These symptoms were after the car accident. And I'll show you the pictures of what he looked like, but basically he had lid fissure narrowing on adduction and widening in abduction. He looked straight in primary position and measured straight. He was orthotropic in primary. He never received any amblyopia or strabismus surgery treatments in childhood. He was not diplopic in primary, and his symptom was only when he looks to the left. His afferent exam, including his visual acuity, was 20/20. There was no RAPD. The pupils were normal. The lids were normal. The rest of the exam was basically normal. And then I'll show you a picture of his motility. But the thing I want you to pay attention to is he had this abduction deficit with a downshoot vertically in abduction, abduction. A CT and an MRI of his head had been normal at the time of his initial head injury in the emergency room. And so here is his eye movement. And maybe while you're thinking about it, I can just walk you through it, and maybe the panel could think about what is weird about it. So in primary, he looks straight. In right gaze,
Can we hear Dr. Lee?
We can't hear Viru.
Yeah, I think his internet is unstable. Andy, we can't hear you. We'll have to type in this.
are you there still? Could you still see it?
Yes.
Me back online?
Yes.
Something happened there. So I think I ended here. Did you want to have someone comment, Virender, or do you see the slide there?
We were on this slide and you were telling that you will let the panel think through.
Yeah.
and
So
we
does
lost
anyone,
you.
do you want to comment on that right there, or?
Dr. Pradeep Sharma is there. He is there to moderate your case. I'll request him to proceed further.
Yeah, so we see a limitation of abduction, abduction in the left eye.
Yes. And do you have any comment about what this childhood strabismus probably was?
Yeah, so that was probably an ortho-DRS, ortho-Duane's retraction syndrome.
Yeah, so there's nothing fascinating about that.
Yeah.
Ophthalmology saw him and said it's a Duane's type 1, as Pradeep said, and he was straight in primary. Presumably that's from the normal co-contraction of the medial rectus and the lateral rectus muscle. The lid fissure narrows in adduction in the Duane's and widens in abduction, and the globe retraction, and all that's just Duane's. He has this abduction deficit, presumably because the mechanism is the lateral rectus is not firing because you don't have a sixth. And that was, you're just born with that. So then because he was in this car accident and he had this Duane's before, the outside neuro-op told the patient, you're faking and you're just trying to get money from the Duane syndrome. And so he came for a second opinion because he said, look, I'm not trying to get any money. I just want to know what's wrong with me. I said, I thought you said you had this Duane syndrome. He said, I did have this Duane syndrome, but after my car accident, which I'm in litigation for, I have this motor vehicle accident. So is there anything unusual about the case so far, or is this guy just faking his Duane's?
So the narrowing of the pupil of the palpebral aperture on abduction.
Yeah, so that's interesting. So in a Duane's, you're straight in primary. You get this lid fissure narrowing because the globe is co-contracting medial rectus and lateral rectus. It retracts, and you can't abduct. It's just straight up Duane's type 1. However, the thing that's weird about it is normally when you have a Duane syndrome, all the problems occur in adduction. The lid fissure narrows, the upshoot and the downshoot occur in adduction. And just to remind you what was weird about his case, he was complaining about diplopia when he looked to the left. So when he's abducting this eye, that's when the vertical deviation occurred. His downshoot is occurring in abduction, which is kind of strange for a Duane's.
Correct.
So then I think you have a comment there in the chat about could it be restrictive? So what do you think, Dr. Sharma?
Yeah, so it could be some in the trauma, if he has had a fracture on the medial wall, then there can be an entrapment of some fibers or the medial rectus itself, which will cause a leash effect.
Yeah, so that's when I was a resident, this is what I learned from my professor, Dr. Van Noorden. He said, well, this downshoot and upshoot thing is a known finding of the Duane syndrome. It can be a leash effect where it pulls and then the downshoot occurs because you're jerking back on the head of the dog who's on a leash, or it could be a reverse leash, which occurs in the opposite direction. Rather than attempted adduction, it occurs in abduction. And this leash and reverse leash effects are known in Duane's already. And so this vertical deviation created by the leash, a restrictive phenomenon, is what's thought to cause the downshoot and the upshoot in Duane syndrome. And usually that occurs in adduction. However, as was alluded to, a CAT scan was performed because it showed that he has this fracture here from his trauma, and he wasn't trying to fake for his car accident. He actually had a restrictive myopathy superimposed on a Duane syndrome. So I guess you can teach an old dog new tricks, because when I was showing the resident and the fellow this case, I said, oh, this guy's just a Duane's. And then I said, but normally you see the leash effect in the adduction position, but this was an abducting vertical deviation. I said, oh, you see that sometimes. That's called the reverse leash effect. And the resident said, okay, but why has he got this new symptom? He doesn't seem like he's faking. Okay, let's do a CAT scan just to prove he's not, that he's just trying to get money, and it showed the fracture. So always believe the patient. So I guess you can teach an old dog, me in this case, a new trick, which is the reverse leash effect. In this case was probably from medial wall restriction fracture from his trauma. His head MRI was really normal because, as you know, it's not that great for fracture. And the CT non-contrast of his head did not pass through the medial wall, and therefore the fracture was not read on that CAT scan either. I turn it back over to you, Virendra and Pradeep, and see what the panel has to say.
Yeah. So
Yes, go ahead.
Andrew, the basic thing that we say leash effect is always, like in this case, you are having an abduction deficit, but the problem lies in the on the opposite side. It is still a leash effect. It is still a normal leash effect, not a reverse leash effect.
That's correct, but the mechanism was not congenital, it was acquired. That is exactly right.
So it can be an acquired leash effect, but here it's still a leash effect and not a reverse leash effect. A reverse leash effect would be if it is having a problem on the same side as the limitation.
That's
For example, yeah. So if there was a fibrotic band on the lateral compartment of the orbit, and that was causing a problem, and when will it cause? It will usually cause when the problem is going from forward backwards, like what you showed here in that picture, that the leash is there on the same side, then we call it a reverse leash effect. But in your case, it is an inverse Duane's.
Yes.
Not a reverse leash.
That's totally correct. I was totally off base on this. I thought, well, that happens sometimes. So with the leash, like the leash on the dog, when the dog tries to run away from you, the head will jerk back. That's the leash effect. But if the dog tries to run towards you, you can also get an effect, which is a reverse.
So that's
effect.
then correct.
But in this case, the guy actually had an acquired medial wall fracture, which was causing a restrictive strabismus. So you're right, Pradeep. It really was a leash, but not from what I thought it was. And the first neuro-op was shocked. I had to write to the first neuro-op and tell the guy, hey, this guy has a fracture. And he wasn't faking for money. And I don't know if you guys have seen this before or not, but in the United States, which is a very litigious country, people try and sue people for stuff they were born with. And this Duane syndrome is a notorious one because it gets misdiagnosed as a sixth nerve palsy, and then the person tries to get money for double vision that they never actually had. But in this case, it was the reverse. He was not faking it. He was telling the truth.
Yes. And your case is really interesting because the abduction deficit would usually be there in a Duane's. But in your case, the catch is there that it's a downshoot, and sometimes there may be retraction, which is the point which will be giving you the diagnosis that there is a restriction, acquired restriction on the medial side, which is another problem. So it's a wonderful case.
I mean,
very
the
interesting
outside
case.
doctors said it was Duane's. The neuro-op said it was Duane's. but they totally ignored the point you just made, which is the downshoot is an abduction in this case. And if he didn't have Dwayne's, you would not be doubting this guy is real at all. It's only because he told the truth that I really did have this when I was a kid.
Really interesting case, yeah. So there are two problems in the same person.
Yes, and so sometimes the old dog thinks he's so smart by calling it reverse leash effect, but it was not that.
Yeah,
It
it's
was
not a
a
reverse
real
leash.
leash effect,
It's a regular
but
leash.
from
Yeah.
a totally different mechanism than I had told the resident and the fellow. So the old dog had to really learn a new trick here.
So that's wonderful. Yeah.
Thank you.
Yeah.
Just to make
Thanks
a
so
couple of
much.
points, maybe to the discussion. I think we all have seen a couple of cases of inverse twin following trauma, and it also highlights, this case also highlights that CT would be important in these patients, and MRI may or may not reveal everything, but CT could be useful. And second thing, maybe just to add to like Dr. Pradeep Sharma was saying, usually my understanding is that if the muscle gets entrapped in the interior 1/3, the likelihood is that we will have a regular leash effect. But reverse leash effect happens when the pathology is towards the posterior 1/3 of the muscle length. And in the middle portion, it can be either or even both. There could be limitation of duction of the agonist as well as the antagonist. So just wanted to add that point to the discussion.
Yeah, totally.
And
It's
another thing,
completely mechanical. It's not neurogenic at all. It just gets stuck. So it's completely dependent on where the restriction is. Virender, you're exactly right. It's not neurogenic. It's mechanical. It's a literal leash.
Thank
but
you.
just to add on one more thing, that if you have a sixth nerve palsy and which has caused a medial rectus contracture, and later on the sixth nerve palsy partially recovers, then you may have an abduction, and the contracture of the medial rectus will actually cause a leash effect again. So another kind of presentation would be there as a abduction deficit, but with a leash effect on the medial side.
Yes.
Not
Yeah,
Duane's, but it
I
may be
agree completely. And it doesn't have to be trauma. Our most common scenario for that is they had surgery, like what Wayne Kornblath was saying. Once they have surgery, all bets are off. The motility looks totally weird to you. But our most common cause is an induced leash effect caused by fibrosis, usually from them having surgery.
Correct.
Yeah, I
So
just
that's wonderful.
quickly wanted to add, what Dr. Virender has said, especially, the anterior versus the posterior fibers of, the entrapment of MR. Again, if it is a more volume of the muscle is entrapped, then you would see very classic widening on adduction. But here being, the pre-existing DRS, I think that has been kind of, the concealed, that motility, which we expect in trauma.
That's because the lateral rectus is not firing in abduction because of the Duane's. Yeah.
Yeah, we see the same kind of thing anterior posterior in floor fractures, where it depends on which part of the inferior rectus muscle gets restricted. So normally it's just.
I think we're again losing Dr. Andrew.
Yes.
But that was wonderful. Yeah.
Yes, that was wonderful. Thank you, sir, for nice discussion. It was wonderful case. We'll just wait for a few seconds. Otherwise, we will go ahead with the next case.
Well, thanks so much for having me.
Thank you, Andy, and
Thank
have
you.
a safe
Bye.
flight.
Thank you.
We move ahead with the next case that will be by Dr. John Chen, and he'll be speaking to us on an interesting case, double vision, dilated pupils, and a diet pill. Over to you, John.
Great. Well, thanks again for the invitation to be here. These have been some wonderful cases and learning a lot. I thought this was a fun case that I saw had a couple good teaching points that I wanted to share. So this was a 39-year-old male who came in with a 2-day history of dilated pupils, some eye irritation, day of blurred vision, predominantly at near, and then he came in because now he's having double vision, horizontal double vision. Past medical history is just some degenerative disease in the lumbar spine, denies smoking or recreational drug use, alcohol 1 to 2 beers a weekend. Medications uses some really for the degenerative joint disease in the lumbar spine. And he started this Thrive supplement 2 days ago. And this Thrive supplement is, as you can see here, this advertisement. It's there to increase your lifestyle plan and kind of have weight management and cognitive performance and make you a better person. Look at how happy these people look. So we looked in there because, he said he's got dilated pupils. They said, could there be something there that kind of explains it? And you can see here there is citrus aurantium, which contains synephrine, which acts on alpha-1 adrenergic receptors. And so this is his exam, and you can see it was 2020. He did have these big dilated pupils right here that did not respond to light or near. And on the motility exam, his motility was full, and he had a fairly comitant esotropia, as you can see here, again with full motility. And so we thought we had our diagnosis. This is a 39-year-old, previously healthy male, now with binocular diplopia, mydriasis. He had started this Thrive supplement 2 days prior, which had synephrine. And so we thought we had our diagnosis. It decompensated foria secondary to pharmacologic mydriasis. So we said, stop the supplement. We'll see you back in a couple of days. So he stopped the supplement, and now we're seeing him 5 days later. And you can see here, he said, Doc, my pupils are still big and I still have double vision. And so this is what we found on exam. Again, you can see here that the motility was fairly full, but he does have this esotropia. And really strikingly, no response to light. And then now I'm having him look at near. So no response of the pupils to near either. So essentially these large pupils. And so the next step is let's go and check, maybe he's got an 80s. So we did dilute pilocarpine, and no response. And then we said, oh, well, maybe he's got just pharmacologic dilation. And so we did a full 1% pilocarpine. You can see the pupils came down super, super nicely. And so this is neurologic, not pharmacologic. It's not, we can't blame it on the medicine if the pupils get that small with pilocarpine. So, what's the differential diagnosis of this patient with double vision in large pupils? And anytime we've got double vision, we always think about thyroid, myasthenia, but those wouldn't involve the pupils. And there's only a few things that actually cause double vision and cause mydriasis of the pupils, which I have here. So we talked a little bit more, and we knew this was some neurologic conditions. We were trying to have something else higher on a differential diagnosis when we decided that the mydriasis was not pharmacologic. He said, you know what, I've been having some tingling of my and numbness in my palm. And we checked his reflexes, and he did have some mild diminished reflexes in the biceps, brachioradialis, and triceps. He had no ataxia. MRI of the brain and cervical spine was normal, and the EMG did show a mild sensory neuropathy. So a diagnostic procedure was conducted, and our diagnosis was a very high GQ1B antibody, positive 1 to 12,800, and this confirmed our diagnosis of Miller-Fisher syndrome. And so that Thrive diet pill was actually a red herring. And then this is that picture that Wayne Kornblatt showed you. I'm here to distract you. And so again, we thought we were smart. We thought we had our diagnosis. But then when we realized that that was just pharmacologic, it really kind of clued us in that this was coming Miller-Fisher syndrome. So I just wanted to share some slides about Miller-Fisher syndrome. Miller-Fisher makes up about 1 to 5% of Guillain-Barré. The classic triad that we see is ophthalmoplegia, areflux, and ataxia. It affects males slightly more than females, and that biomarker is the GQ1B antibody present in 80 to 95% to help clinch the diagnosis. In terms of initial symptoms, it's double vision as the predominant symptom, which is why we see them as ophthalmologists and neuro-ophthalmologists. They might have gait disturbance and ataxia in 20 to 56%, and paresthesias in 20 to 50%. In terms of the neurologic signs, ophthalmoplegia, especially abduction deficits, is what you're going to want to look for. You can look for ataxia. In about 30%, it can be severe, but sometimes it can be very subtle. In our patient, and they didn't have any at all. Areflexia, again, part of the triad, but up to 31% of patients can have normal reflexes. And this mydriasis is interesting. 37 to 42% of Miller-Fisher syndrome patients have the mydriasis. And the differential diagnosis of diplopia and mydriasis is actually quite small. So when you have that patient, you want to have Miller-Fisher quite high on a differential diagnosis. They might have dystosis, dysphagia, facial weakness. And in terms of the pathophysiology, the vast majority of these are post-infectious, typically URI more than gastrointestinal. And it's thought to be molecular mimicry in terms of how this happens. There's lipopolysaccharides on the outer membranes of bacteria similar to GQ1b. And the immune response creates these antibodies that target GQ1b, which is this ganglioside involved in plasma membrane and signal transduction. And that's what leads to the double vision and other symptoms. The good part is the majority of patients spontaneously resolve in over 3 to 6 months. Ataxia resolves before the ophthalmoplegia. It's very rare to have recurrences. And occasionally, sometimes it can start with kind of Miller-Fisher syndrome on the face and then spread to more systemic Guillain-Barré. Treatment is observation, IVIG, or plasma exchange in very severe cases. And so for our patient, we gave them some Fresnel Prism 18 base out. And then we later found that the patient confirmed our diagnosis of GQ1b. He had no improvement, so we did give him IVIG to help try and quicken the recovery. The mydriasis resolved 3 to 4 days later, the palm tingling a week later, and then over 6 months, the diplopia completely resolved. And again, here's really kind of that differential diagnosis you want to think about in terms of diplopia and bilateral dilated pupils. It's a pretty small differential diagnosis. And so again, it's just a helpful thing to look for. Since I saw this case, now every single time a patient comes in with any kind of ophthalmoplegia and dilated pupils, I always say Miller-Fisher, and 9 out of 10 times that's the diagnosis. Botulism, tic paralysis, those are pretty rare. Bilateral third nerve palsy, it's going to be pretty clear that that's bilateral third nerve palsy as opposed to this Miller-Fisher, which tends to be much more symmetric in terms of how involved the pupils. So I thought this was just a nice, interesting case with some good teaching points, and just wanted to share it with the group.
Thank you. Thanks, John. Very interesting case. And I think, as you highlighted in the last slide, we have very limited differential diagnosis when we have bilateral ophthalmoplegia along with mydriasis, and suggesting a couple of other interesting points that I felt was like when you told that, at the time that when dilute pilocarpine did not work, but the 1% pilocarpine was positive, suggesting that there is a neurologic cause, suggesting that we should go further and do further workup. And how often do you come across other etiologies like botulinum and tic paralysis in your experience? There must be some antecedent history in them too.
We occasionally see them. It's incredibly rare. For botulism in the Midwest, people like to bottle their own fruit sometimes, and then that's how occasionally it can happen, but very rare. Tick-borne illness, again, we're in the Midwest where there is a little bit more tick-borne illnesses, so occasionally we see them. But again, like I said, when I see the dilated pupils in ophthalmoplegia, 9 out of 10 times it's going to be Miller-Fisher. So that should be at the very top of the list.
Thank you. And maybe I missed it. Did the patient have a history of antecedent, any viral illness or anything that you could...
He didn't really, we asked about it later, and we assumed he would have something, but he actually didn't. So we didn't have that to kind of help us. So yeah, initially we didn't think much about it at all. I just thought it was the diet pill and just broken down, decompensated floria.
Yes. In your experience with the Miller-Fisher syndrome, do you always usually see that it's bilateral and symmetric, or do you come across asymmetric presentations?
The pupil involvement tends to be bilateral symmetric. The ophthalmoplegia can do anything at once. Again, abduction deficits over other ones, but really can do anything at once. And on the chat, someone had asked, could Miller-Fisher just present with pupillary dilation? And yes, it's been described as well. As Dr. Schwaz said, it has been described where it's just pupillary mydriasis, no other findings as well. But it tends to be very symmetric. It tends to involve light and near, but sometimes it can be just light and spare the near. So it could be different there.
Thank you. I think one more clue that did come up in the findings was that the deep tendon reflexes were reduced. So it may not be complete reflexia, but at the same time, they could be reduced reflexes. Possibly that is also there.
Yeah, it's part of the triad. Again, it's something that we should look for. Again, when it's mild, like a -1, I think it's sometimes hard for us to gauge, but it's something we always check for. But it can be helpful when it's there.
Thank you. We did have an outbreak of GBS last year, and we did see a few cases like that in India. Multiple centers reported, but I remember seeing a couple of cases with ophthalmoparesis, but no pupillary involvement. But it was the areflexia at that time. Any of the other panel would like to share their experience about multiple Fisher syndrome? Sorry, Miller-Fisher syndrome. Dr. Ramesh, you are there? You have few cases. Okay, maybe he's not there. Any other questions? There is an interesting comment. Luciano says that Mariana presented last year with meiosis, both eyes, and NTGQ1B positive in the last case festival.
Absolutely. It's interesting. It can cause meiosis. It tends to cause ptosis if it's going to involve the lids, but this patient actually had a little bit of lid retraction. And I looked it up, and apparently rarely it can cause lid retraction as well. So that was an interesting finding there. Another comment on the chat in terms of CSF, oftentimes they'll have obulin cytologic dissociation elevated protein. So that's another clue you can do, especially if the GQ1B is negative. But yeah, it could cause some really interesting pupillary findings.
Yes, thank you. I think since these cases are uncommon, possibly worldwide multicentric data collection would help us compile much more information about this disease. This is possibly one way we could get more robust literature about this. This is just my thought I thought of sharing. Thank you, John, for a very interesting case. As I don't see any other comments, we will move ahead with the next case. Thank you. Next will be by Dr. Lulu Bustin, and she'll be presenting a case of Act 2 Beyond the Cellar. And it will be moderated by my colleague, Vivek.
Okay, perfect. Thank you for having me back at the Case Festival. Tough act to follow some of the big giants in the field and some great cases. So I'm going to present the case of a 54-year-old woman who presented for her first ever eye exam in her life. She says for the last year, she has noticed some blurred vision, and it's gotten a lot worse over the last 6 weeks, where she's now having some difficulty reading. She sees her optometrist, who does a visual field test that shows a left homonymous hemianopia, and she gets referred to neuro-ophthalmology. So on exam, her visual acuity is 20/25 in the right, 20/40 in the left. She has slightly reduced color vision in both eyes. There's a left RAPD, extraocular movements are full, and she is orthophoric. Optic discs at this point are pink and healthy looking. She has her visual field test here, and you can see she's got this incomplete, incongruous left homonymous hemianopia. So she has an MRI, and this shows a pretty classic looking snowman-shaped suprasellar lesion consistent with a pituitary macroadenoma. So she goes to see endocrinology. They do some blood work. Prolactin is minimally elevated. They feel like this is likely due to stalk compression, but she does have elevated IGF, suggestive of growth hormone overproduction. So the plan is for surgical resection. She's referred to neurosurgery, and then they send her off to endocrinology for planning the endoscopic approach. While she's in that clinic, she says, you know what, my vision's actually gotten a lot worse recently. Thankfully, they're just down the hall, and so he sends her right back to my clinic. So at that time, her vision is count fingers in the right, 20/60 in the left, can't do color vision testing in the right, and it's completely gone in the left. Now there's no longer an RAPD, eye movements are still full, her optic nerves at this time still look okay. So she goes through her surgery. Unfortunately, it is complicated by suprasellar bleed, and she has to go back to the OR later that night for clot evacuation. She gets discharged home, but then is rapidly readmitted for repair of a CSF leak 1 week post-op. And then 2 weeks after that, she is readmitted with meningitis, and she has to have yet another surgery to repair ongoing CSF leak. A few weeks after that, her visual acuity thankfully has recovered quite nicely, 20/40 in the right, 20/30 in the left. There's now a right RAPD, and unfortunately at this point, both optic discs are pale. Her pathology is consistent with this PIT1 lineage adenoma with a high Ki67 index of 10%. The staining is positive for growth hormone, prolactin, and TSH, and all of these are driven by the PIT1 transcription factor. So her final diagnosis is that of a plurihormonal PIT1 positive adenoma, which was previously known as the silent subtype 3. And we know that this is a more aggressive type of pituitary adenoma. So here's just a sample slide from her pathology. In the inset, you can see this is normal pituitary, and her tumor is filling the rest of the screen. And you can see that it's pleomorphic and disorganized. This is the stain showing the Ki67, and you can see there's really quite a lot of staining, greater than 10%. And in most of our typical benign pituitary macroadenomas, it's less than 5 or even less than 3%. So I follow her along. She comes back for her 1 year post-op visit, 20/25 in the right, 20/30 in the left, still has a right RAPD. She's got optic disc pallor, and she's got this persistent left monomus hemianopia. 9 months later, she calls in saying, I have just developed severe right eye pain, right ptosis, and diplopia. Vision's dropped a little bit. Discs are still pale. She's got a complete right ophthalmoplegia and mild right V1, V2 numbness. So now she has a right cavernous sinus syndrome affecting cranial nerves 2, 3, 4, 5, and 6. She has a repeat MRI, which shows recurrence of the tumor in the right cavernous sinus. So she has repeat surgery to debulk the right cavernous sinus. Thankfully, her diplopia resolves. Repeat pathology is similar, so she's got the same PIT1 lineage adenoma. MRI looks good, no residual tumor. The optic nerves have been decompressed, and she undergoes radiation 3 months later. So I follow her for the next couple of years. No change in vision. She still runs into objects on her left. MRI show no recurrence. Vision stable. Optic discs are pale. Visual field is stable. And then in February of this year, she calls in again saying, I've got this new onset back pain. She has no change in her vision, but we repeat the MRI, and you can see that she has recurrence of her macroadenoma in the right cavernous sinus. But she also has another lesion here, just medial to the right supraclinoid carotid artery. She has another lesion here in the interhemispheric fissure. On the sagittal view, you can see that she has multiple small nodules, so in the cerebellum here, by the corpus callosum. She also has an MRI of the spine, and we see multiple extramedullary interdural enhancing nodules. So you can see there's one up here at T2, and you can see that it's occupying about 40% of the spinal canal. She's got another one here, T5 to T7, which is really just filling the entire spinal canal. Here's the poor little spinal cord over there. And then she's got another one here at L2 and L3. So to look for further metastases, she has a GA68 dotatate PET CT, which confirms this this avidity in the nodal spinal cord lesions. And we also see a new lesion here in the hip and then one in the humerus. So unfortunately, none of these lesions were really surgically accessible, and she couldn't have an LP because of the location of this particular lesion. So we just went on the assumption that this was metastatic pituitary tumor to the spinal cord, leptomeninges, and bone. So the plan for her was a year of chemotherapy with monthly CAP-TEM therapy, MRI spine and brain every 3 months to assess response. So far the intracranial lesions have been stable and the spinal lesions have reduced in size with some improvement in her symptoms. So I most recently saw her in October. She continues to complain of foggy vision in the right and some periocular paresthesias, but no diplopia. Vision's 20/40, 20/30. There's a right RAPD. She's got a right 6 nerve palsy, and she's got subjective decreased sensation in the right V1 distribution. So I wanted to talk about this case because I see lots and lots of pituitary tumors, but this one, I've never seen one quite like this. So pituitary tumors are common, 10 to 15% of intracranial tumors. If you do an autopsy series, you will find this in about 14% of individuals. If you do neuroimaging, about 22% of individuals. So these are really, really common. However, ones that are actually clinically significant and come to medical attention is about 85 per 100,000. So less than 1% of all of these tumors actually require medical care. Neuroendocrine tumors most often arise from the stomach, the intestines, the pancreas, and not typically the pituitary. But we do know a lot about this type of tumor. We can classify them by their immunohistochemical profile and their transcription factors, which represents their embryological origin. And it's important to do this because different embryological or phenotypes of tumors behave differently in terms of their proliferation and their aggressiveness. So of all these tumors that we see, less than 2% tend to behave in an aggressive manner, and only 0.1% are metastatic pit nets, which we previously called carcinoma. So we can use biomarkers to try and help predict aggressive behavior. So the PIT1 lineage tumors, like what we saw here, is pretty variable. If you have an SF1 tumor or gonadotrophic tumor, those tend to be less aggressive, whereas the TPIT or corticotrophic tumors are more aggressive. And the multilineage tumors, which have poor hormonal differentiation, tend to have more atypical features and resistance to treatment. So metastatic pit net most commonly happens in ACTH or corticotrophic tumors rather than what we had with the PIT1 tumor. Transformation from your standard pituitary macroadenoma to a metastatic disease tends to take some time, 5 to 6 years. One of the clues is if you're regularly testing their hormonal biomarkers and they have increasing overproduction but no visible growth on neuroimaging, you should probably be looking out for metastasis. And they tend to occur mostly in the CNS, liver, and skeleton. If you're suspecting metastases, you can use dotatate PET-CT, which tends to be very good for finding prolactinomas, or FDG-PET, which is better for poorly differentiated tumors. Treatment is with surgery, radiation, hormonal therapy, or chemotherapy. So in our case, we used CAP-TEM. Other people have tried bevacizumab or immune checkpoint inhibitors. And something that's a bit more recent, a bit more exciting is immune therapy with peptide receptor radionuclide therapy. So this has been used in other neuroendocrine tumors, but so far I was only able to find 6 case reports of its use in a pituitary neuroendocrine metastatic tumor. So key points, while pituitary tumors are common, metastatic pituitary tumors are rare. And this is something that we need to think about when the tumors behave in such an aggressive manner. So our patient had all of these clues. It came back quickly. It came back severely. And so these patients really need close and long-term follow-up. She also had a very high Ki-67 index. As I indicated, anything greater than 3% is a bit suspicious, and she had greater than 10%. She also presented with site-specific symptoms. So thankfully, both of our diagnostic and treatment options are increasing, so we should be able to do a better job of caring for these patients. So things that I wanted to bring up to the panel. So if you, as a neuro-ophthalmologist, do you follow these patients? We're often involved in the diagnosis of these pituitary tumors. But how often do you follow them? How long? So if they've had surgery, do you follow them for 5 years, 10 years, forever? How often should we be repeating imaging? In this case, especially considering her aggressive behavior, should we have been imaging her more often than once a year? Should I have been seeing her more often? Would we have caught this earlier? So what is your routine practice?
Yeah, so thank you so much, Dr. Lulu Bustin, for bringing a very interesting case, and it's been, like quite long follow-up. So I think that itself suggests, I think our follow-up protocol should be not just immediate post-op, but it should be, even beyond the 5 years. So I think in my practice, if you ask me, once we refer this patient to the neurosurgical team, then once they do a resection of tumor, then I do follow them immediately, the first post-surgery field test, eye evaluation in 3 months. And then later on, every 6 months for almost 2 years, and then probably every 1 year. But this particular case, I was discussing with my neurosurgeon where he was not able to join, but he had given me some inputs in terms of, what we have seen in this particular case, where it has shown a recurrence or some telltale signs of, the aggressive nature, and then ultimately it ended up with kind of, the pit net, which is extremely rare phenomenon. So I was just out of discussion with him, the aggressive nature is not that uncommon, that they do see very often, like maybe, 7 to 8 patient probably in 100 patient, but net pit or a endocrinological, the metastatic component is extremely rare. Although as a part of routine practice, when they do resect these tumors, they do a histopathological examination, and there, as you have very rightly highlighted, like involvement of cavernous sinus, then first or second recurrence, probably they are the indicators where we should think and look carefully for, the metastatic possibilities in terms of repeat histopathology of, the second or third resection, and even advising for PET scan. So yes, I think they should be followed for, I would say with this particular case, lifelong, if not every year MRI, but eye examination and field testing, they should be done even beyond 5 years.
Yeah, I mean, it's tough because pituitary tumors are so common. And as you pointed out, having some aggressive behavior, so invasion of the cavernous sinus or recurrence or growth, it's also fairly common. And if I follow every single pituitary tumor every 3 to 6 months forever, I'm not going to be able to see anything other than pituitary tumors. So how do I decide who I'm going to follow a bit more closely? And how often do I do that? And how much do I push for repeat imaging for forever? So
yeah, I think
should I have done radiation right after? Should I have recommended radiation the first time when we saw that high Ki-67 index?
Yeah, I think this point, I think for those who are, the aggressive tumors, I think there is no harm in following them of every year, because they would turn down the line even after a decade, into the kind of pit net, right? So in that context, I think for all aggressive tumor, we should be considering following them up on a regular basis. However, as you said, like if they have the tendency and histologically proven, probably they would want to follow even as early as every 3 months or 6 months to just pick it up, the metastasis to the other body organs, because if they're originating from the pituitary itself, then we must follow them to pick them up the metastasis in the other organs.
I think, Dr. Besson, these are very interesting and important questions. Most of the time, what we do observe, this is my experience both in India and when I was doing fellowship in USA also, that after the initial resection, the follow-up does happen between neuro-ophthalmology and endocrinology more often than with the neurosurgery. So predictors of high-grade malignancy are more important things that you brought in. We do follow up the patients initially 3 monthly for a couple of times and then make it 6 monthly, and then over a period of time make it an yearly if everything is going on well. But the patients are explained to come back earlier if there is any change in vision, any new onset diplopia or new onset field effect, keeping in view that one of these systems are likely to get affected. But all these are very important questions. Our neurosurgeons do refer the patients for a radiation if there is an incomplete resection and if the patient was there was significant cavernous sinus disease which was left inside. And third thing is that if the might it was a grade 3 or 4 tumor. So these are some of the things in the world where we have the best facilities available. Histopathology and correlation with that is the standard of care that we have to provide. And thanks for bringing in these very important questions. Uh, Dr. Ambika has put in a couple of questions which would benefit, I think, all the audience. She asks, so when we see atypical bad histopathology in pituitary, we should suspect MEN. Uh, should we send for PET scan at the same time? And did the patient have any other tumors? Because P53 usually has multiple tumors that might develop.
Yeah, I mean, those are good questions. So she didn't get a PET until she presented with her metastatic disease. So have some of these lesions been brewing for longer than we thought? And as I said, I admitted we did not get any pathology of the metastatic deposits because they were challenging and it wasn't felt to change what we did. I have a wonderful endocrinologist, so she did get a pretty thorough working over initially, but despite the high-grade pathology, the neurosurgeon was so confident, yeah, I got it all. The post-op MRI looked great. She's already been through so much with her CSF repair that we didn't really do anything further initially, and maybe I regret that. Maybe we should have looked a little harder the first time based on that pathology. The trouble is these cases come around so infrequently that maybe I've learned a lot from this case, but when am I going to get to apply this knowledge the next time around? So as far as we know, she didn't have any other tumors initially, but to be fair, we didn't look until this year. And I didn't show you all, I mean, she did come back a lot. My initial version of the presentation had about 57 slides with all of her follow-ups, and I cut most of them out.
Thank you. Wonderful case again. Anybody would like to add anything? Any
Dr.
other
VS,
inputs?
I was just wanted to add 2 points here. When I was
Yes.
going through this presentation, very interesting. So usually what happens, we see these cellular tumors with bitemporal hemianopia. So this particular patient had, the homonymous hemianopia. So either I was thinking it could be, it's kind of, the prefixed chiasma, or probably the lesion might be extending posteriorly and causing compression on the optic radiation, but we don't see very often the presentation like this, number one. Number two, at baseline, many tumor who are like larger size, at baseline they have the invasion in the cavernous sinus and encasing the internal carotid. So these are the group of patients where the ENT as well as the neurosurgeons, they do take care of both the component. Like neurosurgeon do the open surgery and ENT surgeon, they try to take out as much as possible. So at the end of day, what I learned from the neurosurgeon, that most of the patient when they do have a residual or the recurrence, then they do a radiotherapy irrespective of grade of the tumor. So that's their common practice. Now through this case, what are the indicators where they are like aggressive or probably they would turn out to be cancerous? There we need to be careful, and that's how this case brings I think we should be vigilant about other complaints also. Like this patient came up with new onset back pain and other brain lesions on follow-up MRI. They are the indicators where we should be really looking for this. Thank you.
Thanks, Vivek. Great observations. Thank you, Dr. Bastian again. And we'll move on to the last, but another very interesting case with Dr. Padmaja Sudhakar. She will be presenting the last case. We heard of a lot of red herrings, and she has a zebra. Over to you, Dr. Sudhakar, and Dr. Seema Biswas will be moderating the case.
Are you able to see my slides? I'll change to presenter mode now.
Yes.
All right. Okay, thank you so much. Again, it's a pleasure to be part of this festival. And I'm going to present this case where the zebra was mistaken as a horse with stripes. I am from Kentucky, so that's why special interest in the horses. So my case is a 55-year-old gentleman. He came to neuro-ophthalmology with bilateral severe ptosis and ophthalmoplegia. And he mentioned that it had affected both the eyes. There was diplopia in the beginning, but this has subsequently resolved. So his symptoms started as early as 8th grade, where he said the ptosis was interfering with his ability to read. He could not run, climb stairs since he was a child. He had frequent falls. He had some trouble with speech and pronunciation. So he got speech therapy in school, but he had no trouble chewing and swallowing. When he was in his 20s, he could not get up from a chair, or he could not walk up the stairs without difficulty. In his 30s, he had whole body jerks and muscle cramping, but no seizures. He also had some shortness of breath with exertion, and apnea and sleep with persistent fatigue. Over time, his ptosis and his weakness worsened. And then when he was an adult, he noticed some blurred vision and distorted images. He would say things look slanted. There was no night blindness. Past history was significant for hypertension, hyperlipidemia, and former smoking. And there was a distant niece, a grand niece, who had some ophthalmoplegia when she was 11, and his mother had died of lung cancer. So this is the workup which the patient already had acetylcholine receptor antibodies, which were tested, and it was negative. Other labs like inflammatory markers, CK, folate, B12, ANA was normal. Somebody had attempted a tensilon years ago, and he said the results were equivocal. He had gotten an MRI brain and orbit with contrast, which did not show any significant findings. And like it was unclear if he had ever had the EMG nerve conduction study. For years, he had been committed to pyridostigmine. He said that it was not particularly helpful, but he continued to take it. He had been tried on steroids and IVIG without much benefit. They had also done a bilateral ptosis surgery around age 27. We did not have much details, and this surgery did not help. So on the neuro-ophthalmology exam, he had about 20/40 in the right eye and 20/25 in the left eye, with slightly decreased color vision, no stereopsis, bilateral moderate ptosis with very poor levator action and frontalis overaction. But I could not appreciate any fatigable ptosis. He had bilateral complete ophthalmoplegia, and so orthophoria and primary gaze, anterior segment and fundus were unremarkable. These are the visual fields. Obviously, you see that the superior field is depressed from his bilateral ptosis. The OCT RNFL was fairly unremarkable. On neurology exam, he had very poor orbicularis oculi and oris strength. Other cranial nerves were okay. He had proximal muscle weakness in both arms and legs, slightly weak neck flexion, and weak abdominal muscles. He had mildly reduced pinprick in the dorsum of toes and fingers, preserve reflexes, mute plantar, no dysmetria on finger to nose. And then with his gait, he was unable to get up from a chair unassisted. Romberg was negative. He had a slightly wide-based gait, but no swaying. He could not tandem, but he could stand on his heels and toes. So here we have a gentleman with the complete bilateral external ophthalmoplegia, bilateral ptosis, proximal muscle weakness. So when I looked at it and he said this is going on from 8th grade, my obvious thought was, is this a hereditary mitochondrial myopathy? Is this CPO with the, other muscles which have been involved? And then we also wanted to test him for sleep apnea. So we did some additional workup. We repeated the acetylcholine receptor antibodies, MuSK, thyroid stimulating antibody, TPO, CK lactate, aldolase, paraneoplastic antibody panel. Everything was negative. Home sleep study was negative for sleep apnea. And then we did the modified barium swallow, which showed no aspiration. And he did pulmonary function test. That was also fairly unremarkable. Then we went on to do the EMG REP-STIM. This was what caught our attention. So there was a post-synaptic neuromuscular junction disorder with a chronic right C6 radiculopathy, which was only a distractor in this case. And we went on to do a genetic test, and this showed a pathogenic mutation in the ChRNE gene E553 DEL7 mutation. So this is consistent with autosomal recessive congenital myasthenic syndrome. Then we subsequently went on to do CT chest and EKG, and this was all right. So here we are dealing with a patient of congenital myasthenia gravis. These are rare inherited neuromuscular disorders caused by a pathogenic variant in the gene that codes for different proteins expressed at the neuromuscular junction. This can be autosomal dominant or recessive. It can start at birth, early childhood, late childhood, or early adulthood. The clinical features would be that there would be skeletal muscle showing fatigable weakness, so it can affect the ocular, bulbar, limb, and respiratory muscles in different patterns and different degrees of severity. Cardiac and smooth muscles are not involved, and the cognition is generally good. If it's an infant, you're going to have symptoms like weak cry, suck, respiratory trouble, feeding difficulties, stridor, and they can even go on to sudden infant death. If it comes later in childhood, they're going to be delayed motor milestones, fatigable muscle weakness with fluctuating ptosis, and then difficulty in doing things which a child likes to do, run, climb, and jump. The most common genes are those which code for the acetylcholine receptor subunits. So they are going to produce an acetylcholine receptor deficiency, or the acetylcholine, sorry. The acetylcholine receptor deficiency or acetylcholine receptor abnormal kinetic function. And there are various of these genes, ChRNE, which is what our patient had, ChRNB1, RND, CHENA1, ChRNG. These make up 50% of cases, but there are a variety of other genes which may code for proteins involved in the end plate development. Some cause end plate acetylcholinesterase deficiency, and some cause presynaptic acetylcholine.
You're not on slideshow.
Yeah,
You're
sorry.
not on slideshow. And it's, I think, the first slide that is displaying for us.
All right. I'm so sorry. I don't know why this happened.
Yeah, you were on the discussion and it suddenly changed. Yeah, now you're on the correct.
Okay, all right. So there are a variety of genes, as I was describing. 50% of cases are the genes which code for the acetylcholine receptor subunit, and they cause the acetylcholine receptor deficiency or the abnormal kinetic function. But there are other genes which code for the end plate, and there are genes which code for the end plate acetylcholinesterase deficiency, and there are genes which code for presynaptic congenital myasthenic syndromes. So then there's slow channel and fast channel congenital myasthenic syndrome. The slow channel ones start in the first decade. They can have wrist and finger extensor weakness. They spare the ocular muscles, although sometimes you see ptosis. And these kids go on to develop progressive respiratory failure. Interestingly, they don't do well with pyridostigmine or 3,4-diaminopyridine. They may improve with fluoxetine, quinine, quinidine. Fast channel is what my patient had. So this would be a mild to severe phenotype, and they do respond to pyridostigmine and 3,4-diaminopyridine. So when the acetylcholine receptor is the problem, then they can have ptosis, ocular motility issues, and they can have this fixed ophthalmoplegia. So when you see fixed ophthalmoplegia, I think in a previous case they discussed, the differential diagnosis is very limited. And if you see someone with a long-standing problem, you tend to think about mitochondrial problem. But congenital myasthenia can come with fixed ophthalmoplegia. They can have mild to severe bulbar and limb weakness. And as I already said, they improve with the pyridostigmine and 3,4-diaminopyridine. And then albuterol, interestingly, this is not the inhaled ones, but the oral albuterol also produces a response. So the differential in these cases is seronegative MG, congenital myopathies, and if it's an infant, you're going to think about all causes of floppy infant. And then the diagnosis is not so easy. So you have to look for these typical features. If you repeatedly test the antibodies, which is what all of us did, it's going to come negative. It's not an acetylcholine receptor antibody autoimmune problem. It is a receptor end plate problem. And if you do a muscle biopsy looking for ragged red fibers, that is not going to be present. The key here is the rep stim. So when you do a low rate repetitive nerve stimulation test, you will have a decremental response. And you will have this thing called double response. So with a single nerve stimulation, you're going to have a double decrement. And this is quite typical of the slow channel congenital myasthenic syndrome. If you do a single fiber EMG, you may see a jitter. Remember, they are not going to respond to steroids, IVIG, plasma exchange, none of that. This is not an autoimmune problem. And they have a positive response to the pyridostigmine, the acetylcholinesterase inhibitors, but not always. And then how do you go about testing? You can sometimes start with single gene testing, but sometimes you may have to go for multi-gene or genomic testing. And let me remind you, even in the United States, getting this approval is very hard. So you treat with the acetylcholinesterase inhibitors, and then albuterol and ephedrine are effective in some congenital myasthenic syndrome. Fluoxetine is beneficial if it's a slow channel myopathy. So our patient, we continued him on pyridostigmine. We added oral albuterol. He has done well. There's improvement in the proximal muscle weakness and neck flexion, but not in the ophthalmoplegia. So in conclusion, if you need to consider congenital myasthenic syndrome in the differential diagnosis where a patient comes with complete fixed ophthalmoplegia, and when the clinical picture looks like a myopathy, the muscle biopsy and the EMG may not show features of myopathy. Genetic testing is the key. And then remember that this is one condition where the weakness is actually reversible with treatment. And that's my last slide. I'm happy to take questions.
I think we saved the best for last. Thank you, Dr. Sudhakar. It was a great presentation. I am an EMGer, so from your entire slide, I'm interested in the EMG slide. My question to you is that this patient had presented with symptoms starting from 8th grade, and he had proximal weakness also, and he had some neuropathy symptoms. I guess that was a red herring in his case. So when would you, and he also had a trial of pyridostigmine and perhaps steroids too, and it did not work. When would you say that enough is enough and I'm going to do genetic testing on this patient?
This is a great question. I think, maybe when they had come, maybe in a second or third decade of life, this is not a normal child who can't run, climb. And then from 20s, he's not able to get out of his chair. He needed assistance. I think if we had seen at that stage, we would have offered at least like the neuromuscular panel, which if we are lucky and they allow us to do the genetics, I think we would have. And then supported by this EMG, which clearly showed a postsynaptic neuromuscular junction disorder, which, at that point, I think we should go for the EMG.
So there is this remote history of knees having similar symptoms. And when do you think that you guys tried albuterol and it helped, right? So do you routinely add it to patients who don't respond to pyridostigmine or other medications conventionally used, or would you wait and then say, let's trial albuterol and see if it improves?
Oh, only in the congenital myasthenic. We tried only after we got the genetic diagnosis in this case. Otherwise, like, traditionally albuterol, I don't know. We don't use in our other
Right.
autoimmune myasthenia. But this was like, it was a lesson for me too, because I know it was mentioned, but I have seen a couple of other congenital myasthenia patients, but this was one of the cases where we tried and he responded.
Thank you. I don't have any further questions, but just wanted to point out something on the EMG. So when we do the EMG study, the rep stem that we call, it's done at a low repetitive frequency of 2 to 3 hertz. And when there's a decrement of like by 10% in the compound motor action potential, that's what is called decrement. And most institutes don't do single fiber EMG, and in single fiber EMG, there's increased jitter, which is very pathognomic of most myasthenia gravis patients. Any
Thank
other
you.
questions from other panelists?
Yeah, Dr. Sudhakar, it's a very interesting case. And I think of late we have also been thinking about this in patients typically presenting in the first decade with juvenile myasthenia. We we have picked up a few patients where it was not coming conclusive towards with the serology, or there was no response to pyridostigmine. But as you highlighted all the things, these these patients have this course. A couple of questions are that, so always you are in a dilemma that once the patient is seronegative but has presentation similar to myasthenia, do you give a therapeutic trial or you send it for the genetic testing at that time? So what approach do you take? Second point is that I have read that certain patients may worsen even with pyridostigmine. They might have a worsening response, and it's contraindicated in these congenital myasthenias with a genetic basis. So having said that, would it not be imperative that we get it early before we give a trial of pyridostigmine? What's your thought about it?
So you're saying even before the pyridostigmine to try to get the genetic diagnosis?
If the serology is negative and you do have high suspicion of myasthenia.
Yeah, I think it's reasonable, but you see that we are probably the last set of doctors who see these patients, right? They go
Yes.
through neurologists, they go through other ophthalmologists who, and this applies even to like even simple pseudotumor cases where like they're already put on medication and you're the last
Exactly.
person to see. So at that point, instead of just continuing or like, because this man has been subjected for 30 years to the pyridostigmine.
Yeah.
And so like you can't suddenly stop. But if we had seen like first time, I would have even, I never put anyone on pyridostigmine before I have any diagnosis. So we do as you guys showed in your series of cases, the bilateral complete ophthalmoplegia, has so many differentials. So would be
Yes.
interesting to actually get the diagnosis before we start treating. I would have never put him on if I was the first doctor to see him.
Thank you. Just a one more thought I was having. So, can you highlight a little bit more about the aspect of the double jitter as well as the high channelopathy versus the low?
So in the double responses, like with which Dr. Bishwas just explained, with that rep stim low frequency, this double response comes, which is supposed to be a very specific feature for congenital myasthenia. We don't see that, I think, in the autoimmune myasthenia gravis. And as far as the slow and fast channel, I think it depends on the genetic. So like the slow channel ones are like a different set of genes and the onset is much earlier. But the fast channel is what with the CHRNE and those genes, which are a little bit more like coming within our spectrum because they have the ocular features, especially the fixed ophthalmoplegia.
Thank
Whereas
you.
the slow channel, like they spare the ocular muscles.
That's interesting. So if we are seeing the ocular muscle involvement, it's more likely to be CHRNE gene as well as the fast channel myopathy.
Yes. And then they're saying that the 50% of the myasthenic cases are where the CHRNE and all those various genes that I listed. Hard to even remember all those alphabets, but
Yes.
that 50% of cases come in that spectrum.
Yes, exactly. Even from there's a study from India which also describes CHRNE as the first, and this has been our experience with the thing. But I think we had one patient with Rapsin. So there again, a disease where multicentric studies would help because it's a rare disease.
Did you say Rapsin?
Yes.
Oh, okay.
RPSN.
Yeah.
Thank you. Thank you very much. Wonderful case again. Over to Dr. Satya for all the concluding remarks. You need to unmute, Dr. Satya.
Yes. Thank you, Virender. So as we come to the close of the 5th Global Neuro-Ophthalmology Case Festival, it is both an honor and a joy to extend heartfelt gratitude to everyone who made these 2 days such a memorable and meaningful success, and to our distinguished faculty who generously shared their rare and thought-provoking cases. Thank you for your time, effort, and dedication. Each presentation has added new dimensions to our understanding of neuro-ophthalmology, reminding us why this field continues to captivate and challenge us year after year. A special word of appreciation goes to our moderators, panelists, and discussants whose thoughtful insights and lively interactions transformed this event into an engaging learning experience. Your enthusiasm and expertise remain the driving force behind the spirit of this festival. We also extend our grateful thanks to our global audience joining from different time zones. Your comments, questions, and energy kept the discussions vibrant and reaffirmed the strength of our worldwide neuro-ophthalmology community. A heartfelt thank you to Sunil ji, our ever-dependable webmaster, whose seamless technical coordination continues to make these complex online events feel effortless. Your behind-the-scenes dedication keeps everything running with precision. We also deeply appreciate our partners at Entod Pharmaceuticals for their continued support and commitment to educational excellence. Your contribution has once again made this global exchange possible. As we wrap up this year's festival amid the festive and wedding season, and with a brand new year just round the corner, we wish everyone moments of celebration, renewal, and inspiration. May the coming year bring continued curiosity, collaboration, and clinical brilliance to us all. Thank you once again for your presence and participation. Until we meet again, stay inspired, stay connected, and have a wonderful evening.
Thank you.
Thank you.
Thank you, everyone.
Thank you.
Thank you.
Thank you, everyone. It was wonderful to join you all online and wonderful cases.
Thank you.
Thank you.
Thank you.
It's a great opportunity to connect with colleagues from around the world. So thank you so much for organizing this.
Thank you.
See you next year. Bye.
Hopefully in person.
Absolutely. Keep well and safe. Bye-bye.
Bye. Thank you, Sunil.
Bye, Dr. Satya.
Bye, Virender.
Thank you, Sunilji. Bye.
Thank you. Thank you. Thank you, Satya. God bless. See you.
Thanks, Krishna.
Thank you. Bye-bye.
Thank you, Hedi, Swati, Paromita. Bye. Sunil, we can end this session.
सत्य कृष्णा ने शायद बोला। क्या देख रहे हो तुम लोग मेरे बिना?